use the SP142 assay, and then before analyzing the data, they use the SP263. All patients received adjuvant chemotherapy from 1 to 4 cycles, and then they were randomized to Atezulusumab versus best supportive care. How they analyze their statistical analysis based on hierarchical statistical testing. So they will check the DFS in the PD-L1 positive in stage 2 to 3A, and then if this is positive, they move to the DFS in all randomized stage 2 to 3A. And then if this is positive, they go to the DFS in the ITT, including the stage 1B. And then if this is positive, then they will analyze the overall survival in the ITT population. When we look at the baseline characteristics, so 2/3 of the patient had a non-squamous histology, 12% stage 1B, 40% stage 3A, and PD-L1 positive in around 54%. When we look at the result, so the DFS in PD-L1 positive stage 2 to 3A population, it was a positive with a hazard ratio of 0.66. When we look at the DFS in all randomized group, the hazard ratio dropped to 0.79. And when we look at the DFS, including patients with stage 1B, hazard ratio actually dropped to 0.81. When we look at the DFS in subgroup of the PD-L1 positive, we see that current smoker, there's a question mark if they gain benefit because the hazard ratio was 1.24. When we look at the ALK also, there is clear that they did not get benefit from using immunotherapy with a hazard ratio of 1.05. When we look at the DFS in all randomized group, and when we look at the PD-L1 status, as you can see here, for the TC more than or equal to 50, hazard ratio was significant, 0.43, and I will come to this later. Then here, actually, we had a more update in the ESMO from the Empower 010, and they looked at the group who is negative, and then 1 to 49, and then more than or equal to 50. And it's very clear that majority of the benefit is driven from the TC more than or equal to 50% with hazard ratio of 0.43. The disease negative group was a hazard ratio was 0.97. And the group from low positive 1 to 49, the hazard ratio was 0.87. When we look at the incidence and patterns of disease relapse in the positive PD-L1, so the relapses were more in the best supportive care, 44 versus 22%. In the Atezulusumab group, it was more loco-regional than distant metastases, and the opposite in the best supportive care. Overall survival data is still very immature, and we need to wait for more data. Safety profile for Atezulusumab is similar to what we learned from previous study. Even the toxicity is, nothing was actually different. So in October 2021, FDA approves Atezulusumab as an adjuvant treatment for non-small cell lung cancer. Moving to PEARLS, or the Keynote 091. So it was presented by Dr. Bazares in the ESMO virtual plenary session in March. And in this trial, the eligibility for registration was confirmed stage 1B to 3A, completely surgical resection with negative margin R0. And they had a testing for PD-L1. And then PD-L1 testing, they used the 22C3. And at the eligibility for randomization, they made sure that the patient has no evidence of disease. And then, of course, excellent performance status. For the adjuvant therapy, they considered for stage 1B, and it was strongly recommended for stage 2 to 3A. And they randomized patient to pembrolizumab versus placebo. They had a dual primary endpoints, the DFS in the overall population and DFS in the PD-L1 TPS more than or equal to 50. So they screened or registered 1,900 patients. They randomized 1,177, Pembro versus placebo. The median follow-up is 35.6 months. When we look at the reasons for discontinuation in the pembrolizumab was adverse event, And when we look at the placebo, majority of the cases, they discontinued treatment because of disease progression. When we look at the baseline characteristics, so non-squamous carcinoma was 2/3, stage 1B is 14%, stage 2 is around 57%, and 3 is around 30%. For the current smoker, they were in the around 85 to 88%. And for receiving adjuvant therapy, 14% of the population did not receive adjuvant chemotherapy. When we look at the PD-L1 status, around 40%, they were PD-L1 negative. So the DFS for the overall population, hazard ratio is 0.76 with a very positive or strong p-value of 0.0014. When we look at the DFS PD-L1 in the PD-L1 positive more than or equal to 50, hazard ratio is 0.82. It was not statistically significant. The p-value is 0.14. When we look at the subgroup analysis, so it seems that majority actually benefit was in the pembrolizumab arm, but when we look in depth, you can see actually the group who did not receive adjuvant chemotherapy, they crossed the line with a hazard ratio of 1.25. And for the group who actually squamous cell carcinoma, also they crossed the line with a hazard ratio of 1. And interestingly, when we look at the EGFR mutation, for the EGFR mutation positive, their hazard ratio was 0.44. So they got benefit from receiving pembrolizumab. When we look at the overall survival in the overall population, hazard ratio is 0.87. Again, not significant, p-value 0.17. Data is still immature. When we look at the treatment led to death in the pembrolizumab arm is 0.7%. And when we look at the toxicity profile is quite similar to what we know from previous data from the pembrolizumab. So in conclusion, pembrolizumab provided a statistically significant, clinically meaningful DFS improvement versus placebo in the overall population. Median DFS of 53.6 months with pembrolizumab versus 42 months with placebo, and hazard ratio 0.76. Generally consistent DFS benefit in participants with negative PD-L1, low positive, and positive. OS data are immature, and the DFS in the PD-L1 defined population and overall survival will be tested at future analysis according to the analysis plan. Pembrolizumab safety profile as expected, and data suggests pembrolizumab has the potential to be a new adjuvant treatment option for patients with stage 1B to 3A non-small cell lung cancer following complete resection and adjuvant chemotherapy when recommended, regardless of PD-L1 expression. So let's look at the two trials. We have to keep in mind that both trials use the AJCC version 7 in their staging. And also when we compare trials together, so the control arm in the IMPOWER was best supportive care versus placebo in the PEARLS. When we look at the PD-L1 status or the PD-L1 testing, they use different testing. When we look at the adjuvant chemotherapy, IMPOWER 010 received adjuvant, PEARLS actually recommended in stage 2 to 3A. So if we look at their outcome, if we look at the DFS stage 2 to 3A in all comers versus DFS in stage 1B to 3A, all comers in PEARLS, actually hazard ratio is quite similar. Hazard ratio of the IMPOWER 010 is 0.79, and for the PEARLS is 0.76. When we look at the PD-L1, there is lots of questions after the PEARLS and the IMPOWER 010 about the importance of PD-L1 expression, because we learned from the IMPOWER 010, the group who actually drove the benefit is the group, the PD-L1 more than 50 with a hazard ratio of 0.43. But actually, we did not see this in the PEARLS data. When we look at the EGFR mutation, in the PEARLS, EGFR positive patient, their hazard ratio is 0.44. The confidence interval is actually wide. It's too early data, so I don't know how to actually comment about the benefit in the EGFR group, especially in this days when we have actually ADAURA or the osimertinib as an option in the adjuvant setting. So we know from the IMPOWER 010, when we looked at all comers, they did not get benefit, and their hazard ratio was 0.99. We need to keep in mind Pearl's trial was done or started in 2015. So at that time, we were not testing for NGS upfront or like in the early stages. So 56% of the mutational status is unknown in the Pearls and 35% is unknown in the IMpower 010. When we look at the adjuvant chemotherapy, so the group who did not get adjuvant chemotherapy did not get benefit. Hazard ratio was 1.25. It's a small group and the data is still immature. What about markers? I don't have the answer for this if circulating tumor DNA will play an important role in future to decide or to approach how to actually treat or choose treatment options, especially that we're getting more and more options with time. But we know from the circulating tumor DNA from the IMpower 010 data that the ctDNA negative group did better than the ctDNA positive group, and both the negative and the positive actually had benefit from receiving Atezulusumab. Now we have a lot of ongoing trials in the new adjuvant, and we have a lot of ongoing trials in the adjuvant setting. So I think in the near future, we'll have more questions about how to sequence and how to select patients for each treatment approach. We have an ongoing also trials for the combination of chemo plus immunotherapy in the neoadjuvant setting, followed by immunotherapy in the adjuvant setting. And this will raise more and more questions. So the conclusion is Atezulusumab is an FDA approved as an adjuvant treatment following resection and platinum-based chemotherapy for adult patients with stage 2 to 3A, whose tumor has a PD-L1 expression more than or equal to 1. Again, we had the same question from Adora, same questions for immunotherapy in the adjuvant setting. We don't know if DFS will translate on overall survival. Pearls raised more question about how PD-L1 going to help us, especially that the PD-L1 positive group did not get benefit. What about the EGFR population? The data from the Pearls actually, I think, confused me personally. And also the role of adjuvant chemotherapy. I think the data is still immature. And I think when we hear more and more about the data, then hopefully this will answer a lot of questions. We have so many ongoing trials, and more and more questions will come with the result of all these trials. And I conclude my presentation with this beautiful picture from Jeddah. Thank you so much.
Thank you so much, Dr. Samah, for this excellent presentation and for sticking to time. And now just we will go for the second presentation by Dr. Ignacio Hilpazzo. He is medical oncologist and the co-director of the medical oncology department in University of Navarra, Spain. Dr. Ignacio will just give us a presentation about dealing with stage 3 lung cancer. Dr. Ignacio, the mic is yours.
Thank you very much. Thank you very much for inviting me. This is a great pleasure to me to be again in this 6th edition of the Immuno-Oncology meeting. So in next following 20 minutes, I will be touching on the role of immunotherapy in the stage 3 non-small cell lung cancer. So these are my disclosures. So I just want you to focus on this number, because this is actually, this 25% is the overall survival for patients with stage 3 unresectable non-small cell lung cancer in the old days, so in the pre-immunotherapy era. We will see how this has changed over time with the new findings of the immunotherapy in this setting. So I will briefly introduce stage 3 non-small cell lung cancer and how the role of chemoradiation therapy has been the standard of care. And then I will follow with the rationale and role of immunotherapy in this specific particular setting and what questions are still to be addressed. But the first thing to mention for me is that stage 3 non-small cell lung cancer is all about teamwork and multidisciplinary work. So in fact, when these patients are treated in a multidisciplinary fashion, This is a favorable independent prognostic factor for the patient, and this is important to bear in mind. So the first question would be, what is exactly a stage 3 disease, and what is exactly, which is more difficult to address, unresectable stage 3 disease. So stage 3 disease is all patients with, of course, N3, N2, T4, and unresectable is probably, again, the same categories here. It is true that some very selected patients with N2 non-multistation involvement, non-bulky lymphadenopathies might still be candidates for surgery, but most patients are not amenable for surgery in this setting. And this is around 25 to 30% of all patients that we see in our clinic with stage 3. So it's a relevant number and prevalence of these patients to manage in the clinic. But most importantly, the expected overall survival in this specific stage 3 disease is really poor, or has been really poor in the pre-immunotherapy era. If we just consider this stage 3 disease in a pooled fashion, we see that 25% that we mentioned at the very beginning is probably the expected overall survival for these patients. But if we focus on stage 3C patients, this is less than 15%. Chemotherapy has shown to add and improve the outcomes that can be achieved with just radiation therapy. This is something really known, and this is in fact a very old paper. And more importantly, concurrent chemoradiation is even better than sequential radiation therapy plus chemotherapy. And this is something that we will mention again when it comes to immunotherapy, because we don't really know the role of immunotherapy in that sequential potential setting. We know it in the concurrent setting. However, when we have tried to address whether next generation immunotherapy such as pemetrexed would add something to this overall survival in this stage 3 setting, we see that the concurrent chemoradiation with either regimen had actually the same outcome. And in fact, if you look at the 3-year-old overall survival, again, we are around 40%, and 5-year overall survival around 25%, as we just mentioned. So in this not very, with good prognosis setting, this is where we actually think of something else that can add to those patients and improve the outcomes significantly. And let's talk about immunotherapy in this particular setting. So immunotherapy has actually revolutionized the treatment of patients with cancer in general, and more particular in non-small cell lung cancer and small cell lung cancer patients. If we look at the lung cancer management in terms of immunotherapy, and if we consider only the last 6 to 7 years, we can see all these different new approvals of combinations or monotherapy treatments over time. This is really a story of success that we can consider for lung cancer patients. And here we have patients with small cell, but also with non-small cell lung cancer benefiting from immunotherapy. We have monotherapy upfront, we have chemo immunotherapy upfront, we have anti-PD-1, anti-PD-L1, anti-PD-1 plus anti-CTLA-4. We have, even as it has been just mentioned in the previous talk, adjuvant treatment after surgery, and more specifically, which is what we are going to be talking about today in this talk, Nivolumab in the stage 3 non-small cell lung cancer after chemo radiation concurrent. So very simply, but very in a very illustrative way, we have to bear in mind that tumor cells normally have very specific neoantigens, which are differential and specific for the tumor cells as compared to the normal tissue. And those antigens or proteins can be recognized by the antigen-presenting cells, such as the dendritic cells. That has been able, or this will enable the confection of a, let's say, portrait of the tumor cell that has to be chased and killed. And when that information is passed on to the cytotoxic T cells, this can activate those T cells, and actually those T cells can look for the tumor cells and kill them. When it comes to radiation therapy, it is also important to remember that that chemoradiation is going to induce a massive killing of tumor cells with a massive release of antigens, neoantigens, which are specific of the tumor cells. And at the same time, PD-L1 is going to be overexpressed due to that chemoradiation combination in the tissue. So that will eventually facilitate the immune activation and the immune response. At the same time, we can consider that radiation therapy may play a critical role also in different phases of the immune modulation. In the lymph node, most specifically, it can also help in the T cell priming and activation. It can actually help also in the T cell trafficking in the bloodstream, but also facilitating the infiltration of the tumor by those T cells. It can actually also facilitate cancer cell recognition and killing. And finally, it may also play a role in immunogenic cell death. And this is the particular setting in which we can conceive the PACIFIC trial. The PACIFIC trial was a phase 3 randomized, double-blind, placebo-controlled, multicenter global study randomizing patients with a stage 3 unresectable non-small cell lung cancer that had not progressed to concurrent, and this is important, concurrent, not sequential, chemoradiation. More than 700 patients were randomized in the first 6 weeks, again, another important part of the clinical trial, in the first 6 weeks to either durvalumab alone every 2 weeks up to 12 months or placebo. The primary endpoints were PFS and OS. Just for you to remember, patients that after ending radiation therapy were still treated with chemotherapy might not be eligible in the setting of the clinical trial. However, patients starting with induction chemotherapy followed by chemoradiation concurrently were included. If we consider the different characteristics of the patients included, it's something which is important because it might have some implications, at least in some parts of the world, such as Europe. PD-L1 status was unknown in more than 1/3 of all patients in both arms. So this is probably due to no tissue available or no test performed. So you probably know that there has been progressively new updates of the median overall survival and PFS over time. I'm going to present here the most updated data, which are the 5-year PFS and OS data. In the PFS curves, you can see that there was a 45% reduction in the risk of progression. We see that durvalumab in this adjuvant setting actually more than tripled the results obtained by placebo. And we see a 33.1% of patients that are progression-free at 5 years. Most importantly, if we look at the overall survival curves, we see that there was a 28% reduction in the risk of death, and most importantly, 5 months, so nearly very close to 4 years median overall survival. This is really something impressive that we have not seen before in this particular stage 3 setting. And again, if we remember the 25% of those patients in the pre-immunotherapy era that were alive 5 years later, this is 43%. So really something unprecedented. But I want you to also make another exercise, which is to see how the curves actually have been separating progressively from the very beginning. And if we see the 12-month overall survival data, we see a benefit, a net benefit of 9% in favor of Nivolumab. In the 24-month overall survival, this goes up to 11%. In the 3-year overall survival data, more than 14%. And if we consider the 48-month and the 60-month, is more than 18%. And it seems to be stable between the 4 and the 5-year overall survival data. So as we see, we have doubled from the first year to the 5th year, the net benefit in comparison with placebo that Nivolumab can actually obtain. This is the subgroup analysis for the PFS. We see that most subgroups actually benefit very equally. And we still have some specific subgroups that we don't really know what is the benefit that can obtain from this approach. These two are the EGFR or the ALK positive patients, in which, of course, this is not pre-planned, so we cannot really tell, but it looks like the benefit is not the same. And again, the PD-L1 expression level might play a role. However, this was not pre-planned, and we cannot make final conclusions either. If we look at the overall survival subgroup analysis, very similarly, most of the subgroups that you can consider benefit equally. But again, we have this remaining question about the actionable mutations, how they might be impacting the benefit of the Nivolumab in this setting, and if PD-L1 expression is really critical or not for those patients to benefit, taking especially into account that this PD-L1 expression is the one prior to the chemoradiation therapy, so at the onset or the diagnostic biopsy. So we know that this PD-L1 might be completely different after the chemoradiation and before the Nivolumab, and this makes it very difficult to make conclusions. There are some other interesting data that have been updated in this 5-year-old that 5-year overall survival paper, but I think one which is important is how the time to the first or the second subsequent therapy has improved over time in the patients receiving Nivolumab. And this is important because sometimes these patients of ours after the chemoradiation completion are very toxic, and they are having not a very good quality of life. You know, the longer these patients remain without a subsequent treatment which is needed, the better they can, rehab and be, showing much better overall quality of life. So we don't want these patients to end our treatment and 3 or 4 or 6 months later restart any treatment because of progression disease. So this is another way to see how there is a clear clinical benefit of patients receiving Nivolumab. And this is just a summary of how things have really changed in this inoperable stage 3 non-small cell lung cancer setting over time, from the 80s in the last century to the 2020 with the Nivolumab adjuvant therapy that we have just mentioned. And in fact, these are the current clinical guidelines of the NCCN, and we see that Nivolumab is category 1 recommendation after definitive concurrent chemoradiation. This is just a clear example of a patient of mine that was diagnosed with adenocarcinoma of the lung with multi-station N2 involvement. The PD-L1 expression was 10%, and the patient, the N2 was actually confirmed by EVUS, and concurrent chemoradiation was prescribed to this patient up to 60 grade. There was a very nice response in the primary tumor as well as in the multi-station N2 involvement. This was 2018. The patient was started Nivolumab in March 2018, completed the 12-month treatment with no grade 2 or greater toxicities. Is an elderly patient, as you can see, and very recently the patient came to a checkup again, and he was maintaining a very good condition and response. So what are the open questions and the potential future directions in order to address those questions? First would be, as we mentioned before, what is the role of immunotherapy after sequential chemoradiotherapy, taking into account that there is a relevant percentage of patients that might not be good candidates for concurrent chemoradiotherapy, frail patients, patients with more number of comorbidities? Well, we don't really know because this has not been addressed in the Pacific trial. Second question would be, as we mentioned again before, do PD-L1 negative tumors actually benefit or not? We should actually run a new clinical trial addressing this in a pre-planned way. What about the oncogenic addicted tumors? Can they benefit from this approach? What about frail patients that might not be candidates for all these treatments? Is there any other regimen that may help them? How can we actually minimize or prevent immune-related adverse events? And what is the addition or the role of adding immunotherapy during the concurrent chemoradiation? So there are several clinical trials trying to address most of these questions. The Pacific trial is just trying to address specifically that combination of Nivolumab with chemotherapy and radiation therapy, followed by Nivolumab adjuvantly. And we will see some of the results very soon, probably. It's going to be interesting to see what happens. In the Pacific 5 study, we see that sequential as well as concurrent chemoradiation therapy is allowed. So we might be able to address also the question on whether Nivolumab is also benefiting patients after sequential therapy. And then we have some other strategies trying to add or use different drugs such as anti-PD-1, Nivolumab, with chemoradiation, followed by Nivolumab plus Ipilimumab or Nivolumab alone versus the standard of care. And then we have the Keynote 799 study with 2 different cohorts, but this is not a randomized treatment or trial, and it's just a phase 2. But we can see that there was a clear benefit of adding immunotherapy to concurrent chemoradiation in terms of the overall response rate that we can see up here, and a nice number of partial and complete responses, and the duration of response is also very nice. However, well, these are the Kaplan-Meier estimates of duration of response, but the price to pay is really high in terms of toxicity. And if you can see here, we have more than 50% grade 3 to grade 5 toxicities. This is probably not really acceptable, and we really have to work hard on reducing this toxicity if we don't want to jeopardize these potential interesting strategies. There are some other more, let's say, innovative strategies, such as this natural killer cell-based adaptive immunotherapy after concurrent chemoradiation therapy. This is just 16 patients treated, and the estimate of 1 year progression-free survival seems to be benefiting patients receiving this natural killer cell-based adaptive immunotherapy with some interesting complete and partial responses. So in conclusion, in the pre-immunotherapy era, the expected 5-year overall survival for stage 3 non-small cell lung cancer patients was around 25%. For unresectable stage 3, concurrent chemoradiation has been the most beneficial and standard approach. Immunotherapy, however, has really revolutionized the standard of care in non-small cell lung cancer, and there is a clear rationale supporting the immunomodulatory effect of radiotherapy in non-small cell lung cancer. In fact, immunotherapy with Nivolumab has become the new standard after concurrent chemoradiation, showing impressive 5-year overall survival. However, some open questions remain open, as I say, and we really have to work on new clinical trial designs to address those questions. Thank you very much.
Thank you. Thank you. Thank you, Dr. Gulbazi, for this very nice and very excellent presentation as usual. Thank you so much. Thank you, Mirvad, Dr. Al-Hamad, and Dr. Murshid, and congratulations for running this very successful meeting for 6 years in a row. This is just a great and amazing achievement. Now it is my honor and pleasure to introduce our next speaker, our guest, Dr. Paul Pike. Dr. Paul is a medical oncologist, and he's a director of the Thoracic Oncology Service at Memorial Sloan Kettering. Dr. Paul will take us through different treatment options for patients who are having stage 4 non-small cell lung cancer and at the same time having a negative PD-L1 level. Dr. Paul, please.
Great. Well, thank you for the invitation to come speak to this, particularly to Dr. Marhous for the invitation a few months ago, and congratulations for this quite successful and interesting meeting focused on immunotherapeutics. So I will take the next 20 minutes to talk about what the potential best treatment options are for PD-L1 negative metastatic non-small cell lung cancer patients. These are, let's see if I can get this to work. My disclosures for reference, nothing particularly relevant with regards to immunotherapy. So by way of overview, there are a few different things that I wanted to touch on because this question of whether or not there's a best option or what the best option is in a PD-L1 negative stage 4 non-small cell lung cancer population, it sort of seems like it's an easy question to answer, but there's a lot of heterogeneity in that population that we have to try to disentangle to answer the question. And to start off with this, I'm going to begin with just a brief review of what the first-line therapy landscape has been since 2000. And the reason why I want to do this is because then it's going to uncover that first part that's important for us to untangle, which is what's the role of histology in all of this? And here I'll review some of the data between squamous and non-squamous results for immunotherapy in the frontline setting. We'll then touch on the importance of targeted therapies in non-small cell lung cancer, because there's not enough time to talk about it in detail. But the idea is that PD-L1 immunohistochemistry is just not enough, that this group of patients is quite heterogeneous. And so we have to take that into consideration. And then I'll talk about some specific cross-trial comparisons for the PD-L1 negative frontline immunotherapy data as far as we can sort of tell. And then I'll end with the question as to whether or not there's a better way that we can analyze the non-comparative data than just a sort of very raw cross-trial comparison. And I'll touch on this thing called matching adjusted indirect comparison analysis that was done a couple of years ago by Balazs Helmus and colleagues, which gets at a little bit more rigorous way at analyzing these frontline data. So overall survival, 20 years in 2 minutes. So the modern era of platinum doublet chemotherapy really, I think, can sort of be pinned at starting around 2002 when Joan Schiller and colleagues had published their New England Journal paper comparing 4 different platinum doublet chemotherapeutic agents. They all performed similarly. There were no differences by overall survival. And at the time, overall survival was reported to be 7 months, which probably reflected standard care in the 90s. In 2008 is when the really modern era, I think, platinum doublet chemo started with Scagliotti's JCO paper of cisgem versus cispemetrexed in a non-inferiority study. And here, there were these minor differences on subset analysis by histology. CISGEM, for example, had a median OS of 10.8 months, favoring squamous. CISPEM favored adenocarcinomas, a little more than 11 months. And that led to that sort of histologic divergence in chemotherapy that we now see. Mark Sosinski and colleagues had tried to push this a little bit further with nab-paclitaxel, newer taxane back in 2012, with a median OS that was not better. It was 10.7 months in the intention to treat population. And then in squamous in particular, we tried to sort of push things in the Squire study by adding Mesothelioma, which, if you'll recall, is a monoclonal antibody against EGFR, coupled to CISGEM. This trial showed a very modest, significant difference in overall survival, 11.5 months, was really not routinely adopted despite FDA approval because of that very modest benefit and the increased toxicity that was seen. And that leads us up now to sort of the modern era of frontline immunotherapeutics in this disease. Carboplatin plus a taxane plus pembrolizumab. This is the squamous study with a median OS of 14 to 15.9 months, depending on what sort of cut point that you take a look at. And the question is, okay, it's been something like 10 to 20 years. Is this difference in median overall survival from 10.8 months to 15.9 months, is that really great or is it not that great, specifically for squamous cell lung cancer patients? And to get at this, you can create a line like I did here, which charts the seminal trials over time. The length of the line corresponds to a median overall survival of 14 to 15.9 months. If you put the lung adenocarcinoma line underneath that, which also shows some seminal trials that overlap over time, you can see that those results aren't that great for squamous lung cancer patients, that there's actually a fairly large divergence in median overall survival in modern times, with a median OS for adenocarcinoma patients of 22 months, median OS of 14 to 15.9 months in squamous, with essentially identical regimens. The only difference is a single chemotherapeutic, a taxane versus pemetrexed. And as I showed before, that's really invariant with regards to overall survival just with chemo alone in these populations. So the question then is, what's going on here? Why are we seeing these discrepancies? And of course, the short answer is that probably we have to recontextualize our notion of overall survival and efficacy based now on IO responsiveness rather than chemo responsiveness, which rests on these inherent differences in the natural history and biology of the two histologies, which we know about. To some extent, we've done plenty of comprehensive genomic analyses that show these differences in driver oncogenes, for example, signaling pathways, but still don't have a very good handle on how this intersects with immunotherapy sensitivity. And of course, there is this impact of targeted therapy that depends on these differences in biology. Most of the benefit remains in lung adenocarcinoma patients. There are relatively rare drivers that pop up in squamous cell lung cancer. This undoubtedly leads to some of these differences that we see also in overall survival. Speaking to this, of course, NGS testing is now standard of care in all of non-small cell lung cancer patients. This was updated a couple of years ago by the NCCN, where now routine genomic testing is recommended both for adenocarcinomas as well as squamous cell lung cancer patients. This was a change from the preceding 10 years, where there was just a subpopulation of squamous patients where molecular testing was recommended. But of course, the idea is that NGS needs to be done in addition to PD-L1 testing to get at what the best treatment option is going to be for a PD-L1 negative patient. The algorithm, or a version of an algorithm for treatment, can be shown here, which again, forget about the bottom part, basically, that takes care of itself, but you have to do tumor NGS, ctDNA testing, or PD-L1 and PD-L1 immunohistochemistry to get at what the combination of potential drivers are and biomarkers that are present for us to guide a patient into the appropriate targeted therapy or immunotherapeutic, for example. So we're going to now review some of the first-line immunotherapy data through the lens of histology. Again, to get at this question, is there really reproducible difference by histology that we've seen? And I think the short answer is what Dr. Al-Rahali had shown in the adjuvant setting really does hold up also in the metastatic setting. I spoke about Keynote 407 and Keynote 189. You can see by the KM curves for overall survival that the benefit is much bigger for adenocarcinoma patients than for squamous cell lung cancer patients. The granular data I already spoke about. If you take a look at an apples-to-apples comparison now with identical chemo IO regimens, carboplatin with or without Atezulusumab, with Empower 130 and 131, it's very clear that squamous patients also seem to do worse. The study was positive in the lung adenocarcinoma study. These were separate studies done that were histology specific with a hazard ratio of 0.79, which was positive. You can see separation, not that big, but there's still separation in the KM curves. This was not present for IMpower 131, which is the same regimen done in squames, where there is really no separation between the curves, and a median OS hazard ratio that reflects that. So again, identical regimens, better in adenocarcinomas, worse in squamous lung cancer patients. Keynote-024, which of course I'll just touch briefly on because we have another talk about this later on, but the idea of this really great study, median OS is really long compared to chemo. But again, on subset analysis, you can see that squamous patients do worse than non-squamous patients highlighted in that green box in the forest plot. And then for Andy Guerin's update of the 5-year OS data a few years ago now, which was very exciting because we were seeing in a stage 4 population now, 5-year overall survival rate pushing 30% as opposed to 5%, which is what we were used to some 15 years ago. But again, on subset analysis by histology, you can see that almost all of this benefit is driven by the non-squamous population, with a 5-year OS for squamous patients still of just 5.6%. And then finally in Checkmate 227, first-line Ipi-Nivo, again, in terms of PFS, there is comparatively less benefit in squames versus non-squames, highlighted in that green box on the forest plot. And in overall survival, while the hazard ratios seem to be better in squames than in non-squames, this was almost entirely driven by the poor performance of the control arm with chemotherapy in the squamous population with a median OS of 9.2 months. You can see comparatively that the OS for Ipi-Nivo is 14.8 months, which is still pretty bad in comparison to the non-squamous cohort of 19.4 months. So Ben Levy had done a couple of years ago during a discussion of all of these frontline data at ASCO. How do we pick which one is the best? You have all of these updates for these frontline studies. They're complicated. The granular data itself is separated by different PD-L1 cut points. Some of them use different PD-L1 markers. How do we make sense of what the best agent's going to be? I was tasked to try to figure this out for the PD-L1 negative population. And so we're going to talk now a little bit about the specific PD-L1 negative data here. For Keynote-189, in the PD-L1 negative population, the hazard ratio for overall survival was 0.59. And you can see in the forest plot on subset analysis in the green box, for the less than 1% population, that's pretty good, especially when you compare to the 1 to 49% population. It sort of holds up in terms of that hazard ratio for overall survival. For Keynote-407 in squamous lung cancer patients, that's really not the case. The hazard ratio for overall survival is 0.75, just missed significance. This is not as good as the PD-L1 positive population. And so that's kind of the answer for squamous lung cancer patients. Again, the idea is that histology seems to still matter in the era of IO therapy. For Checkmate 227, we do not have granular data on histology crossed with PD-L1 negativity. So all we have is across all histologies that the PD-L1 negative hazard ratio for overall survival is 0.62. What's interesting in this PD-L1 analysis, which was the 2019 update to the TMB analysis in 2018 in the journal, is in the first top green box. You can see in the forest plot that there's really no difference between PD-L1 negative and PD-L1 positive patients. We actually saw this in the initial press release from BMS, which sort of begs the question, if there's no difference with TMB cutoffs and there's no difference with PD-L1, then why are we sort of focusing on PD-L1? And the answer is, I don't really know. One of the more interesting things, or potentially interesting things, that some folks had taken a look at was a deeper dive in PD-L1 and TMB balances. So in the second green box on the bottom, if you have a PD-L1 negative population, but that's TMB high, then the median OS, the hazard ratio seems to be particularly good at 0.51. So some folks, when they think about Ipi-Nivo in a PD-L1 negative population, will take a look at TMB, and if the TMB is high, then they'll give preferentially Ipi-Nivo, for example, based on this subset analysis. Checkmate 90A, which was basically Ipi-Nivo, but with 2 cycles or Taxol at the beginning to try to get over that hump that we see and drop off for immunotherapy. This PD-L1 negative hazard ratio was for overall survival was 0.62. Again, across all histologies, we don't have specific histologic breakdown by PD-L1 expression status. And here you can see it's fairly consistent in the forest plot on the bottom in terms of PD-L1 cutoffs. for Checkmate 9LA at around 0.6 to 0.64 for the hazard ratio for OS. And then finally, for Empower 150, which is lung adenocarcinoma only, so not squamous, the PD-L1 negative hazard ratio for overall survival was 0.77. So not as good as we have seen for, like, for example, Keynote 189 in the PD-L1 negative population. Interestingly, in this study, the improvement in overall survival really did track with PD-L1 expression. So as you got from high expression to low expression based on the TCIC cutoffs, then you really saw a dilution in the magnitude of benefit with Empower 150. The other interesting part of this was this persistent signal in the EGFR ALK positive population, where there seemed to be benefit in overall survival. And so some folks use Empower 150 as a immunotherapy-based regimen after frontline targeted therapy in EGFR ALK positive lung cancer patients. So that's one way that Empower 150 is being used by some folks in a more targeted fashion. And so what's the preferred PD-L1 negative first-line immunotherapy regimen? The answer is, by cross-trial comparison, we don't actually know. So by histology, which is really what matters here, again, because there are these differences, the best data we have are with pembrolizumab. Keynote 407 and 189 directly address these histologic differences. There's generally consistent benefit for 189, the dilution effect for 407. But because of this, it's arguably become the standard regimens, also because they came out, one of the first to come out with histologic differences for a lot of providers as a result. And so it's very common that folks will recommend a Keynote regimen in the upfront setting in a PD-L1 negative population. Nivo, no PD-L1 intersected with histologic data, so it really is impossible for us to determine the benefit of PD-L1 in a PD-L1 negative, for example, squamous lung population for the purposes of cross-trial comparison. So we're sort of relatively hampered here in our ability to compare studies, really. But some are interested in the PD-L1 negative TMB high population for this based on that subset analysis that I had shown. And then Empower 150, consistently less benefit as PD-L1 expression goes down. Sort of on the surface level, intention to treat population, the magnitude of benefit doesn't seem to be as high as 189. So I don't think there's as much routine adoption for this. But again, on subset analysis, there's that interesting signal that we don't quite understand in the EGFR ALK positive lung cancer patients, where some of us are using Empower 150 after, again, frontline targeted therapy as an immunotherapy chemo sort of angiogenesis inhibition-based combination in that population. But the sort of one of the questions, of course, is these cross-trial comparisons that we're all doing, how reliable are they? And the answer, of course, is that, well, they may not be terribly reliable. They are subject to a lot of reader biases. We all bring in different preferences that we have, different anecdotal experiences to regimens, which is meaningful, but again, can provide bias in our interpretation of the data. They're subject to trial population imbalances, right? Because the studies are not matched at all. And so there are going to be vagaries of trial conduct that lead to imbalances in the population. And they can be subjected to also random differences in how the control arms perform. We saw that, for example, for 227, where the squamous control arm performed particularly poorly for reasons we don't understand, but that does then lead to imbalances in the hazard ratios that we see, which largely reflects population imbalances probably. And so the question is there a better method for cross-trial comparison? And the answer is that there might be. Starting, I think, in the early 2010s, there was in the field of biostatistics, this thing called matching adjusted indirect comparison that emerged. Much of which I understand, some of which I don't. There's a lot of sort of heavy statistical analysis that gets done in the back end for this. But the idea is there is an ability, particularly if you have very granular data, and this means patient level data, at least for some of the studies, you can try to take these data and harmonize them from a clinical characteristic and sort of tumoral characteristic perspective. So differences basically that exist in characteristics between 227 and the Keynote studies, you might be able to harmonize through statistical methodologies to then generate matched populations for this kind of comparison that tries to eliminate at least the population level biases and differences that might exist. And so Balazs Helmos and colleagues have done this a couple of years ago now for Checkmate 227, as well as the Keynote studies, using Checkmate 227 as the kind of control comparator for for patient variables that are present. And so what this ends up looking like is here, the baseline characteristic table that basically shows the control population, which is the Checkmate 227 population on the left, and then a before matching and after matching population for the keynote studies, which demonstrates imbalances in the before matching. So age is a pretty evident one, for example. And then after matching analysis that's done shows more of a harmonization with the control analytic group. And so again, the idea is that we're trying to population match here. And because you have granular efficacy data and can basically take apart Kaplan-Meier survival curves to get this granular data, you can then do analyses for overall response rate and time-dependent endpoints. And so that's what they did, a match-adjusted indirect comparison for PFS and OS in a PD-L1, in this case, positive population. But the idea here is that in a more rigorous statistical fashion, what they found was that chemo-pembro did seem to be better. Overall survival was 23.7 months, followed by Ipi-Nivo at 16.9 months, followed by the chemo control arms, and this sort of matched the PFS data that's shown on the right side. Some of this, a lot of the times, I think MAIC is going to match our intuitive cross-trial analysis comparisons because we're not sort of out of our mind biased as oncologists. We do try to view the data in a fairly impartial fashion. And so there's sort of a matching, at least with this analysis, with I think a lot of what we've done on cross-talk comparisons independently in our brains. And you can generate very, very nice match-adjusted Kaplan-Meier survival curves also. This is for OS, which clearly demonstrates that the keynote studies seem to be best, followed by Checkmate 227, followed by the chemo control arms, and that's demonstrated on the forest plots on the right side as well. And so in summary, PD-L1 negativity really can only be interpreted in the context of molecular data that increasingly is NGS based. And of course, the idea is that a PD-L1 negative EGFR positive lung cancer patient is going to be different from a PD-L1 negative squamous cell lung cancer patient. PD-L1 negativity probably does mean different things based on different histologies. Squamous cell lung cancers, through lots of different studies, appear less responsive than adenocarcinomas to immunotherapy-based regimens. And again, we saw this in the adjuvant studies quite nicely also. There are no direct head-to-head trials between first-line IO regimens. So really, it's impossible to know if there are meaningful differences, especially when you get to these finer subset analyses. But there are tools like this matching-adjusted indirect comparison, which can get a little bit of control on this question as to whether or not one regimen sort of rises above another in a more rigorous fashion. And I think ultimately, for me, there are lots of regimens that are approved. There are lots of regimens that have efficacy, and this just gives us lots of tools to be able to sort of adjust a regimen based on a particular patient's clinical characteristics, performance status, preferences on potential side effects, comorbid conditions, and other kind of modifying factors. And that's a great thing at the end of the day. But by default, I think a lot of us have adopted chemo-pembro as a standard option for reasons that I had mentioned. And I think that's it. I think I'll finish a little bit early. Thank you.
Thank you very much, Dr. Paik, for excellent presentation. And I will handle that mic to Dr. Munira Al-Maged. Dr. Munira, please.
Thank you, Dr. Marfat. It was a very nice presentation, Dr. Paik, and we will move to next talk where Dr. Ahmed Al-Lahibi will tell us about how to choose the first-line immunotherapy in PD-L1 positive metastatic breast cancer. Dr. Ahmed Al-Lahibi is a consultant medical oncology at King Faisal Specialist Hospital and Research Center, Jeddah. Welcome, Dr. Al-Lahibi, and you might start.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Munira, for the kind introduction. I'd like to thank the organizing committee headed by Dr. Hassan Murshid and Dr. Mirvat Mahrouz for their kind invitation for me. It actually gives me great pleasure to be here. This is my second year in a row to be involved in this prestigious event. So without any further ado, I was given the task of talking about the role of first-line immunotherapy in PD-L1 positives and how to choose. And has been suggested by Dr. Paul in his brilliant presentation, which sets a perfect stage for my presentation now. The choices are quite variable, and there are several choices, and it's quite confusing and complex to understand and basically to choose which one is the best medication out there, or what kind of combination medication that we can use. So these are the main objectives of the talk, and I'd like to highlight the first objective, which is to recognize the best options in case of PD-1 positives disease, whom and what to choose, and whether a single agent immunotherapy would be suffice enough to treat our patients versus dual immunotherapy or chemo immunotherapy or dual immunochemotherapy. So these are going to be the main studies that we're going to go through. And I believe that the devil's in the details, because there are a lot of things that we can actually conclude from these trials. So these are the main studies of the single agent immunotherapy, and these are the chemo immunotherapy trials or studies that we're going to go through. And these are the dual immunotherapy, as we all know about, that we're going to go through, and we'll try to squeeze out as much as possible information so that it will help us to guide the treatment algorithms in our patients. So this is the first talk, or the first study, which is the Keynote-24. And we all know that the Keynote-24 enrolled patients who had PD-1 positive disease, mainly strongly positive, more than equal 50%. And they had strict inclusion and exclusion criteria in terms that they actually excluded all EGFR and ALKs from the study, and they actually enrolled patients who were no untreated CNS metastases. So patients who had CNS disease should have been treated previously before enrollment, and they were basically they were given either pembrolizumab versus chemotherapy, as we all know, and we all know that the overall survival benefit was quite significant for pembrolizumab, as basically you can see here in 5 years, it's almost 30%, 5-year overall survival rate versus 16% in favor of pembrolizumab. And these are the observed response rates and duration of responses, almost reaching 30 months in favor of pembrolizumab. And I'd like to point out here in the forest plot that these patients who had brain metastases, although that it appears that they gained some benefit from pembrolizumab, but you can see that the confidence interval definitely crosses the 1 line, and that we will go over as well in the subsequent trials. So we have to keep that in mind for later on. So how about the IMpower110? Well, the IMpower110 looked at the use of Atezulusumab in patients who had either squam or non-squam, and they were stratified based on the following criteria, as you can see there. And there are 2 arms, Atezo versus chemotherapy, and based on what kind of histology you would have the option of maintenance chemotherapy, mainly if it was non-small cell lung cancer adenocarcinoma. And that's the overall survival benefit. And these are the highly positive PD-L1 markers, as you can see there, the TC3 or IC3, with an overall survival of almost 20 months versus 13 months in favor of Atezulusumab single arm. Hazard ratio is quite significant as well. And this is the forest plot. And I'd like to point out that all subhistologies gained some significant benefit, but mainly the ones who had the main benefit were the adenocarcinomas, as you can see there. And again, these are the highly positive PD-L1s. How about the whole population? Well, it was not as suggestive as you can see there. So it did not gain some benefit for the ones who had the lower positive PD-L1s or the negatives. So we will strictly use Atezulusumab in highly positive PD-L1s. And now we're going to go to more interesting data with the use of Cemiplimab. And I think the stratification factor in Cemiplimab, which is a new anti-PD-1 medication, actually they enrolled patients who, again, no EGFR ALK, no driver's mutation, but they enrolled patients who had a clinically stable CNS metastases, and more importantly, they enrolled patients who had hepatitis B, C, or HIV were allowed. So that is one point that we need to point out and keep in mind as well. And stratification factors were basically based on histology and region. Arm A was Cemiplimab versus chemotherapy of choice. Accordingly, primary endpoint would be overall survival and PFS. Again, they were quite well balanced between both arms. I'd like to say that brain metastases were not more than 12% for all arms. Basically, we have to keep in mind that the population with brain mets were of small percentages. So these are the data for overall survival. It was not reached upon the study analysis, and it was published, and it was 14.2 months. So it was in favor of the use of a Cemiplimab, significant hazard ratio of 0.57 and significant p-value as well. Here in the forest plot, as you can see there, for patients who had brain mets, although that is a small number of patients, but it's quite significant and has a ratio of 0.17 if we want to talk about strict numbers there. So it is quite positive trial as a single agent medication that can be used in brain metastatic disease. So that's the conclusion. Cemiplimab is a new medication that we can think of as a single immunotherapeutic agent in patients with metastatic non-small cell lung cancer. So these are the adverse events, as you can see there. I'm not going to go through that in details. So now we're going to move on to chemo immunotherapy, as been stated by Dr. Paul in the previous presentation. So the keynote 189, we all know that we use this particular regimen in patients with adenocarcinoma and metastatic disease. And it's combination immunotherapy, pembrolizumab plus chemotherapy. And as we all know, there's significant overall survival benefit in the whole intention to treat population. As you can see there, it's almost 22 months versus 10.6 months, significant hazard ratio as well. But when we talk about the positive disease, and I'm going to point out to the left-hand side of the slides, as well as the middle graphs, you can see that in strongly positive disease, the overall survival benefit was almost 28 months versus 10 months. And in the low positives, it's 22 months almost versus 12 months with a significant hazard ratio, as you can see there. The negatives were all already mentioned by Dr. Paul. So here, we're going to be talking about brain mets for the keynote 189. It seemed that patients who had brain metastatic disease gained significant benefit, even with the use of pembrolizumab plus chemotherapy in this subset of patients. We need to keep that in mind as well for the end of the talk. Keynote 407. So these are the patients who had squamous cell carcinoma metastatic disease, and we all know this is the most aggressive form of non-small cell lung cancer, and we need to treat that for most part with chemotherapy, immunotherapy, unless if the patient has a lot of comorbidities as per the keynote 407. And you can see there that the overall survival was significantly positive for the whole intention to treat population of almost 16 months versus 11.3 months. But I'd like to point out the positive diseases basically in terms of the PD-L1, and I'd like to reach out to the in the slide on the right-hand side of the slide, as well as the middle side of the slide. You can see that the use of pembrolizumab plus chemotherapy was strongly positive, and it was not reached in terms of median months for patients who had strong PD-L1 positive disease. And the same thing is basically for patients who had low positive disease. It was 14 months versus 11 months, and with significant hazard ratios. These are the forest plot in terms of the benefit, and it seemed that everyone had gained significant benefit. And despite the use of the backbone of chemotherapy, it didn't make much of a difference in terms of nab-paclitaxel versus paclitaxel. So the Empower 150 has been alluded at by our colleague Dr. Paul as well. So this looked strictly at patients metastatic non-small cell lung cancer, non-squamous population. And most importantly, this is one of the few trials that pointed out liver mets, and they stratified patients based on liver metastatic disease. 3 arms, arm A, Atezo chemotherapy, arm B, which is the experimental arm, Atezo beva chemotherapy, then chemo plus bevacizumab. Again, they enrolled patients who had EGFR positive mutations, although that quite small number. Here's the results. The overall survival in terms of the intention to treat population, the wild type population, meaning the patients who did not have the alkyl EGFR mutations, was quite positive in favor of the arm B, which is the main experimental arm, the quadruplet of 19.2 months versus 14.7 months, significant hazard ratio. Again, overall survival in intention to treat population, including patients who had EGFR ALK positives. Again, it's almost 20 months versus 15 months almost in favor of the arm B, which is the quadruplet. One thing to be pointed out here is that the addition of bevacizumab to Atezulusumab in the arm B, when they compared it to EGFR versus ALK and the intention to treat population that's wild type, it seemed that there is some benefit when you add in the quadruplet versus only the chemotherapy plus bevacizumab in patients who had EGFR ALK positive mutations. We have to say that the numbers are quite small and strict conclusions cannot be withdrawn, although that this remained as a possible option in patients who had progress while being on EGFR ALK positive mutations. Moving on to Empower 130. So the Empower 130 looked at Atezo chemotherapy versus chemotherapy plus alone. And they actually stratified patients again based on liver metastatic disease. I have to mention that the Empower 150, the liver metastatic disease was a positive trial in terms of liver mets. However, in the Empower 130, when they've given only Atezo chemo versus chemo alone, the overall survival was in favor of the Atezo chemo, with almost 19 months versus 14 months. But when you look at the liver metastatic disease, it did not show that there is any significant benefit. It actually crosses the line. So that's one thing that we have to keep in mind. So that's a table that just looks at the adverse events and just for comparisons between trials. So now moving on to the dual immunotherapy, we all know that Checkmate 227, they stratified patients regardless of histology, mainly to either PD-1 positives or negatives, as you all know. And I'd like to point out, this is the drop in the first 6 months has been alluded at by Dr. Paul, and that has been overcome later on by the Checkmate 9LA. So here the results for the overall survival in terms of the patients who had the PD-1 positives. It was a positive trial in the population with the overall survival at 3 years of 33% versus 22% rate. And these are the 3-year updated results, as you can see there, for Nivo Epi versus Nivo. So now the Checkmate 9LA. So the Checkmate 9LA, basically, it was done based on the previous trial, the Checkmate 227. And in this trial, they only added 2 cycles of chemotherapy on top of the Nivo Epi to alleviate and to eliminate that initial drop in the graph, as we had seen. And here you can see that there has been no initial drops with the 2 cycles of chemotherapy alone, and the overall survival, as you can see there, is 14 months versus 11 months in favor of Nivo Epi plus chemo with a significant hazard ratio. And that's the primary endpoint that's been updated. It's almost 16 months versus 11 months in favor of Nivo Epi plus chemotherapy, and it was a very well-tolerated regimen. One thing to be mentioned, the first plot here, CNS metastatic disease gained significant benefit, as you can see there, with a hazard ratio of 0.38. So it's another regimen that we think about in terms of patients who had CNS metastatic disease. But in patients who had liver mets, it seems that the hazard ratio is only 0.83 as compared to the Empower 150. And this table is just to tell us about the cross trial comparisons, which I do not tend to use a lot. So we're going to be talking about, if patients had brain mets, you have the Checkmate 9LA, which you can use as we had seen in the forest plot. So that's one option that we can think about in terms of dual immunotherapy plus chemotherapy, And in terms of patients who would have or not fit for combination chemo immuno, then you can give Symptom in these patients who had brain metastatic disease, as you can see there. Although that there is some crossing in the line, but it is one of the few trials as a single agent immunotherapy that enrolled these particular patients heavily. So how about the Keynote 189? As we had seen, patients who had brain mets gained significant benefit. So again, that can be a contributing factor in terms of your decision-making process in patients who would have Keynote 189 in terms of patients who had brain mets. How about liver metastatic disease? As we said, in Empower 150, they actually enrolled these patients and stratified them upfront. So that's a big advantage for that trial. You can see that the patients who had liver mets had significant benefit with a hazard ratio of 0.54. If you want to be evidence-based, basically that can be one approach that we can use in these patients who had liver mets, which we know all that is a poor prognostic factors in patients with non-small cell lung cancer. So that's my approach. In terms of the non-small cell lung cancer, you would see if it's an adenocarcinoma, you would have to check the PD-L1 status. If it was more than or equal to 50%, then you would have to assess if you need a rapid response. If you need a rapid response in these patients, then you would have to go down the path of chemo immunotherapy, not single agent immunotherapy. No rapid response, then you would give single agent immunotherapy. Always keep in mind that if you want, if they have seen a patient with brain mets, then you have the option of using Checkmate 9LA, Keynote 189, and if you want a single agent immunotherapy, then Symptom is going to be your way to go. If patients had the liver metastatic disease, then you would have the Empower 150, as we stated previously. So that's again the squamous cell carcinoma approach, rapid responses, chemo immuno. And strictly speaking, for squamous cell carcinoma, my initial thought on that is to always go for chemotherapy plus immunotherapy right up the front, despite the PD-L1 status, unless if the patient cannot tolerate combination chemotherapy, immunotherapy because of the aggressive nature of the disease. With that, I conclude my presentation, and thank you very much for your kind attention.
Thank you very much, Dr. Ahmed. That was excellent presentation. I would like to invite our speakers to join us. We'll go for the polls, and then we'll go for the Q&A. Can we have the barcode for the floor, please? have barcode for the floor. Okay. Can you please just scan this barcode so you can vote? So we'll start the polls now. And unfortunately, the panelists, they are unable to, except with the floor team. So the online will witness the voting. So first question for the attending. Did you attend the ASCO, WCLC, or ESMO virtual last year? Yes, no. Can you please vote? So 82% no, and almost 80% attended last year ASCO and WCLC. Next question. So immune therapy became the standard of care in many disease sites because tolerable, convenient, I'm still not using. Can you please vote? So 43% pointed out it's a convenient and 29% it's tolerable. Still, we have about quarter, I'm still not using it. Dr. El-Hayb, do you want to comment on this? Which one you will go for the immune therapy? Is it tolerable, or convenient, or what do you think?
So thank you for the question, Dr. Mervat. I think tolerability definitely plays a major role, and we always have to look at exclusion factors like autoimmune disease and other processes. We should keep immunotherapy as a standard of care in our population, especially definitely if they had EGFR, ALK, and RAS negative diseases, then immunotherapy has a significant role unless if they have some kind of contraindication.
Thank you. Next question. Last 2 years has unprecedented data for non-small cell lung cancer management, meaning regarding the adjuvant and also the dual blockade. Agree, disagree, I'm not sure. Can you please vote? So we do have the results for the voting. 46% consider it's unprecedented data the last 2 years for the non-small lung cancer, and only 9% disagree and almost equal for not sure. Can you please, Ignacio, give us your thoughts regarding unprecedented data?
So I do agree. I think this is not just for the last 2 years. I think this is something for the last 10 years and more specifically for the last 8 years probably, that we have seen new data, new combinations, new achievements in terms of overall survival, new targeted therapies coming up to clinical practice. So this is really, you know, the neoadjuvant setting has emerged that we have not considered before in lung cancer in general. So yes, I do agree. I think we are in the best part of the wave in terms of drug development and clinical trials, you know, success. So I do agree.
Perfect. And I think also the Pacific study, it was one of the unprecedented data as well.
Yes.
Perfect. We go for the next question regarding the IMpower010 study. Is it changing practice? Yes, no, I'm not sure. Can you please vote? Dr. Samah, you were very convincing. We have 61 yes and no. It was 5%. I'm not sure about 33. What do you think?
So I think it's a practice changing actually in the PD-L1 positive. And of course, discussing the option with the patient. I think between medical oncologists, actually we divided between some people, they find it a practice changing. Some people, they think that they want to wait for more data. So, but personally, I think it's positive for the more than 50% PD-L1.
Perfect. Pearl Keynote 091 is proving concepts but very confusing in PD-L1 more than 50%. Agree, disagree, I have concern about this data. We all do. Thank you. So can you please vote? So it was 63% agree about the proven concept. However, the point of the confusing regarding PD-L1 50%, I think it's raising a lot of questions for us. I have concern about the data about quarter. Paul, do you have concern about this study?
Yeah, I do. It's, you know, part of the thing that's so reassuring, and I think Ignacio really was touching on this when it comes to the unprecedented nature of where we are right now with immunotherapeutics, is the consistency that we've seen sort of across studies. And then you come to this and it's not, and then it's very confusing. It's sort of one of those existential angst moments where, you know, do we really know what's going on? So I think we just need to better understand it. I mean, it is confusing. It is, you know, something of an anomaly, and it does raise sort of lots of questions to what's going on, particularly in this perioperative space where the stakes are much, in ways, stakes are always high for our patients. But when we talk about trying to sort of reset the bar with curative therapies, this really, you know, the bar is much higher, right, in terms of that. Yeah.
Right. And Nivolumab in stage 3 irresectable has benefits in all patients as a standard of care. Agree. Only PD-L1 positive patient, I have concern regarding post-radiation IO. Can you please vote? I think after many years of Pacific, we all agree about the study, but still, I think as Ignacio pointed out, that the EMA approval for patient with PD-L1 less than 1%, they are not going to, I think it's a problem in Europe. However, it's FDA approved. So the voting agreed about 70%, only PD-L1 positive about 17%, and I have concern regarding post-radiation about 13%. What do you think, Ignacio, please?
So the truth is that we don't really know, because we have not tested this value of PD-L1 as a good marker in this setting. So this has never been tested before. So we know that from the subgroup analysis in the retrospective way, we can see that it seems that those patients being negative for PD-L1 might not benefit equally, but we have not tested this in a pre-planned way in a randomized clinical trial. So the answer is we cannot tell, and we really need more data in order to demonstrate this further. And at the same time, as I mentioned in my talk, we have to consider that patients that you know, present a negative PD-L1 at the time of the diagnostic biopsy might present PD-L1 positive after chemoradiation, because we know that that can happen. There can be an overexpression of PD-L1 due to chemo and radiation therapy. So we don't really know.
Yes. Next question. What is your preferred first-line treatment in 55 years patient with metastatic squamous cell carcinoma, non-small cell lung cancer with PD-L1 negative ECOG1? Pembro, Gem, Carbo, Nivo, Nivo plus chemotherapy. What do you think? Please vote. So 51% vote for the Pembro Gemcarb and 22% for Ipi-Nivo and 9-LA Ipi-Nivo chemotherapy. What do you think, Paul?
Yeah, there's really no right answer here. And I think as Dr. Al-Habi was saying in his talk, and this is sort of my riffing off that when he was at the very end slide, he was talking about squamous patients and preferring chemo IO. And as I presented before, IO just doesn't work as well in this population. We have hypotheses as to why that's the case for differential biological differences, for example, in the NRF2 pathway versus lung adenocarcinoma. But because of that, it really sort of elevates the role of adding chemo in general to this population. The population also tends to be presenting a little bit more symptomatic if they can tolerate it. So for me, the preferred answer depends on how a patient is feeling and how old they are. This patient is relatively young, so I think they could tolerate chemotherapy, in which case, I think if they were particularly symptomatic, the pairing chemo with immunotherapy, for example, would make sense. What that is, there's no right or wrong answer here. We just don't know. And I think there's efficacy whatever you give. So I think it's just you sort of pick one based on sort of the patient characteristics and go with that.
So in Memorial, in your clinic and patient a good performance status or whatever is your choice. So what is your favorite and what one you will pick from this?
Sure. So I tend to use Keynote 407 as a regimen. And maybe half of us to 75% of us do that. Some of my colleagues do like 9LA though, for a frontline chemo IO regimen for squamous patients, and that's perfectly fine as well. The data also look good. So I think for us, it's one of those two options.
Perfect, thank you. Last question. So flip the side. What is your preferred first line in 55 years patient with metastatic squamous, but with PD-L1 positive 10%, ECOG1, Pembro, Taxol Carpo, or Ipi-Nivo or Ipi-Nivo chemotherapy? What do you think? Can you please vote? And then we'll take the opinion of Dr. El-Heibi. So we have 62% Pembro Taxol Carbo, and we do have Ipi-Nivo about 18%. Still people, Ipi plus Nivo plus chemotherapy, 20%. What do you think, Dr. Ahmed?
For the question, Dr. Mirvat. So yeah, definitely something that we face not that quite frequently because of the low incidence of the squame that we see. However, it is a very bad disease. And as I said, the best options for these patients out there is chemo immunotherapy, but with all the in the right context, as been mentioned by Dr. Paul. So in this patient particularly, I would be leaning towards giving chemo immunotherapy. So pembrolizumab Taxol Carbo is an excellent option, as well as dual immunotherapy along with chemotherapy. And it all depends on the performance statuses of the patient, whether or not they can withstand 4 cycles of chemotherapy, or we can just go by 2 cycles of chemo along with dual immunotherapy. So both options are quite valid, but I have more experience in the chemo immunotherapy world.
Thank you. We finished the pause. We'll just only have 5 minutes for the Q&A. So I will start first with one of the questions of the attending. Sometimes we face rapidly progressive among PD-L1 positive patients using Keynote 189 protocol. Any explanations, and what is your subsequent therapy? So Dr. Gilbazo, can you just give us a thought about this question?
So I think the molecular level of these patients is really relevant. We know not all patients respond equally. And more specifically, we know that some genomic alterations, such as STK11, for example, or KIR1, might be a barrier of that immunotherapy to work. And at the same time, it's not only predictive, but also a poor prognostic factor. At the same time, sometimes we have an HER2 mutation or overexpression. Sometimes we have a MET, a RET, a ROS1 that we might not know it is there, depending on the the wider or less wide genomic analysis that you perform in your on your patients. And that can also make an impact on what you see in this chemoimmunotherapy setting. So my advice would be try to test as wide as possible, NGS as if ever possible. And then if the patient is completely negative, still you might see some patients that do not benefit, but most patients should benefit.
We do have a question for Dr. Samah that for a stage 3 disease, patient has surgery and PD-L1 negative, what is the subsequent therapy on adjuvant base?
Sure. So if we're talking about immunotherapy, we know from the IMpower 010 that the benefit was mainly driven from the PD-L1 positive group. So I don't think I would recommend adjuvant immunotherapy in the PD-L1 negative. If we look at the Pearl's data, actually, again, the PD-L1 status, it did not help. So I think waiting more for maturity of the result of the Pearl is very important, because if Pembro will get an approval, it will be for all PD-L1, regardless of the PD-L1 status, basically.
Thank you.
Dr. Mirvat, I have a question, actually.
Yeah, please.
Okay, for Dr. Ignacio, for the Pacific, we know actually from the Pacific data that we don't know the answer if Nivolumab will be helpful in the group with the mutation positive. We have a retrospective data that maybe there is no benefit. So what's your approach, especially that Pacific is the standard of care now?
Mm-hmm. So I think this is a relevant question. So the truth is that, again, as we mentioned before, with relation to the PD-L1 expression levels, we don't have the clear answer to this. We know that probably those patients with EGFR or ALK might have an immune suppressive microenvironment in the tumor, right? And that is something that could preclude the benefit of this approach. However, this has not been tested. So what do we normally do? I normally talk to the patient, because we have to put in the balance not only the efficacy or the potential efficacy, but also the potential toxicity. I normally talk to the patient, I explain the data, and the patient has the right or the last word in order to decide to go for the treatment in the adjuvant setting or not to go for the treatment. Sometimes you can consider at the same time PD-L1 on the one hand, EGFR out positive, negative. So it's not probably a matter of one factor, but a couple of factors. And the age of the patient, how the patient is willing actually to come to you on a regular basis, or just start follow-up checkups. It is a whole conversation that you really have to maintain with your patient in order to decide.
I have a question, Dr. Hilpaso, also for patient who is stage 3 who just finished chemotherapy, and you for the Nivolumab for those patients, if they develop brain metastasis, but still they are free in other part of the body. And so do you think this patient will not be eligible anymore because they officially progressed? Or you think still there is a room for continue the plan and offer the Nivolumab?
Mm-hmm. So the truth in my experience is that this is not something that happens very frequently. This is probably a different situation as what we see in patients receiving, for example, first generation or second generation EGFR TKIs. Those patients would eventually progress in the brain. And those patients we tended to treat locally and keep the systemic drug, right? So in this immunotherapy setting, it is more likely to be uncommon that those patients progress in the brain. However, this can happen, as you mentioned. And what I would do is that if the patient is really benefiting overall and is tolerating very well the treatment, I can treat locally, preferred as SBRT. If it's only 1, 2, 3 lesions, small lesions, I would go for local SBRT treatment. whole brain irradiation could be also considered, but in that setting, I would rethink the whole thing, and I would retest the patient for potential mutations.
Herbert, can I ask a very quick question?
Yeah, please go ahead.
Thank you. It is again for Prof. Giglianzo. Excuse me, regarding patients who are stage 2 or 3, what do you think? To whom should we offer immunotherapy in the neoadjuvant setting, putting in mind financial toxicity, clinical toxicity, and you need a fit patient to send him for surgery, because still surgery is a mainstay for treatment of lung cancer. So how are we going to choose? Shall we leave it for patients who are lymph node positive, a patient with high risk? In the clinical setting, in your clinic, how do you stratify patient for neoadjuvant versus non-neoadjuvant immunotherapy?
So do you mean patients with stage 2 or 3 but resectable disease?
Yes.
Okay, so at this point, we have no definitive data, and there's no standard of care to provide neoadjuvant immunotherapy or immunochemotherapy. However, we have a lot of clinical trials running, and we actually recruit a lot of patients in these clinical trials. And we have seen really, amazing pathological complete responses and maintain benefit over time. So once we have this approach approved and demonstrating substantial benefit to the patients, I think we have to consider whether those patients may benefit from that neoadjuvant therapy according to comorbidities, according to the risk that the progression of the disease may occur during that neoadjuvant therapy. We have to take into account several factors, but the truth is that we don't have biomarkers to choose or to select patients that will eventually benefit from that neoadjuvant therapy. So still a lot of work to be done, and a lot of selection of patients to be done.
I have a question.
Last question, please.
Yeah, okay. I have a question for Dr. Paul. I mean, we know that we do for all our patient NGS in the very beginning, and my question to you, for patient with high expressor, I mean, do you think all the driver mutation are the same? I mean, do you start with the driver anti-driver mutation treatment for all patients? I mean, MET like BRAF is the same like ALK or ROS1, or do you think still there is differential in some of these marker?
Yeah, I still think there are differences. I think there's no hard line that we use to elevate a targeted therapy to the frontline setting. And of course, the challenge is that we almost never, particularly in the rare mutations, have had data that inform whether or not something should be sort of migrated to the frontline therapy versus an immunotherapy-based regimen. But we can do sort of the mental exercise for this. And a good example would be the MET exon 14 skipping space, where we just have single-arm phase 2 studies. The aggregate data shows an overall response rate of 50% and a median PFS between 10 to 12 months. And so you sort of look at that and think, well, how good is that compared to frontline IO-based therapy? And the short answer is that it's pretty good. And it's a pretty well-tolerated drug in an elderly population. So a lot of us will migrate that to the frontline setting. But it's hard for some other drugs and agents, for example, EGFR exon 20 insertion, right? Those data are decent, but they're not frontline data worthy, right? So generally for those treatments like amivantamab, we'll give it as salvage therapy in the second line setting. Again, the idea I think is that we sort of have this general idea of what a threshold is to meet for overall response rate and PFS, and that's generally kind of what we use. But I do think that there are differences that are there. Although most of our endeavors have been fairly successful in terms of, particularly lately, sort of hitting that target with the first attempt. So.
With that, I would like to close session. First of all, I would like to thank our co-chairs, Dr. Ahmed Rifai, Dr. Nafisa Abdel Hafiz, Dr. Munira Al-Magid. Thank you very much for sharing with me. And I would like to extend my thanks to our distinguished speakers, Dr. Samah Al-Rahili, Dr. Ignacio Gelbazo. Thank you so much, Dr. Paul Pike and Dr. Ahmed Al-Lahibi. It was our pleasure. Thank you very much for your excellent contribution, and see you soon, inshallah. Thank you. I would like to close my session, and we'll start with our first slide symposium with BMS. I would like to introduce first our chair, Dr. Rashad Al-Khayat. Dr. Rashad Al-Khayat is known for everybody. He is our dearest colleague. He is a medical oncology consultant and assistant professor in King Abdulaziz University Hospital in Jeddah. He will chair the BMS Satellite Symposium. Thank you very much.
Thank you, Dr. Mirvat. Can you hear me? Well, good evening, everyone. And it's my pleasure to chair this session. I'd like first to congratulate to our colleagues in Prince Sultan Medical City for keeping the success on a yearly basis. This is the 6th year. And I still remember the first year when it started, and I see more topics and more great speakers who are here. So this is just saying we are trying to keep the knowledge and the exchange discussion all the time. It's my pleasure to introduce Dr. Ahmed Al-Lahibi. Dr. Ahmed Al-Lahibi is a consultant medical oncologist at King Faisal Hospital. He's the head of the Saudi Lung Cancer Society. Dr. Ahmed, he will be presenting about the clinical outcome of the dual immuno-oncology blockade-based regimen in treating first-line non-small cell lung cancer. And special thanks, for BMS for sponsoring this satellite activity. And we're going to leave the question toward the end of the presentation. Please, Dr. Ahmed, the mic is yours.
Assalamu alaikum all. I'd like to thank you very much, Dr. Shadi Khayat, for your kind introduction. It's always a privilege to be introduced by an iconic oncologist like yourself. So thank you for that. I'd like to thank the sponsoring company, BMS, for sponsoring this event. We're going to be talking about the clinical outcomes for the dual immunotherapy blockade-based regimen in the first-line treatment of non-small cell lung cancer. We kind of touched base on that in the previous lecture, but here we're going to have kind of a deeper dive into it. So what's the rationale for the dual immunotherapy? As you can see that the improved survival has been a challenge in some of these cancers, as you can see there, mainly the lung cancer, melanomas, and kidney cancers. The 5-year survival outcomes had been quite poor, and it was kind of an unmet need that would need further exploration and innovations to control that. Hence, that the idea of the dual immunotherapy came about. And what's the mechanism of action of Nivolumab? If you can imagine that the T cells is the middle between the tumor cell and the dendritic cells, then Nivolumab would be the one to block the PD-1, which is located in the T cell, so that this inhibitory signals will be alleviated and will make only room for the stimulatory signals between the tumor cells and the T cells for the T cells to be activated and to recognize the tumor cells. And hence priming and activation of T cells would occur through that T cell receptors between the CD28 and the B7 interaction. And that can be further added and helped by the use of Ipilimumab, which is the anti-CTLA4 medication that augments the T cell activation and proliferation, including the activation and proliferation of tumor infiltrating T effector cells, which is quite important to further aid in the killing process of the cancer cells, as you can see there. So it is through that synergistic interaction of immunotherapies together can help deliver and enhance anti-tumor responses greater than with either antibody alone. And that has been evident in several trials, and most notoriously has been evident through the Checkmate 9LA, where combined with 2 cycles of chemotherapy to provide early disease control and actually help with the significant response rates and initially alleviation of that drop that we had seen at the beginning. So these are the Nivo Epic-based regimens that has been approved in Saudi Arabia. For melanoma, you have the Checkmate 67. And the first-line treatment for renal cell carcinoma is the Checkmate 214. For the first-line treatment of malignant pleural mesothelioma, we have the Checkmate 743. And then first-line treatment option for non-small cell lung cancer, you have the Checkmate 9LA. Only Nivolumab and Ipilimumab offers dual immunotherapy durability, delivering a chance for long-term survival, as had been seen in previous studies, like in melanoma. You would have a 6.5 years follow-up with almost 49% disease overall survival versus the standard approach. And you have in the first-line setting for non-small cell lung cancer, again, the 2 years follow-up is 37% rate versus 22% rate. And the same thing is truthful for the metastatic renal cell carcinoma in the upfront setting, as well as in the malignant pleural mesothelioma. So again, when you break them down to specific disease sites, like in melanoma, at the 6.5 years, you have almost 50% overall survival compared to 42 and 23%, respectively, in favor of Nivo-Epi. Again, the complete responses at 6.5 years, almost approaching 23%, partial responses about 36%, favoring the Nivo-Epi combination when it comes to melanoma. How about malignant pleural mesothelioma? As we all know, the Checkmate 743 is a practice-changing study where it actually included patients with unresectable upfront malignant pleural mesothelioma, no prior systemic chemotherapy. They were stratified to either epithelioid versus non-epithelioid and gender. I'd like to point out that the non-epithelioid, which is the sarcomatoid component, is the more aggressive part than the epithelioid component. They were randomized 1-to-1 to either Nivo-Epi for up to 2 years, or cis carboplatin pemetrexed for only 6 cycles, and they were given until disease progression or unacceptable toxicities, or for 2 years of immunotherapy. The primary endpoint would be overall survival. Secondary endpoint would be overall response rate, disease control rate, PFS, and they also looked at safety and tolerability. Here, when it comes to the overall survival percentages, it was about 23% versus 15% in favor of the combination versus chemotherapy. With the overall survival in terms of months, it was 18 months versus 14 months with a significant hazard ratio, as you can see there. Hence, the first approved therapy in more than 15 years to demonstrate durable long-term survival versus standard of care chemotherapy in the first-line setting was mainly with the durable immunotherapy, as we had seen there. And basically, this is to tell us about the duration of response when the dual immunotherapy is being given. The median duration of response is almost 12 months for the dual immunotherapy versus 6.7 months. And the response rate would be 28% at 3 years, as opposed to the standard of care. Now we're going to be talking about the first-line Nivo-Epi with 2 cycles of chemotherapy versus chemotherapy in patients with advanced non-small cell lung cancer. And here I'm going to be talking about the 2-year update from the Checkmate 9LA. And here, basically, as we stated before, that the main idea of the Checkmate 9LA was to alleviate the initial drop that had been seen previously in Checkmate 227. So adding a limited course of 2 cycles of chemotherapy on top of Nivo-Epi could potentially provide disease control rate while building on the durable overall survival benefit, as we had seen truly in the previous study and the previous presentation. So what they've done in the Checkmate 9LA is basically to assess the potential safety and tolerability of the use of 2 cycles of chemotherapy. The key inclusion criteria would be stage 4 or recurrent non-small cell lung cancer, no prior systemic chemotherapy, no drivers mutations, ECOG 0 to 1, and they were stratified based on the PD-L1 status. If it's negative, less than 1%, versus more than equal 1%, any positivity, SACS, histology, squamous versus non-squamous disease. And they were randomized 1-to-1 to either Nivolumab at a dose of 360 milligrams every 3 weeks, plus Ipilimumab 1 milligram per kilogram every 6 weeks, and chemotherapy every 3 weeks for only 2 cycles, versus chemotherapy every 3 weeks for 4 cycles. Based on the underlying histology, there will be maintenance pemetrexed versus no maintenance chemotherapy. Primary endpoint would be overall survival. Secondary endpoint would be PFS, overall response rate, and efficacy by tumor PD-L1 status and safety. The patient's population was quite well balanced between both arms. Most of the histologies, as you can imagine, would be adenocarcinoma. Otherwise, they were quite well balanced between both arms. And I'd like to point out that it actually involved liver metastatic disease and to some extent CNS disease. So here's the overall survival at the 2-year cutout. It was in favor of the Nivo-Epi combination with chemotherapy for almost 16 months versus 11 months for the standard of care, in favor of the experimental arm with a hazard ratio of 0.72. At 2 years, the overall survival rate would be approaching almost 40% versus 26% in favor of the Nivo-Epi plus chemotherapy. So when you look at the forest plot, it seemed that patients who had CNS disease had gained significant benefit of 0.47 hazard ratio, and patients with squam versus non-squam had significant benefit as well. And I'd like to point out for the squamous population, the benefit was almost 0.63 as a hazard ratio, which is quite significant for this aggressive disease. And all PD-L1 statuses gained significant benefit, as you can see there. So how about when we look at the overall survival in patients with PD-L1 less than 1%? Again, it was in favor for the experimental arm, which is the Nivo-Epi plus chemo, of almost 18 months versus 10 months in favor of the Nivo-Epi plus chemo with a hazard ratio of 0.67. At 2 years rate is 37% rate for survival versus 22%. And here it's based on the PD-L1 expression being positive more than equal 1%. As you can imagine, there is significant benefit of almost 16 months versus 11 months in favor of Nivo-Epi plus chemo with a hazard ratio of 0.70 and a significant rate of survival at 2 years of 41% versus 28%. How about the histology for the non-squamous population? It's almost 18 months overall survival versus 12 months in favor of Nivo-Epi chemo with a hazard ratio of 0.78. And you can see that at the overall survival rate at the 2-year cutoff was 40% versus almost 30%. The squamous population is 14.5 months of median overall survival versus 9 months with a significant hazard ratio of 0.63 and 35% rate of overall survival at 2 years versus 20%. The non-squamous histology with a negative PD-L1 expression gained significant benefit, again, of 18.6 months versus 12.5 months with a hazard ratio of 0.75, as you can see there. For the non-squamous histology with a PD-L1 expression more than equal 1%, there was significant benefit as well of 17.6 months versus 11.5 months and a significant hazard ratio. How about the squamous subhistology, which is something that we always look for because we all know that it is an aggressive tumor, and to some extent it does not respond as well to chemotherapy, the immunotherapy. And here in the negative population of PD-L1 in the squamous population, 15.3 months overall survival versus 8 months, which is quite staggering and outstanding for this trial with a hazard ratio of 0.48. The overall survival at 2 years rate was 33% versus 11%, and the positive population of PD-L1 again gained significant benefit of 14.2 versus 10.5 months with a significant hazard ratio. And here we're going to be talking about duration of response. As you can imagine, for dual immunotherapy plus chemotherapy, it was 13 months duration of response versus chemotherapy alone, which is 5.6 months in favor of the experimental arm. And when we compare the Nivo-Epi plus chemotherapy, showed significant PFS benefit versus chemo alone across PD-L1 expressions, as you can see there. Whether it's negative, which you can, as you can see there on the left-hand side of the slide, it was almost 14 months versus 7.8 months in favor of the dual immunotherapy plus chemotherapy with significant hazard ratio 0.62. And in the ones who had positive PD-L1 expression, the PFS was again significantly beneficial in the experimental arm. How about the PFS based on the subhistology? Again, in all histologies or subhistologies, they gain significant benefit, but I'd like to point out the squamous histology on the right-hand side of the slide. They gain significant benefit in terms of PFS of 13.6 months versus 7.4 months with a hazard ratio of 0.60, which is something that we have been struggling a lot in the population of squamous cell carcinoma in the metastatic setting because of the poor responses to various treatment algorithms and options. And here, that's the table that describes the adverse events in the population would be treated with Nivo-Epi. As you can see that the grade 3 to 4 adverse events would be about almost 47% for the Nivo-Epi population plus chemotherapy. And the treatment-related adverse events leading to discontinuation does not exceed 19.3%. Hence, the safety of Nivo-Epi with this new approach is quite tolerable for our patients' population based on these data. Again, the grade 1 to 2 side effect profile would constitute the most common one in terms of skin toxicity, followed by endocrine and gastrointestinal toxicity. Grade 3 to 4 does not exceed 6% in all of these toxicities, as you can see there. Again, the main adverse events that are associated with chemotherapy, as you can see there, it's anemia is more notorious to happen because of the more frequent cycles as opposed to Nivo Epi plus chemo, followed by neutropenia, then alopecia, which is quite almost identical, as you can see there. Overall survival was not impacted in patients who discontinued Nivo Epi with 2 cycles of chemo due to treatment-related adverse events, which is another strong advantage for this trial. At the 2-year cutoff, the overall survival rate for patients who had discontinued treatment for whatever reason would be 54% versus 38%, which speaks about the durability of this combination in terms of sustaining the overall survival benefit. How about the dosing? So basically at the initial dose for the first cycle, it would give Nivolumab at 360 milligram, along with Ipilimumab at 1 milligram per kg with chemotherapy. Then at 3-week time, you would give Nivo alone plus chemo. Then at the 6th week mark, you would give Nivo Epi without chemotherapy, and then you would carry out only with Nivolumab from there on until this, Nivo Epi from there on until disease progression or unacceptable toxicity for up to 2 years. So in summary, Nivo plus Epi with 2 cycles of chemotherapy offers a unique option for metastatic non-small cell lung cancer across histology and PD-L1 expression to provide rapid initial disease control. And we actually had seen the significant benefit for the use of this combination of regimen in patients with metastatic squamous cell carcinoma, especially with the PD-L1 negatives. So how about disease-related symptom burden? As you can see that everything in light blue is in favor of the combination arm, the experimental arm. And if they're pointing upwards on the right-hand side, that's in the better disease-related symptom control, which all goes in with a significant benefit for controlling the disease burden for these patients. And the same thing is applicable to overall health status, which was again in favor of the Nivo Epi combination. The same thing is truthful for the time to definitive deterioration was quite delayed with the use of the Nivo Epi combination with chemotherapy in terms of these symptoms of anorexia, fatigue, cough, and dyspnea, which has all been graded properly for this study for this population. So how about the use of this combination in patients with brain metastases, which is something that we had been struggling a lot about. And here I'd like to point out that some of these patients had prior radiation therapy, as you can see there, and whole brain radiation was the main way to go ahead with for this population. So here we're going to be talking about the overall survival benefit in patients with Nivo Epi plus chemotherapy. On the left-hand side, these are the patients who had underlying brain mets, and we all know that having brain metastatic disease and non-small cell lung cancer would confer a very poor prognostic marker. And here with the Nivo Epi plus chemo versus chemo, you can see that the overall survival is almost 19 months versus 6.8 months with a hazard ratio of 0.43. And the 2-year mark, the overall survival rate is 35% versus 12%. How about patients without brain mets? It was 15.6 months versus 12.1 months with a hazard ratio of 0.79. Hence, both almost are identical in these population, especially with the patients with the brain metastatic disease. How about the systemic progression-free survival and responses? And patients with brain mets on the left-hand side is 10.6 months versus 4.1 months with a hazard ratio of 0.40. And without brain mets is 5.8 months versus 5.4 months with a significant hazard ratio. In terms of the response, systemic PFS and responses, and the responses is going to be on the lower part of the slides. The duration of response in patients with brain mets would be 15.5 months versus 4.4 months. And in patients without brain metastases, is 13 months versus 5.7 months. So in total, this speaks about the significant benefit for the use of this regimen, even in patients with brain metastatic disease. The intracranial progression-free survival in patients with brain mets would be 13.5 months versus 4.6 months, as you can see there. And the intracranial responses in patients with brain mets is quite significant with a duration of response of 22.3 months versus 18.9 months in favor for patients with for the chemotherapy plus dual immunotherapy. And this is the NCCN guidelines where it actually puts the Nivo-Epi combination for both the adenocarcinoma population as well as squamous cell carcinoma population in the frontline setting, along with other chemotherapeutic agents with immunotherapy. And this again, where you can use the Nivo-Epi combination for these patients in the first line setting as per the NCCN guidelines. So in conclusion, the Checkmate 9LA is a very valid option, especially in patients who are not able to tolerate 4 cycles of chemotherapy with immunotherapy, and that would constitute an excellent option for both subhistologies, adenocarcinoma or squamous cell carcinoma, regardless of the PD-L1 status. And with that, I conclude my presentation, and thank you very much for your kind attention.
Review and until we get to questions. So in your clinic right now, we are representing now in the 9LA. You also touch base on the double immuno-oncology, and we have kind of the older regimen of the Keynote 189 or the Keytruda. So which one, let's say, any specific criteria where you build your choice for a first-line treatment in these patients?
No, thank you very much for the excellent question, Dr. Shadi. And I think, we have a lot of options in the first line setting for our population, especially with the metastatic non-small cell lung cancer PD-L1 positives. It all boils down to the patient's unique characteristics or whether or not they'll be able to withstand 4 cycles of chemotherapy. And most importantly is the availability of the medication at your institution. So that's going to be another thing that we need to think about. So in the Keynote 189, they enrolled brain metastatic disease who had stable disease previously treated, exactly like the Checkmate 9LA. There was significant benefit. In the Checkmate 9LA, they enrolled brain metastatic disease and they had significant benefit as well. So I think in terms of which one would gain the most benefit, I would basically boil it down to the PD-L1 status. If it was negative, there might be an option for Checkmate 9LA, especially if the patient cannot withstand 4 cycles of chemotherapy, especially that only 2 cycles of chemo looks quite intriguing in this population. So that's basically how I look down at things, and mainly the response rate would be another thing that we have to point out and to look at before we choose our systemic treatment accordingly.
Well, that's really I believe it's quite difficult as we have more options. It would be much more difficult to have what's your preferred, but again what's available and also clinical condition, because we face some patients who are quite their clinical status borderline, and they might not be able to trade the 4 cycles of chemo. And this is where we come to a choice of just double immuno or having the 2 cycles. In your discussion with the patient, do you think having 2 cycles versus 4 cycles of chemo made a difference in them? Or it would be easier to go without double immuno only versus 4 plus immuno?
I think this is an excellent question again, and definitely it all boils down to patients' characteristics and whether or not they'll be able to stand the 4 cycle chemotherapy versus 2 cycles of chemotherapy. Again, 2 cycles of chemotherapy looks quite intriguing, and it is something that I can think of in some of the patients I see in clinic that I think they would not be able to withstand 4 cycles of chemotherapy. The other issue is basically when it comes down to the availability of the medication in your institution. So that's another factor that comes into play. Again, it's very tough to choose between all of these options. I think I have some kind of a clearer idea when it comes to the more aggressive option, which is the squamous cell carcinoma. The Checkmate 9LA looks quite intriguing in this specific population, especially with the PD-L1 negatives. Although that we have another option, which is through the 407, they can use 4 cycles of chemotherapy along with pembrolizumab. Again, it all boils down to patient's characteristics as well as the availability of the medications in your institution.
I do have a question, please, Dr. Shadi.
Sure. Go ahead, Dr. Mirfat.
Thank you. Thank you very much, Dr. Ahmed. That was very impressive overview. My question regarding the CNS involvement and the impressive data for the dual blockade. And do you have an explanation for this patient to have these results? Specifically, we know that the molecule for the immune therapy, it's not crossing the blood-brain barrier. Do you consider this is part of the systemic control of the disease, or what is the explanation for this impressive results? Thank you.
Well, thank you very much, Dr. Mirta. I think this is an excellent question. So when you look at the single agent immunotherapy, there is definitely some data that suggests there is some control of the immunotherapy in the CNS disease. Although that has not been evident clearly in the Keynote 24 because it crosses the line. However, in the Cemiplimab, despite the very small number, they actually enrolled those patients and there is significant control of the disease in terms of the CNS metastatic disease. However, when it comes to the combination chemotherapy along immunotherapy, in the Keynote 189, it was very clear that there was significant control of the disease, but it seems that it's quite more significant in Checkmate 9LA, as we had seen there in the PFS, the response rates, the duration of responses. So I believe that the addition of another immunotherapy like Ipilimumab, which will help more in priming the antigen-presenting cells and help more in creating more T effector cells into memory cells, which then would cross the blood-brain barrier and help controlling the disease, that can be a very important factor, plus the backbone of chemotherapy. So in terms of the choice of backbone chemotherapy, I'm not a big fan of the use of gemcitabine if I'm using immunotherapy, because I don't think that gemcitabine helps in priming the immune system by the release of antigens. So taxane can play a major role along with the platinum, which has been evident in previous trials that it actually can prime the immune system properly. I mean, for a clear answer, that would be my explanation. Otherwise, it's not quite clear, basically based just on the data itself. Thank you.
Ahmed, would the primary pathology type squamous versus non-squam will make a difference for you?
In terms of the choices, absolutely.
The choice, yes, yeah. the protocol.
I think that's an excellent question again. So basically, when it comes to the squam versus non-squam, we all know that the squamous population of metastatic disease, they would tend to do worse than their counterpart of adenocarcinoma. So in the adenocarcinoma world, I would be more lenient in using a single agent immunotherapy. However, in the squamous population, if they have metastatic disease, I would just start right off the bat with chemotherapy, immunotherapy, unless if they have a PD-L1 status more than equal 50% and they cannot withstand chemotherapy. But my first line option for squamous carcinoma is chemo immuno right from the get-go. That is an excellent question. I think subhistology is very important to delineate which pathway would go down the route for.
We have a good data on squamous, pathology in different disease sites. So that's why I think majority of us, is trying to hook the immunotherapy upfront, because those patients, they will stand a good durability of the disease. Well, I don't have any questions more that comes to me here. Let me just see the screen.
We would need to move. Thank you very much, Dr. Shadi. Sure. Dr. Ahmed Al-Haybi for excellent overview and the great discussion. And we'll move for the next satellite symposium by AstraZeneca. It's my pleasure to introduce Dr. Abdullah Al-Turki. Dr. Abdullah Al-Turki is known for everybody. He is medical oncology consultant in Medical City. His main area of interest, lung and breast. He will chair the session for the satellite symposium for AstraZeneca. Dr. Abdullah, mic is yours. Thank you.
Thank you so much, Dr. Mirfat. Assalamu alaikum wa rahmatullahi wa barakatuh. First, I would like to thank really the organizer, and special thanks to you, Dr. Mirfat, for and the team from Prince Sultan Medical City for organizing this event. So also I would like to thank AstraZeneca for organizing such a satellite symposium. So this session, I would say it's focusing on a small cell lung cancer, and this part is not really, has been addressed in the earlier session. So to set the ground, it's really my pleasure to introduce Prof. Louis Bazaris. Prof. Bazaris is the chairman of Medical Oncology Department at Hospital Ducy Octobre, and he is the head of lung cancer. He's a head of lung cancer unit, in fact, at National Cancer Research Center in Madrid, Spain. He's one of the lung cancer leaders and have numerous publications and clinical trial involvement in this field. He's been active and member of number of academic and scientific society related to that. So today he will touch base an important unmet need topic with an overview related to extensive stage small cell lung cancer. The mic is yours, Prof. Louis.
Okay, so thank you very much. This is Luis Bazaris here speaking. So just give me a couple of seconds. So just I'm going to try to start sharing the slides here. So we'll see. Okay, sorry. I don't think this is the case. I should wait 1 second. I was confused here. Okay. Okay, so I don't know if you are able to see that is now. Not yet.
Not yet, no.
Okay,
not
1
yet.
second. It's going to be 1 second. Okay. Sorry about that.
Do you have the presentation?
Yes, yes.
I think it's here.
Yes,
Okay.
now, yeah, good.
Okay.
Thank you so much.
Okay, sorry about that, and sorry for keep you waiting. So it is really my pleasure to be with you today. I'm really thankful to the organizers of the PSMMC meeting. I'm really thankful for AstraZeneca as well for allowing me to have this role, this conversation on immunotherapy in extensive stage small cell lung cancer. And you see here my conflict of interest. And concerning small cell lung cancer, the progress is not been so huge as compared to non-small cell lung cancer. Truly, things didn't change as much. You just go back to this overview by the Cochrane survivorship at 2 years for patients with limited stage is not overpassing 20%. And look at that. For those 70% of the patients with extensive stage, our diagnosis survivorship at 2 years is in the range of 6 to 7%. So it's clearly we have to improve things. Thank goodness we have learned a bit on the pathogenesis of the disease. We know very well the genomic abnormalities behind. Very recently, we learned a lot about the transcriptomics of small cell lung cancer. We now have a subdivision of 4 major subtypes, and we know which are the typical pathways which are more, let's say, dysregulated, particular description. We know alterations in P53, retinoblastoma, so a lot of cell cycle issues because of the damage recognition and repair is not quite intact. Of course, a lot of epigenetic transformation, which indeed relates to this transcriptomic dysregulation. And there are a number of also alteration on the notch and stemness of this disease as well. But maybe more importantly, particularly taking into account the advances we have done into the immunology of lung cancer, here we have made some progress as well. We know that small cell lung cancer is a disease where new antigens are quite abundant, high mutational rate because of the smoking exposure in most of the patients. We know that a number of patients do have autoimmune paraneoplastic syndromes, and we know that those patients specifically are doing better as compared to patients without this autoimmunity. But also at the same time, we know that this is a not very immunogenic disease. very often we see downward ratio of HLA from the beginning of the disease, and this is not the typical tumor you see very inflamed. So there is kind of yin and yang here. So the first question, how are the results with immunotherapy here? Well, the initial results show that some 10%, 15% of the patients do have responses on the relapse setting to PD-1, PD-L1 inhibitors. However, those data are not enough to beat chemotherapy in pre-treated patients. It's not even better to no maintenance in the patients that had respond to chemotherapy, induction chemotherapy, so no role for maintenance treatment. So what about the role of PD-1, PD-L1 inhibitors in the first-line setting? And that question had been answered firstly by the IMpower133 trial. As you see here, patients without prior treatment, chemo-naive, were treated with a standard of care, carbo-etoposide, as compared to carbo-etoposide plus Atezulusumab. And as you see here, clear improvement in survival, hazard ratio 0.7, very significant, and that was at the cost of not much toxicity. There was a very similar trial in design, the Caspian trial, where standard of care was EP platinum etoposide. Here, the two platinums, carbo and cis, were allowed up to 6 courses, because many of us use 6 courses in the standard of care setting. And then the experimental arm number 1 was 4 courses of chemo plus durva, followed by durva. And the second experimental arm, 3 arms in this trial, was durva, treme plus EP, 4 courses, followed by durva. Importantly, some patients with untreated brain metastases were allowed in this trial as well. The results were very similar to those in the IMpower133 trial. Clear impact in survivorship, improvement in median survival in the range of 3 months as well. And you see here the updated result with a follow-up of 3 years. That difference in survivorship is maintained over time. And you see, in the 3-year survivorship, the difference in survival was 7%. Let's say, was triple, was 6% in the standard of care arm as compared to 18% in those patients treated with chemotherapy plus durva, as you see in this updated overall survival slide. So therefore, very similar result in that setting. As you see here, all patient subgroups were benefiting from this therapy, and the magnitude of the benefit was very similar. That includes smokers, non-smokers, regardless gender, age, region, and even stage of disease. And more importantly, even brain metastases. Those patients with brain metastasis high diagnosis, they do have the same benefit as compared to patients without. And remember, some 10% of the patients had brain metastases that were not treated with radiotherapy. This is actually what we typically do. In a patient which is not very symptomatic, we typically start systemic therapy. And that was one of the benefits of the design of the Caspian trial. Those patients were allowed to start immediately systemic therapy. Consistently, other efficacy endpoints were again in favor of the experimental arm chemo plus durva. You see here, those patients that are having better progression-free over the long term are those patients on the durva plus EP, even those data were not significant, and the same is true in responses. Some 10% more responses, 58 versus 68. That is a numerical increase rather than a statistically significant one. And as you see here, long-term responders happen most of the cases on patients treated with chemo plus durva as compared to those with durva with chemo alone that were typically short-lived responses. Here is the safety. Safety, as we have seen as well with the TISO, no new signal. That is what we expected. On the chemo arm, the typical chemotherapy toxicity. On the chemo plus durva arm, the same chemo tox plus the typical side effect of PD-1 inhibition, including, as you see here, 20% of the patients, some immune-related adverse event, including some 5 to 7% of the patients with serious adverse event related to immune side effects. Importantly, there was no major impact in terms of mortality or treatment-related mortality due to the addition of durvalumab to chemotherapy here. So if we go on the analysis of this trial, we have seen improvement in survival and other efficacy endpoints, nice, or let's say favorable toxicity profile, and the third dimension is quality of life. And as you see here, for most of the symptoms items, there was a clear improvement for patients treated with platinum etoposide plus durva, and as you see here, time where global health status is maintained over time is always better on the durva arm as compared to the chemo alone arm. So I would say data that suggests quality of life is better maintained over time as compared to the other. So taking together all those two trials, I would say one trial typically validate the result of the other. Results are pretty consistent one trial to the other, even as you know, taking into account some small size trial with Nivo and another phase 3 trial with Pembro. Altogether, the data are very similar. The meta-analysis showed that there is a clear improvement in OS, hazard ratio 0.75, as you see here overall, and the same for PFS. I think even more importantly, if you look in all 4 trials, PFS survival at 2 years is very consistent, always in the range of 22-23% at 2 years. Remember, this is something like 3 to 4 times higher as compared to the data with chemotherapy, the data seen in the Cochrane analysis where survivorship at 2 to 3 years is in the range of 6%. Well, we have very similar data in terms of efficacy. Maybe we should, let's say, analyze if there were any difference in toxicity. I don't think there were, as we have mentioned. There were some, let's say, at least subtle difference in terms of design. And particularly for me, it's important to say that we have used 6 courses of chemo in the Caspian trial, in the control arm. We have allowed patients with brain metastasis without prior radiotherapy to enter in this trial as well. And maybe importantly, I think at least for me, we have used carboplatin in 3/4 of the patients, but cisplatin as well in some 1/4 of the patients included in the Caspian trial. And those were mainly the big difference for me, and maybe that have some application in the clinical practice. Okay, we have learned then that some patients, not huge number of patients, but some patients do have a clear benefit. The question then is, do we have biomarkers that select us which patients are benefiting so that we can choose to treat those patients only? Secondly, do we have any other additional treatment for patients that are not benefiting? Well, at this time, the answer is no for both questions. I don't think we have clear biomarkers. We have seen that PD-L1 is not predictive. PD-L1 expression is only present in some in tumor cells in some 5% of the tumors, in immune cells in 20% of the tumors, and is not predictive. Is not predictive in the Empower trial, is not predictive in the Caspian. The same is actually true when we're talking on TMB. TMB, tumor mutational burden, is not predictive of benefit from immunotherapy in this setting either. So the only thing I may add here is that now we have defined some transcriptomic subgroups. There is some updated classification on these transcriptomic subgroups based on major regulators of transcription, including NeuroG1, AXL-CL1, POE3. And there is a 4th group called inflammatory, where you see a clear upregulation on genes related to T cell response. and actually is specifically that subset of immune inflamed tumors that they derive more benefit, higher magnitude of the benefit as compared to the other subgroups, as you see here in this sub-analysis done by the group of Dr. Bayers in this sub-analysis of the Empower 133 trial recently published in Cancer Cell. So then the next question is what we can do so that we are improving the results in this setting, the result of PD-L1's addition to chemotherapy. And I would say one of the possibilities, could be to further regulate the DNA damage recognition and repair. We know this is an issue in that disease where there is a lot of dysregulation of cell cycle control because of mutation on p53, retinoblastoma, and so on. And we have seen that agents such as PARP inhibitors do have synergistic effect. They do activate the STING pathway. They actually increase the expression of PD-L1, and indeed that relates to some early data in clinical trials suggesting that there is maybe some synergy as well in terms of additivity, particularly maybe true in the subgroup of patients with an expression of 11, and I think that's a significant point as well. And of course, not only that subgroup, but maybe ATR inhibitors or CHEK1 inhibitors and drugs of the class may have a similar effect. The second drug, I'm just going to point out here as well, is another drug which is a major regulator of transcription, lurbinectedin, that had shown clear activity on its own and had shown activity in the different subgroups of small cell lung cancer, and it has shown additivity when is combined with PD-1 or PD-L1 inhibitors, as you see in this preclinical data. We have done actually phase 1 trial, an academic trial from my group, suggesting that in the second-line setting, and third-line patients that had received chemotherapy, if they are treated at the time of relapse with Lurbe plus Atezo, you're getting really nice responses. This is, of course, a small trial with only 21 patients at a time. Is being communicated. Responses were appreciated in some 58% of the cases, which I think is really good number. But more importantly, if you compare the duration of response, the PFS is actually better for most of the cases on those patients treated with Lurbe plus IO as compared to the initial duration of disease control during the first line treating with chemotherapy, platinum-based chemotherapy. So I think those data are really promising. The tolerance is pretty good as well. And as you see here, this concept, this strategy is now being further evaluated in another trial where in the maintenance setting, after chemo plus PD-L1 inhibition, PD-L1 inhibition is compared to Atezo plus lurbinectedin in this very setting. The final word, I think, in terms of what could be an interesting immuno-oncology strategy in small cell lung cancer is the tarlatamab drug. This is a BiTE that is actually binding this bispecific to the T cell by the CD3 receptor, and is also, of course, binding the tumor cell, binding to the DLL3. DLL3, as you know, is a ligand of the Notch pathway, which typically is expressed only into the cytoplasm, but in tumor cells, particularly small cell lung cancer, is overexpressed and is actually expressed on the cell surface. So it's really a very attractive binder to these strategies of T-cell engaging. And indeed, we have seen in the initial phase 1 trial that those results, the drug is pretty tolerable. You see some cytokine release syndrome during the initial courses, but as you see here, that happened in some 44% of the patients, but in most of the cases. Actually, in all cases, step 1 was only grade 2. Only one patient had in grade 3 cytokine release syndrome. So very, I would say, tolerable or favorable toxicity profile. Importantly, responses were seen in some 20% of the patients across doses, and at the highest dose that we have used, 100 milligrams, even the number of patients is pretty low. We have seen responses nearly in some 30% of the cases. So I would say that is some interesting data. This is some data that maybe is giving us some enthusiasm to see immunotherapy as something that we have to further explore in small cell lung cancer, a disease where still there are a number of unmet needs that we have to solve into the future. My final word is, what about limited disease? This is only happening in some 30% of the small cell lung cancer cases, but I think it's urgent the study of the role of immunotherapy in this setting. And indeed, the Adriatic trial is actually evaluating the role of Nivolumab in this setting in patients that had been treated with chemoradiation for limited stage. If they had no progression, patients are randomized to receive placebo versus Durva versus a second experimental arm with Durva-Treme. And there are some other trials as well with other PD-1 or PD-L1 inhibitors, which I think are of interest as well. So just let me finish, to summarize. I think at present, chemo-IO with PD-L1 inhibitors is the standard of care treatment for patients with extensive stage small cell lung cancer. I think we have to further explore the role of immunotherapy in this setting. We need good biomarkers that is selecting us which patients are benefiting from PD-L1 inhibitor, which patients are not benefiting. We need to also explore the role of immunotherapy in the limited stage setting, and still we have to combine, we have to further evaluate novel therapeutics. We have talked about the Tarlatamab drug, but also some interesting combination maybe related to PD-L1 inhibitors with a lot of anectidine, with PARP inhibitors, and with other agents, which I think are being addressed in ongoing trials. So this is very much what I have to say, and I'll be really happy to take any questions you may have from your side. Thank you.
Thank you so much, Prof. You have shown that probably you have mentioned 4 important clinical trials when it comes to the chemo immunotherapy, the Caspian trial and the Empower 133, also the other smaller trial for Pembro and Nivo. I was wondering because what's really seemed to be stand out as the trials when it comes to the size of patient population and the benefit and the magnitude of the benefit, it seemed that Atezo and as well as the Durvalumab, it's what's really stand out. And the question is really how to make those decisions as a clinician, as an oncologist, as also patient, when we make those discussion with patient, how to make those decisions when it comes to Durva, as well as Atezulusumab in combination with chemotherapy. You have highlighted some of important difference, although they are minor, but they are also existed, such as the flexibility of platinum when it comes to Durva, the maintenance treatment, it might be 4 weeks also with Durva rather than 3 weeks. Also, there is PCI allowed with Atezo. I'm not sure also if there is toxicity difference between Durva and Atezo, although it's quite difficult to make those conclusions since we have different clinical trials. How to make those decisions, how to choose between those, yeah.
Okay, so I think, first of all, let's go to the big things. The big things is that, I'm not sure Nivo or Pembro are any better or any worse as compared to Durva or Atezo, but the evidence is robust with Durva or Atezo, so that would be what I could use. Even maybe the other drugs are as good, but the evidence as today is for Durva and Atezo. The second thing important is one trial of, let's say, Durva is validating the result of the Atezulusumab trial and the other way around, because the results are very consistent. And this is always very nice to see. The third thing is that we have just very small differences, and I think you have to take them and comment them with the patient and see how you feel comfortable. So let's say we have no data with cisplatin plus Atezulusumab. We have data with cisplatin plus. So if that is something that you're going to use, I have to be honest, most of my patients, I use carbo in extensive stage because there are meta-analysis suggesting it's not any better. But you like to use that, and then you like to have more evidence, then maybe Caspian is your choice. But of course, I'm not saying Atezulusumab would be any worse in that setting. The only thing I say is that we have no those data as yet. The more important data for me is the untreated brain metastasis issue. Because, this is something we see very often. If you do an MRI to your patient, you see that maybe in 20% of the patients. Indeed, we're in some 10% here of the cases, but we were doing CT scans in many centers as compared to brain. So I think that happened very often. And in those patients, if they are not symptomatic, I never go for radiation because it's taking you some 2 weeks. So what I'm typically doing is just chemotherapy, straightforward. And this is what I'm doing. And that, I think, it was a nice thing of the Caspian trial. The good thing of the Atezulusumab trial is that they actually allow PCI to go concomitantly during the Atezulusumab treatment. We didn't do that in the Caspian trial because at this point, we have no data on concurrent treatment. We were afraid of neurotox. We were not sure. Anyway, to be honest, I never use PCI in extensive stage in my patients. The uptake, we have done recently like a physician quiz in Europe is some 5%, but I'm never using that prophylactically. So I think with this data, you mentioned another important factor, which is the time interval. Of course, during the maintenance phase, having to come to the hospital every 4 instead of every 3 weeks may be a benefit. Hopefully, we may even study into the future to do it every 6 or every 8 weeks with both drugs. And I think we should do it because patients are getting bored of coming to see us.
Yes, thank you so much. I was wondering when it comes to small cell lung cancer, which is quite difficult to understand in terms of biology. We do expect that it might be more immunogenic because it's a disease of a smoker. But when you come to the biomarker, the PD-L1 expression is not really much PD-L1 expression as what we do see with for example, non-small cell lung cancer, and the benefit also of immunotherapy, it's there, but it's not as striking as the way we see it in non-small cell lung cancer. And it's really quite difficult to see how we can make those decisions, especially how to select those who might benefit the most from those drugs from a biomarker perspective, and how to understand the biology and to look further into those who might benefit the most, and also minimize also the exposure for those who might really might not really benefit from immuno when it comes to small cell lung cancer. What do you thought about that?
Well, I think it's totally right that very often the microenvironment of small cell lung cancer is very immunosuppressive. We know that. So you look at the microscope, very few lymphocytes are found there for most of the cases. And you further study that in detail. We just recently have done a deep transcriptomic analysis, and most of the tumors are never inflamed, as compared to non-small cell lung cancer, where the proportion of inflamed tumors are much higher. So I think it is really important to analyze in detail which other strategies we may use in those patients. And of course, one typical which is of interest, is T-cell engaging. That is a way to do direct engagement of the T-cell without needing a clear presentation of the antigen, which is an issue in this disease. Often we do have down expression, down regulation of class 1 molecules, which is hampering antigen representation. And therefore, because also the bystander effect, you really activate T cells, then you activate all the others all around. The second strategy of interest is find new targets. A good one, I think, a potential good one is, for example, CD47 inhibition. That is an antiphagocytic signal in macrophages here in this setting. And small cell lung cancer is the tumor with higher expression of CD47. And I think this is something we should further evaluate. For example, there are some other strategy, of course, including cell therapeutics that for sure would be analyzed into the future, but still a lot of work to do, I would say.
Thank you so much, Dr. Bazaris, for such a nice review. I can see Dr. Talib Bahlega also eagerly waiting for the next satellite symposium. So thank you so much for that. And I think now we can move to the next satellite symposium. I would like to introduce Dr. Talib Bahlega. Dr. Talib is a medical oncologist and the head of medical oncology at Prince Sultan Medical City. The mic is yours, Dr. Talib.
Thank you.
Thank you, Dr. Abdullah. Thank you, Dr. Lewis. It's my pleasure to introduce this satellite symposium, which is sponsored by Roche. And also I would like to introduce Dr. Erika Philip. She's head of the thoracic cancer unit within the oncology department at the Vall d'Hebron University Hospital in Barcelona, Spain. Dr. Philip in charge of thoracic malignancy management and is responsible for the thoracic cancer trial undertaken by the oncology department. Dr. Erika, mic is yours. She will give us a talk about the new era in the treating of early non-small cell lung cancer.
So thank you for your kind introduction. It's a real honor for me to participate in this symposium. So as you mentioned, I'm going to review a new era in treating patients with early stage non-small cell lung cancer. You can see here my disclosures, a disclaimer. So today we are discussing patients with early stage disease, and according to the ESMO guidelines for these patients that are diagnosed with early stage disease, there is a need to perform a PET-CT for those patients with mediastinal lymph nodes negative in the PET-CT, and those patients with clinical N0 disease and peripheral tumors, we may recommend surgery upfront. For those patients with clinical N1 disease or central tumors or tumors greater than 3 centimeters, there is a need for mediastinum tissue confirmation with EUS or video-assisted mediastinoscopy. For those patients with mediastinal lymph nodes negative pathologically, surgery is a treatment of choice for those patients with pathological N2 disease diagnosed pre-surgery. Multimodality therapy is recommended. For patients with early stage disease, more than 15 years ago, the latest meta-analysis was published. For those patients with resected tumors, adjuvant chemotherapy with cisplatin was associated with an improvement in disease-free survival when compared to the control, with a hazard ratio of 0.84 and an absolute 6% improvement in 5-year disease-free survival for those patients receiving adjuvant chemotherapy. In this meta-analysis, adjuvant chemotherapy was associated with a better survival with a hazard ratio of 0.89 and an absolute 5% improvement in 5-year survival rate for those patients treated with adjuvant chemotherapy. And then there were a number of trials comparing in patients with early stage disease, preoperative chemotherapy followed by surgery or surgery alone. And there is also a meta-analysis published in Lancet in 2014, including 15 randomized trials, more than 2,300 patients. And this meta-analysis shows us that preoperative chemotherapy was associated with an improvement in overall survival when compared to surgery upfront, with a hazard ratio of 0.87 and an absolute improvement of 5% at 5 years for those patients receiving preoperative chemotherapy. However, we mentioned that probably adjuvant chemotherapy and neoadjuvant chemotherapy achieve the same results. But probably we are discussing or we are analyzing different patient population. NIGHT trial was performed by the Spanish Lung Cancer Group and published almost 12 or 13 years ago. And in this trial, patients with early stage disease with the clinical staging were randomized to receive surgery alone or preoperative chemotherapy followed by surgery or surgery followed by adjuvant chemotherapy. In this trial, patients included must have clinical stage 1A with tumor size greater than 2 centimeters, 1B, 2, or T3N1, but those patients with pathological end to disease diagnosed pre-surgery were excluded. However, when we analyze the pathologic stage at surgery for those patients with surgery upfront, we observed that 25% of the patients had pathological end to disease at surgery that were not identified previously with the clinical staging. So when we analyze again the ESMO guidelines, there are recommendations for adjuvant chemotherapy. Adjuvant chemotherapy should be offered for those patients with pathological N1 and pathological N2 disease, and should be considered for those patients with N0 disease, but with tumor size greater or equal 4 centimeters. For adjuvant chemotherapy, a 2-drug combination with cisplatin is preferable in 3 to 4 cycles. And when cisplatin administration is not feasible, carboplatin is an accepted alternative. And also the ESMO guidelines were updated last year with a recommendation of postoperative radiotherapy. We had the LUNG-R trial analyzing postoperative radiotherapy in patients with pathological N2 disease and complete resection. This is a negative trial, so the ESMO guidelines updated the recommendation on postoperative radiotherapy in patients with resected tumors, and now the recommendation is that postoperative radiotherapy in completely resected early stage 1, 2, or 3A non-small cell lung cancer is not recommended. There is also a major study published by Dr. Herbst in New England in 2020, analyzing in patients with stage 1B, 2, and 3A, complete resection and EGFR mutation, and including only the activating mutation. The study randomized, as you know, the patients to receive osimertinib or placebo for 3 years. And this is a positive trial for osimertinib. The median disease-free survival was longer with osimertinib when compared to placebo, and for patients with a stage 2 and 3A, the hazard ratio is 0.17. But now we have also a very important studies analyzing immune checkpoint inhibitors in patients with resectable disease. And now I'm going to review the 2 trials in the adjuvant setting with results, the IMpower010 and also the PEARLS KEYNOTE-091, and also the CheckMate 816 trial analyzing preoperative chemo plus immunotherapy. Let's start with the IMpower010. In this trial, 1,280 patients with completely resected stage 1B with tumor size of at least 4 centimeters, 2 and 3A, according to the 70NM classification, receive at least one, but not more than 4 cycles of cisplatin-based chemotherapy combination. The chemotherapy used was decided by the investigator, and cisplatin pemetrexed, cisplatin gemcitabine, cisplatin docetaxel, and cisplatin vinorelbine were schedules allowed in the protocol. 1,005 patients who still meet eligibility criteria after adjuvant chemotherapy were then randomized to receive Atezulusumab for 1 year or no further treatment. In this trial, stratification factors included gender, stage, histology, and PD-L1 status. And the primary endpoints were investigator-assessed disease-free survival tested in a hierarchically way. First, for those patients with stage 2 and 3A and PD-L1 positive tumors, according to the SP263 antibody, if positive in all randomized stage 2 and 3A population, irrespective of PD-L1, and if positive in all patients included, including patients with stage 1B disease. Key secondary endpoints include disease-free survival in stage 2 and 3A and PD-L1 50% or higher. So as we mentioned, 1,000 patients were included, and when we analyze the clinical characteristics, so the baseline characteristics for these patients, we can see that the median age is 62. There are 67% of the patients included male, 34% of the patients had a squamous cell carcinoma tumor, and we have 40% of the patients with pathological stage 3A disease. Approximately 78% of the patients underwent lobectomy, and PD-L1 tumor was negative in 45% of the patients. Atezulusumab in the adjuvant setting was well tolerated. When we analyze treatment-related serious adverse events, occur only in 7% of the patients. Treatment-related grade 5 adverse events in 0.8% of the cases, and adverse events leading to Atezulusumab discontinuation in 18% of the patients. You can see here the primary endpoint in the 3 study population. For those patients with stage 2 and 3A and PD-L1 positive tumors, Atezulusumab was associated with a longer disease-free survival when compared to the control arm, with a hazard ratio of 0.66. At 3 years, there are 60% of the patients disease-free in the Atezulusumab arm, 48% in the control arm. When we analyze all randomized stage 2 and 3A population, irrespective of PD-L1, the study is also positive. The hazard ratio favoring Atezulusumab is 0.79, and you can see that at 3 years, there are 56% of the patients disease-free in the Atezo arm, 49% in the control arm. And in the intention to treat analysis, including patients with a stage 1B, that were approximately 13% of all the patients included, 2 and 3A, in this analysis, the hazard ratio is 0.81. The statistical significance boundary was not crossed, and there is a need for longer follow-up. When we focus in the group of patients with stage 2 and 3A, we can see that there are different results according to the PD-L1 staining. For those patients with PD-L1 positive tumors, we have mentioned the hazard ratio is 0.66. For those patients with PD-L1 negative tumors, the hazard ratio is 0.97. In a post-hoc analysis, not pre-planned, for those patients with PD-L1 between 1 to 49%, the hazard ratio is 0.87. And for those patients with stage 2 and 3A and PD-L1 50% or higher, the hazard ratio is 0.43. When it was presented at ASCO and also published, the overall survival is not mature and should not be formally tested. We need to wait for a longer follow-up. And the conclusion during the ASCO and also in the Lancet paper is that IMpower010 show a disease-free survival benefit with Atezulusumab versus the control arm after adjuvant chemotherapy in patients with resected stage 2 and 3A, with pronounced benefit in the subgroup whose tumors express PD-L1 on 1% or more of tumor cells, and the greatest magnitude of benefit for those patients with tumors with PD-L1 50% or higher. There are 1,280 patients that were enrolled and started chemotherapy. And finally, there are 1,005 patients were subsequently randomized between Atezulusumab or the control arm. And Dr. Al-Turki presented during the World Conference the study discontinuation reasons for these 275 patients who were not randomized between Atezulusumab or control. The most important was the withdrawal by subject in 31% of the cases, disease relapse in 19% of the cases, and adverse event in 12% of the cases. The vast majority of patients were treated with chemotherapy with cisplatin vinorelbine in 303 patients, cisplatin pemetrexed in 385, and there are 152 patients that were treated with cisplatin docetaxel and 165 with cisplatin gemcitabine. And also, Dr. Al-Turki presented during the World Conference a subset analysis for patients with stage 2 and 3A and PD-L1 positive tumors. The hazard ratio is similar for those patients with stage 2A, 2B, and 3A. The hazard ratio is 0.63 for those patients that undergo lobectomy. It was 0.83 for those patients that underwent a pneumonectomy. And the hazard ratio was similar according to the chemotherapy regimen used, around 0.55 and 0.66. However, for patients receiving adjuvant cisplatin gemcitabine, the hazard ratio is 1.14. However, the patients were not stratified according to the chemotherapy regimen used, and also this is a small sample of patients, only 75 patients included in this subgroup. We presented at ESMO the percentage of patients with disease relapse as a disease-free survival event. Overall, we have seen that the disease relapse was higher for those patients in the control arm when compared to the Atezulusumab arm. And this difference was somewhat higher for those patients with stage 2 and 3A and PD-L1 positive tumors. In this group, 44.7% of the patients had disease relapse in the control arm, 29% of the patients in the Atezulusumab arm. And also, we analyzed the patterns of relapse for those patients with disease recurrence. And the patterns of relapse, when we analyze locoregional only, distant only, locoregional and distant, or CNS only, were similar for those patients with disease relapse in the Atezo arm or in the control arm. We updated the analysis during the ELCC meeting of those patients with stage 2 and 3A and PD-L1 50% or higher. When we analyze this subgroup of patients, disease relapse occurred in 44% of the patients in the control arm, 22% of the patients in the Atezulusumab arm. And we have seen some differences in the patterns of relapse in this group of patients of PD-L1 50% or higher. Distant relapse occurs in 9% of the patients in the Atezo arm, 26% of the patients in the control arm. CNS only relapse occurs in 1% of the patients in the Atezulusumab arm, 6% in the control arm. And you can see here the figure of disease-free survival for those patients with stage 2 and 3A and PD-L1 50% or higher. Median disease-free survival was not reached with Atezo. It was 35 months in the control arm. There are 73.8% of patients disease-free in the Atezulusumab arm at 3 years, 48% in the control arm. We have mentioned there is another trial presented just by Dr. Pasares during the ESMO virtual plenary in March 2022, that is the PELS Keynote 091 trial. In this trial, the same patient population was included. In this trial, adjuvant chemotherapy was not mandatory. However, adjuvant chemotherapy should be considered for those patients with stage 1B with tumor size of at least 4 centimeters, and it was strongly recommended for patients with pathological stage 2 and 3A, and it was limited to up to 4 cycles. Then patients were randomized to receive pembrolizumab for 1 year or placebo. In this trial, stratification factors included disease stage, PD-L1, receipt of adjuvant chemotherapy, yes or not, and the geographic region. And the trial has 2 primary endpoints: the disease-free survival in the overall population and the disease-free survival in PD-L1 50% or higher population. We mentioned 1,100 patients were included. The median age is 65. There are 30% of patients with pathological stage 3A disease. There are approximately 65% of the patients with non-squamous histology. And there are 14 patients included that were not previously treated with adjuvant chemotherapy. PD-L1 negative tumors were observed in 39% of the cases. When we analyzed adverse events, were similar of what we have observed in the IMpower010 trial. The grade 5 treatment-related adverse events were seen in 0.7% of the cases. Adverse events leading to treatment discontinuation in 19.8% of the cases. And you can see here the 2 primary endpoints. For the overall population, disease-free survival was longer with pembrolizumab when compared to placebo, with a hazard ratio of 0.76. The median disease-free survival in the pembrolizumab arm was 53.6 months. In the placebo arm, it was 42 months. In the analysis of patients with PD-L1 50% or higher, the difference are not statistically significant. The hazard ratio is 0.82. The median disease-free survival in pembrolizumab arm was not reached, even it was not reached in the placebo control arm. When we analyze the subset analysis in these patients included in Keynote 091, the hazard ratio for those patients with pathological 1B disease was 0.76. For patients with stage 2, 0.70. For those patients with stage 3A disease, the hazard ratio was 0.92. For those patients without prior adjuvant chemotherapy, the hazard ratio was 1.25. For those patients with prior adjuvant chemotherapy, the hazard ratio was 0.73. For non-squamous, a hazard ratio of 0.67. For squamous histology, 1.404. And for those patients with PD-L1 negative tumors, the hazard ratio was 0.78. For PD-L1 between 1 to 49%, a hazard ratio of 0.67. For those patients with PD-L1 50% or higher, hazard ratio of 0.82. It was also that for a small group of patients with EGFR mutations, the hazard ratio is 0.44. As you know, there are other adjuvant trials pending the results. We have the ANVIL trial analyzing adjuvant Nivolumab, also the VR31 trial analyzing adjuvant Durvalumab, and also the Alchemist trial that in the adjuvant setting is analyzing chemotherapy alone or chemo followed by pembrolizumab, or the combination of 4 cycles of chemo plus pembrolizumab followed by pembrolizumab. There are also studies analyzing neoadjuvant strategies, and we have results published recently of Checkmate 816. In this trial, patients with newly diagnosed resectable stage 1B with tumor size of at least 4 centimeters, 2 and 3A according to the 7 edition, but this is a clinical staging, were randomized to receive chemotherapy 3 cycles followed by surgery, or 3 cycles of chemotherapy plus Nivolumab followed by surgery. In the postoperative scenario, optional adjuvant chemotherapy plus minus radiotherapy could be considered. And the trial has two primary endpoints. The pathological complete response, according to the blinded independent pathological committee, and also the event-free survival, also by a blinded independent committee review. 179 patients received chemo plus Nivo, 179 chemotherapy alone. Perhaps to mention that there are 63% of the patients with clinical stage 3A disease diagnosed pre-surgery, with a clinical staging. We can see that in the Nivo plus chemotherapy arm, 83% of the patients had definitive surgery. And we know that pathological complete response is higher in the chemo plus Nivolumab arm, 24% of the cases versus 2% of the cases in the chemotherapy arm. In this analysis, for those patients with PD-L1 negative tumors, the combination of chemo plus Nivo was associated with a pathological complete response rate of 16% of the patients. For those patients with PD-L1 50% or higher, it was associated with a pathological complete response of 44.7%. And we know also data of event-free survival. Event-free survival was longer with chemo plus Nivolumab when compared to chemotherapy alone, with a hazard ratio of 0.63. So we have trials in the adjuvant setting and also in the neoadjuvant setting. The clinical trial endpoints are different. In IMpower and in Keynote, the disease-free survival is the primary endpoint in both trials. There are some differences. In IMpower 010, this is an open-label trial, and the first endpoint, disease-free survival, was investigator-assessed and was tested hierarchically, as we mentioned, in stage 2 and 3A and PD-L1 positive tumors, then in all randomized stage 2 and 3A, and then in a stage 1B, 2, and 3A. In PELS or Keynote, there is a placebo-controlled study, and we have two primary endpoints, disease-free survival in the overall population and disease-free survival in PD-L1 50% or higher. And in Checkmate 816, we have mentioned pathological complete response, that the definition is no residual viable tumor cells in the primary tumor and lymph nodes was assessed by a pathology central review. But again, we think that probably the patients included in the trials with adjuvant strategies and neoadjuvant strategies are not exactly the same. In the adjuvant immunotherapy trials, all patients have had surgery for definition. Randomization was after surgery, and there are a number of patients with pathological end-to disease, but probably are patients not identified pre-surgery. And in the neoadjuvant immunotherapy trial, in the Checkmate 816, there are patients with clinical stage 3A and 2 included, and represents 63% of the patient population. In the three trials, there are a number of patients that were assessed for eligibility, and then there are a number of patients with study discontinuation, and probably there is an interest to further analyze these issues. And also for those patients that now are being included in phase 3 of neoadjuvant strategies in the trials, the IMpower 030, Keynote 671, IASIAN, and Checkmate. These are randomized trials in patients comparing preoperative chemo plus immuno followed by surgery or surgery alone. In all these trials, in the patients randomized to chemo plus immunotherapy in the preoperative setting, these patients will receive immunotherapy in the adjuvant phase. Now, testing is relevant and probably is not the same to test the patients with a diagnostic sample or with a surgical specimen. This is something that probably we need to analyze also in a prospective way. Even in the Checkmate 816, in which there was a need to send centrally the tumor a diagnosis, it was mandatory in the clinical trial. There are 7% of the patients in which PD-L1 expression was not be able to be evaluated. But we know now that in patients with a stage 4 disease, the determination of PD-L1 with 22C3, 28.8, and SP263 have a high concordance, and probably this is the same situation in patients with a stage 4 disease. Last comment about circulating tumor DNA. The IMpower010 trial analyzed circulating tumor DNA samples just before starting adjuvant chemotherapy. We have seen that the percentage of patients with circulating tumor DNA positivity was higher in patients with pathological stage 3A when compared to stage 1B. And also we have seen that probably the presence of circulating tumor DNA positivity was prognostic. However, both groups, those with positive circulating tumor DNA after surgery and those with negative circulating tumor DNA, benefited from adjuvant Atezulusumab. So let me just finish by saying that immunotherapy will be a standard of care for those patients with early stage non-small cell lung cancer, EGFR and ALK wild type. I have the opinion that probably adjuvant and neoadjuvant strategies are covering in some way different patient population. We need patient and tumor-specific biomarkers to predict benefit of immunotherapy. Circulating tumor DNA technology may help perhaps in the future to individualize therapy, and we need to focus on long-term survivors' needs. And thank you so much for your kind invitation. Thank you.
Thank you so much, Dr. Enriqueta. I have just a question. How do you identify a patient best management for them if they need neoadjuvant or adjuvant? Or let's say, how do you identify the best fit patient for neoadjuvant or adjuvant immunotherapy, considering if it is available both?
Yeah, thank you for the question. I think with the information that we have now, at least in my clinic, for those patients diagnosed with clinical stage 1 and 2 and are candidates for surgery, I think surgery is a good treatment strategy. And after that, we analyze the role in each case, considering PD-L1 and also the pathological stage of adjuvant chemotherapy and also immunotherapy. In my opinion, neoadjuvant chemotherapy plus immunotherapy should be a standard of care for those patients with stage 3A and 2 disease diagnosed pre-surgery. In fact, in these patients in the past, at least in my institution, we used to recommend chemotherapy pre-surgical resection. So I think now with the information that we have of Checkmate 816, probably neoadjuvant chemo plus immuno for those patients with clinical stage 3A and N2 disease pre-surgery, and for those patients that are diagnosed with stage 1 and 2, surgery is the treatment of choice, and then adjuvant chemotherapy for those patients with pathological N2 and N1 disease and tumor size greater than 4 centimeters, and in my opinion, adjuvant Atezulusumab for those patients with a pathological stage 2 and 3A and also PD-L1 positive tumors.
Thank you, Dr. Enriqueta.
I will just go for one question, please, Dr. Talib.
If you just let me to comment about this one. Yeah, I think so. The same, I agree with you, Dr. Enriqueta, about the choosing neoadjuvant versus adjuvant setting. But I think so, the neoadjuvant setting, at least the more patient they tolerate this treatment and they receive it more than the adjuvant setting after the chemo, after the surgery. So I think this is only the advantage, and of course to downsize the tumor to make it more feasible for surgery. Okay, go ahead, Dr.
Thank you very much, Professor Filippi, for excellent presentation. My question regarding the Pearl study, that's the confusing data regarding the PD-L1 high positivity more than 50%. We get used that the PD-L1 is a predictive in Pacific study and also on IMpower010. And this goes what we had before regarding IO therapy and adjuvant and neoadjuvant therapy. So how do you explain the confusing data regarding patient with more than 50%? And I think it's proven the concept of the rule of adjuvant, but also confusing in the meantime. Thank you.
Oh, yes, I agree. I think when we saw the results of Keynote 091, so at least for me, it was unexpected, the results in patients with PD-L1 50% or higher. So this is the reality. What we know in patients with a stage 4 disease is that PD-L1 is predictive of monotherapy benefit. But this is what we have seen. There are some differences between Keynote and IMPOWER. It's true that when the investigators of Keynote presented the results in PD-L1 50% or higher, they include all patient population, stage 1B, 2, and 3A. And in IMPOWER, we have PD-L1 50% or higher in patients with stage 2 and 3A. But I don't have any clear explanation. We will have more trials in this scenario, and also we can see the results according to the PD-L1 status, and perhaps there is also a need for longer follow-up. I have seen in the ASCO, probably there will be an update of some information in the Keynote 091, but I was surprised of the results in PD-L1 50% or higher.
Thank you, Enriqueta. I do have also a burning question regarding stage 1B, which was included in IMPOWER 010. So if you do have one patient, stage 1B, high-risk population, PD-L1 positive, do you will give them Atezo as the patient is high risk? Thank you.
Very good question. I think when we analyze, in fact, the hazard ratio between IMPOWER and Keynote, including all the patients, stage 1B, 2, and 3A, the hazard ratio is similar, is 0.81, 0.79. But it's clear that I think we need to treat the patients according to the results of the clinical trials. I have to say that at present, we don't have a statistical significant positive data in IMPOWER for patients with stage 1B disease. There is a need for longer follow-up, and I think this is planned, and probably later this year we'll have more information. But at present, I think that what we have seen in IMPOWER is the results for patients with stage 2 and 3A disease.
Thank you a lot, because we are running behind the time, and we have now break for around 10 minutes. Okay. Thank you, Dr. Enriqueta. Thank you, Roche, for the satellite symposium. We will end the lung session, and after the break, we will start the breast session. Thank you.
Thank you. Thank you. An honor to be here. Thank you so much.
زين علامة كويسة.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى صحبه أجمعين. السلام عليكم ورحمة الله وبركاته. Good evening, ladies and gentlemen. It gives me great pleasure to introduce the next session, which will be for breast cancer. We have very eminent speakers and interesting topics, which was picked up by the organizing committee. Allow me to start with introducing the chairpersons of the session. The first one is Dr. Majid Al-Jahil. Majid is the director of oncology department at King Fahd Specialist Hospital in Medina Al-Munawwara, MOH. Majid is a well-known figure in Saudi Arabia with a special interest in breast cancers and GU cancers. Together with Dr. Aisha Al-Harbi. Aisha is a consultant medical oncologist at King Fahd Armed Forces Hospital in Jeddah so far. And she is with the wide clinical experience, especially in the field of breast cancers. And last but not least, my brother and colleague, friend, Dr. Talib Bouhlega. Talib is head division of medical oncology at and consultant medical oncologist at Prince Sultan Medical Military City in Riyadh. So, and now I leave the floor to the chairpersons. We'll start with Dr. Al-Jahil. Majid, please go ahead. Thank you very much. And I'd like to remind you, please, before we start, to keep up with the time. And I have an announcement, sorry, that I forgot to say. Alhamdulillah, we have exceeded 10,000 participants, 5,000 on the Zoom, and more than 6,000 on the YouTube. So it's almost more than 11,000 viewers. Thank you very much. Majid, please.
Thank you, Dr. Assam, for the introduction and for your kind invitation. And thank you to the organizing committee. And congratulations for arranging such a successful meeting in the 6th year in a row. It's my honor and a pleasure to introduce our first speaker in this session, Prof. Lee Zakari. Prof. Lee Zakari is a professor for breast cancer research and in Division of Oncology and Deputy Director of Clinical Science in Limburger Comprehensive Cancer Center. She will give us a talk about IO in metastatic triple-negative breast cancer. Is it standard of care and what is the best chemo backbone? Prof. Kari, the mic is yours.
Thank you, Dr. Al-Jahil. Can you hear me okay?
Yeah.
Excellent. All right, I will share my screen. It is a great pleasure to speak to this wonderful group. Are you seeing one slide? Are you seeing the presenter mode, or is it good? One slide or two slides?
Yeah, we can see the slides. Yeah.
Okay, just the one slide.
No, the whole slide. In the show mode. Yeah.
Okay, perfect. Thank you so much. Well, it is a great pleasure. It's an incredibly impressive number of people who are participating, and I hope to bring some value in talking about immunotherapy in the metastatic setting for triple-negative breast cancer. These are my disclosures. So it's worth noting, again, this is a pan-cancer, element, and breast cancer compared to other tumors is actually less immune activated than many. And I call your attention to the far right-hand side of the screen, and you can see melanoma, for example, and many lung cancers have a lot of somatic mutations. Breast cancer has relatively fewer, but among breast cancers, the immune activation levels is highest in triple-negative breast cancer, and this is true regardless of what methodology you use to assess immune activation, whether it's TILs or PD-L1 status or gene expression arrays. So, of course, because of this, in breast cancer, triple negative was weighted into the immune checkpoint inhibitor arena relatively early for breast cancer, not early for other tumor types. And I'm going to summarize. You can see some of the trials using different agents on the right-hand side, and I'm going to summarize the findings on the left, which is basically Monotherapy has only modest activity, even in triple negative breast cancer. It is augmented in PD-L1 positive tumors, and we'll talk about that a little bit more. It also is augmented in early, and the more naive, the better in terms of response to therapy. So let me talk a little bit about, the one largest trial that tested this paradigm, because I think it teaches us a couple things, is KEYNOTE-119, which was pembrolizumab versus chemotherapy in the pretreated setting in triple negative. You can see it's pembrolizumab versus chemotherapy of various flavors with an endpoint of overall survival in various subsets of CPS scoring, which is the 22C3 antibody test. So if you look in the upper left-hand side in the intent to treat population, there was essentially no difference between chemotherapy or single agent pembrolizumab, but you can also see a splitting of the curves as you start to move up into a more immune activated subset of triple negative patients. Now, it still is not significant until you get to an exploratory subset of CPS of at least 20. Now, that's a very high number for PD-L1 testing. It's only relevant in less than 20% of patients. But in an exploratory analysis, you can see a hint that the immune checkpoint inhibitor would outperform chemotherapy in that group. And I think there's something to be taken home and a reason for the way we approach breast cancer, triple negative breast cancer treatment from the standpoint of ICIs. If you look at, I'm just going to hop through. If you look at the likelihood, so it's a small minority that are very, very highly immune activated, they have a higher response rate and better survival with evidence of single agent benefit. Again, this was an exploratory standpoint. But you should also know that the CPS 20 is also overlaps with those that are TMB high, which in the US, that's actually an indication by itself, regardless of tumor type, for single agent ICI. For the rest, it really doesn't work all that well. So this is where we get into combination therapies. So how do you improve on immunotherapy as a single agent? Well, there are a number of ways to improve on immunotherapy. You can see sort of the cycle there and all of the potential approaches to trying to augment responsiveness to immunotherapy. The highlight on the bottom, of course, is with chemotherapy, radiation and targeted treatments are the ways of trying to get the release of cancer cell antigens. That's the furthest along from the clinical standpoint, what I'm going to talk about primarily. So what's the rationale for adding chemotherapy to ICI? It's really twofold. One is to release antigens to stimulate immunogenicity. And the second is that chemotherapy tends to reduce regulatory T cells. Now, you want to try and choose chemotherapy that reduces regulatory T cells more than other effector and other types of T cells, but that's in fact one of the advantages of certain chemotherapies. You're trying to make basically a tumor microenvironment more favorable for immune checkpoint inhibitor function. So this table is only important because it's part of a compendium. I'm really going to focus on the randomized trials on the bottom that are in the first line setting. If you look at the single agent, single arm trials on the top, you can see not a very impressive level of activity in these pre-treated patients, but in the first line setting is where all of the advantages have been seen. So let me take them one by one. This is Impassion 130, which again, these are all first-line metastatic triple negative trials. This one has a backbone of nab-paclitaxel with or without atezolizumab, with primary endpoints of PFS and OS, or co-primary endpoints. On the left, you can see the PFS at 18 months that was updated a little after the primary presentation, and you can see essentially no impact in the PD-L1 negative. This is by the SP142 antibody in the immune cell. So that's the IC negative, no effect of adding atezolizumab, but you do see an effect in any PD-L1 positive subset, IC low and IC high. And if you look in the forest plot, you are similarly seeing that in a little more numerical way. So, take home messages from this, and to be frank, other studies like this, is that PD-L1 status matters in the metastatic setting. And this is converse to the early triple negative setting, in which, first off, PD-L1 status is almost always positive. It's more than 80% positive. And secondly, it doesn't seem to matter very much. Here it does matter, and it's much, much lower. So it's about half the likelihood of in the early setting, only 41% in this particular setting, and 14% of those were very high. So that gave you a 3-month progression-free survival advantage, which was in fact statistically significant. Now let's look at the overall survival. So this is now a little bit later analysis at 20 months. You can see a fairly impressive splitting of the overall survival curves pretty immediately with a delta, so a difference between the Atezo and the non-Atezo arms of 7.5 months. And it's worth noting that this and in other studies, the overall survival difference tends to be greater than the progression-free survival difference, which is different from what we typically see with other tumor-targeted agents. There was no impact in PD-L1 status negative group. We need to talk about the adverse events of special interest, as we have, incorporated the ICIs into our conventional therapy, both early and metastatic setting. We of course have to start monitoring differently, and I'll talk about that a little bit later. And this particular trial was fairly typical, not too many grade 3s, but the typical unusual things that we don't normally look for with a chemotherapy alone, namely thyroid, and sometimes really harder to manage things like pneumonitis, colitis, adrenal insufficiency, et cetera. And in truth, you have to stop treatment about twice as often if you have an ICI containing regimen than otherwise. So that seemed pretty good, and that's what gave us in the US, we had Atezo approved pretty quickly by the FDA in that setting. Not long thereafter was the presentation of Impassion 131, a very, very similar trial, except that the chemotherapy backbone was paclitaxel instead of nab-paclitaxel. Otherwise, very similar, the primary endpoint PFS. However, a very different result. And so here's PFS in the PD-L1 positive standpoint as assessed by the investigator, which was the primary endpoint. Again, very similar proportion that were PD-L1 positive, 45% versus 41% in the previous study, but really not much of an impact until maybe a hint of a split later on in the course. When they updated it was 7.2 versus 6.4 months, but at the primary analysis, you can see not only a less than a 1 month difference. Interestingly, survival favored the control arm, oddly enough. It's also an oddly good prognosis for this particular group of patients. So I think there's some question about exactly why this tumor group behaved the way they did. Regardless, it was a flat out negative trial. There's a couple of reasons that people have surmised for why this might be. I think one of the ones that was assumed at the time to be relevant was the fact that steroids were used consistently in Impassion 131, although they were recommended to drop it out over time, people generally didn't. The populations were otherwise fairly similar in terms of age, percent that were PD-L1 positive, percent that were de novo, visceral involvement, et cetera. But as I mentioned earlier, the survival in the placebo arm of 131 was unusually long. And the last thing, of course, is that these are not, the 95% confidence intervals for these trials did overlap, and it's possible that this is simply the play of statistical chance. So a little more light was shed with Keynote 355. So now this is, again, a very, very similar trial, except that the chemotherapy backbone could be one of 4 different agents or 3 different regimens and 4 agents with or without pembrolizumab rather than Atezulusumab. Dual primary endpoints for PFS and OS in the PD-L1 positive group as measured by CPS status. So here is that primary endpoint. You can see the hazard ratio of 0.65 and a substantial improvement of about 4 months in progression-free survival in favor of adding pembrolizumab. If you looked at the CPS greater than 1, so a more relaxed criterion for PD-L1 positivity, you did not see a statistically significant difference. It was just in the CPS 10, which is in fact how it was approved in the US. So looking at the chemo backbone, that was one of the questions that came to me. I'm going to tell you in advance, it's a very hard question to answer, but I'm going to make a run at it. So here are the subgroups within, again, the group in which the drug seemed to have its biggest effect. You can see the chemotherapy arm. Both the taxanes seem to do fairly well. And interestingly, I'll point out that the paclitaxel was not used very often, but in that subset, there is a hint that it seems to be working fine. Again, this is the converse to what was seen in Impassion 131 with Atezo. The gem carboplatin doublet seemed to have less of an impact of pembro in that group. These are investigator-chosen chemotherapy, so there may be some selection bias going on there. Overall survival in this trial was reported at ESMO last year with a 7-month difference, again, larger OS difference than there was a PFS difference and a hazard ratio of 0.73. That's only in the PD-L1 positive CPS10 group. There was no benefit in the PD-L1 low or negative groups. So I've summarized what I just said because I think people scratch their heads a bit on the differences amongst these trials with 2 positive and 1 truly negative. And essentially, as I mentioned earlier, there isn't a huge difference amongst them. The one thing that you might notice is, other than there is, of course, a difference in the way the chemotherapy is set up, the number of highly involved sites was greater in Keynote 355. On the other hand, they had less prior chemotherapy in the early setting of the same class that was used in the Keynote trial. And then truth, if you put together chemo naive of various flavors, either because of de novo or because they were just treated less, there does seem to be more of an effect, and perhaps that's playing a role. I mentioned IRAEs, and I do want to talk about that a little bit more fully, simply because for us in the breast cancer universe, this has been a big change in our normal monitoring processes, both in the early setting and in the metastatic setting. So for thyroid of various flavors, both hyper and hypo, that happens about 20% of the time, seldom grade 3 or greater, but obviously is problematic for our patients and can be quite symptomatic, and there's regular monitoring for that. You also will pick up adrenal insufficiency to some degree, although many of us do obtain baseline ACTH and cortisols in high-risk patients. It is rare, although some believe that in truth we're just underdiagnosing it because adrenal insufficiency tends to have relatively nonspecific symptoms. There's, of course, rashes that are not common, but can be very unpleasant for the patient. And then on the bottom, I think, are the things in aggregate that are relatively uncommon, but we all see them. And they are, in fact, the things that oftentimes cause us to need to stop the drugs, give steroids, and manage actively. So these are all super important to build into your chemotherapy protocols for monitoring. So I also have mentioned as part of this that the PD-L1 testing has been, problematic. I think, we're all we're calling it a work in progress, but in truth, we have multiple drugs, multiple diagnostic tests, and multiple cell types that are being tested with different processes for calling it positive on the basis of the immune cells, the tumor cells, or both. And across multiple tumor types. So of course, what that gives us is multiple sources of heterogeneity. And I do think that this is something that as a community, we need to probably help, we and our pathologists need to help solve the problems of a more uniform, optimized approach to PD-L1 testing, and harmonizing this, I think, should be a very high priority across all tumors in the near future. Some idea of performance came from Hope Rugo and colleagues working within the Impassion 130 trial, where they actually tested a variety of antibodies. I'm showing you here the SP142 and 22C3 concordance data and the hazard ratios as they relate to PFS. And you can see the SP142, which was in fact the assay, the companion diagnostic used for this study, did seem to perform well in both 22C3 positive and negative. 22C3 by itself did not seem to contribute as much. But again, this is the companion diagnostic for Atezo. I would encourage those running trials of other tumors to do a very similar analysis so that we can start to harmonize. I'm not showing you the SP263 data, but to be honest, it looks almost nearly identical. And the optimized approach, I would say, is not yet clear, which I think you've heard from previous speakers also. So let me talk a little bit briefly about chemotherapy. I'd like to call your attention to a really interesting study called TONIC, which just highlights to me the fact that we, not all chemotherapy is the same, but also that we don't really know what the optimal approach is. So TONIC was a phase 2 study of induction chemotherapy given for 2 weeks. So it really was an induction to try and change the microenvironment prior to giving Nivolumab as a single agent. So this is more or less pre-treated triple negative breast cancer. It was not designed to be a comparative study. It was a pick a winner kind of study. And they wanted to test a couple of different approaches to that, all of which had preclinical data supporting them for inducing a favorable microenvironment. with either radiation, cyclophosphamide, cisplatin, or doxorubicin. And here are the results, which I think are intriguing. Again, this is a small study, but it is thought-provoking. What you can see is that, compared to no induction, radiation and low-dose cyclophosphamide actually did not perform very well. Cisplatin and doxorubicin performed much better in terms of subsequent clinical response to single-agent Nivolumab. They did actually look in responders compared to non-responders and see that gene expression signatures that were considered, immune activated, or in this case hot, were elevated, as were clonal T cells. And I think the idea of induction is one that's worthy of further pursuit. What else can we say about chemotherapy, and what lessons do we have? So I've shown you the metastatic data, but let me also highlight there's some variability in the neoadjuvant setting that might give us a little bit of insight. You can see here 4 neoadjuvant trials with or without various types of immune checkpoint inhibitors. And you can see that the chemotherapy backbone, it varied to some degree. So Keynote 522 is the seminal one that in fact is the reason for pembrolizumab approval in the early triple negative setting. It used 4 drugs, so there's not much tailoring going on there. The other 3 trials used different flavors, and the one that had the poorest augmentation of pathologic complete response is actually the one trial, NeoTrip, that omitted the anthracycline. So, if the tonic data are to be believed, then it may be that anthracyclines are particularly important as part of this. I think that's worthy of testing, and I wouldn't take it, I would take it with some grain of salt, but I think it's very, very intriguing. So what are my summary thoughts about treating first-line metastatic triple-negative breast cancer? So regarding the chemotherapy backbone, I've shown you some scientific data, but I would say stick to the existing data. If you're going to use Atezulusumab, I would use nab-paclitaxel as a backbone for obvious reasons. That's what the Impassion 130 showed as beneficial. And using paclitaxel has been demonstrated as less effective. If using pembrolizumab, I still think nab-paclitaxel may be the best choice. And the reason for that is, you still have the concern about paclitaxel from the Impassion 131. There was too small of a subset in Keynote 355 to make too much of it being safe in that setting. And the gem-carbo backbone seemed to have less effectiveness of the ICI when added there, recognizing, as we all must, that these were selected populations, and so they may differ in ways that we don't understand. Now, studies in other tumor types allow other combinations. We don't have data in breast cancer yet, and I think I put e.g. capecitabine, not because it's relevant in this talk for metastatic setting, although it may be a little bit, but it's mostly particularly important for the adjuvant setting in early triple-negative breast cancer that are now, except for the smallest node negative ones, uniformly treated with immune checkpoint inhibition. Now, I mentioned some of the other combination approaches that are coming. We talked about chemo and briefly about radiation and tonic, but realize that some of the really exciting combinations are with PARP inhibition, with ADCs, and other approaches to try and stimulate a hot microenvironment that will be coming. I want to thank you very much for your attention.
Thank you, Dr. Carey, for your kind and excellent presentation. We have 2 or 3 minutes for a question. I can start a question from my side. Do you think that the role of paclitaxel, which more installed and more the efficacy is more appear in breast cancer and triple negative breast cancer than nab-paclitaxel, which affect the result between the 2 trials in the Impassion 130 and the Impassion 131. It's the paclitaxel is more potent, which affect the result of the statistically affect the result of Atezulusumab.
So it's a really interesting question. I mean, we did see, you did, and I think you're also noting the unusually long survival in that group. the reality is that there have been studies comparing, separate from ICIs, comparing paclitaxel and nab-paclitaxel, and they have uniformly been found either to be equivalent, or actually in the neoadjuvant setting, nab-paclitaxel may even outperform. So I think it's a hypothesis that this population may be different in some way from other populations, but I'm not sure that the data as we currently have it would suggest that paclitaxel by itself is a better drug than nab-paclitaxel. And I suspect that was more of an underlying trial population issue is my suspicion, but I don't honestly know.
Thank you.
Can you hear me?
Yes. Oh, now I can't hear you.
The voice, Dr. Talib.
Hi, can you hear me now?
Yes, I can hear you now. Thank you.
For BRCA positive patient, which one you gonna use? The PARP inhibitor first or the immunotherapy in the management of metastatic triple-negative breast cancer?
That's a great question, which of course hasn't been addressed. Because I don't know that use of a PARP inhibitor is going to change the immune exhaustion features of the triple negative breast cancer in the way that a previous line of chemotherapy would. But what I do know is that first line is better. And if you think about the sort of constellation from the early through to the later, the evidence of immune exhaustion and really refractoriness to immune checkpoint inhibitor effectiveness goes down either with time or treatment or both. So to be frank, I typically, if I'm going to use an immune checkpoint inhibitor, I use it first. Although I certainly understand the impulse to use something that's less toxic and appealing. The other thing I'd add is that the comparator arms to all of the PARP inhibitor seminal trials were all second-line chemotherapy options. None of them were a taxane or a platinum, or what we would consider to be first line. So I think how those drugs would perform in that setting comparatively has yet to be determined. But I don't fault people if they wanted to reach for an easy drug that's oral before they launch into infusional therapy with a lot of toxicity.
Thank you.
Yeah, go ahead.
Thank you very much, Dr. Lisa, for the very nice presentation. I'm Sharif Samani, medical oncologist, King Abdullah Mecca. So I have two quick questions for you. There is always some argument about them in the routine practice. The first is, if you have a patient that missed immunotherapy in first line and received whatever chemotherapy in first line, would you go with monotherapy based on the data from KEAT? Well,
I lost the end of that question.
Yeah, 119 and the exploratory endpoint of more than 20% positivity of PD-L1. Would you go for that with pembro single agent? Yes or no? The other question: what about using immune therapy in first line in patient with AR 1 to 10%? Those patients were not represented in the first line trials with immune therapy in triple negative breast cancer.
You're asking the really hard questions. To answer the first one, which is if somehow the patient missed getting their immune checkpoint inhibitor in the first line setting, would I incorporate it into the second line setting? I typically don't, just because the data aren't very encouraging that it would work. The one caveat I would say is if you have a patient with a high TMB, which I think were overrepresented in that exploratory analysis of Keynote 119, I think you have every reason to try pembrolizumab as a single agent. I think it is in fact across tumor types quite reasonable, and there are data supporting a similar effect in breast cancer of these very, very high tumor mutational burden patients. Your second question, what was your second question?
Would you go for immune therapy in patients with ER from 1 to 10?
ER, oh gosh, the ER 1 to 10%. All right, what do we know about ER 1 to 10% patients? So what we used to call ER borderline, now call ER low, is that they are a mixed bag. Most of these patients are in fact non-luminal endocrine insensitive tumors, but not all of them. But since it's the majority of them, in fact, fall into subtypes that are endocrine insensitive, if they're HER2, negative, then I would treat them as a triple negative and I would try it.
Thank you, Prof. Kari, for your excellent presentation and for answering our question. We are glad to have you with us. And Dr. Aisha, the mic is yours. Thank you.
Dr. Majid, Dr. Lisa. Now we'll move to our next. Yeah.
Okay.
Now we'll move to our next speaker. It's my pleasure to present Dr. Khaled. He's a medical oncologist and clinical investigation specialized in breast cancer. He's a professor of medicine at Harvard Medical School and Dana-Farber Cancer Institute. He will present in 20 minutes immunotherapy as adjuvant, neoadjuvant therapy in triple-negative breast cancer, how to select any biomarkers. Welcome, Dr. Howard. Are you muted?
Thank you very much for having me. I'm delighted to be with you today. And it's always a treat to hear Dr. Kari speak. She is one of the best, and I always learn so much from her. So very happy to be with you. I will share my screen here. Hopefully you are now seeing my slides. So I'm happy to speak about how we're thinking about early stage triple negative breast cancer with a focus on neoadjuvant immunotherapy and talk briefly about biomarkers and patient selection. So a couple things about triple negative breast cancer that are worth remembering. The first is that this is the subtype of breast cancer where anthracycline chemotherapy still seems to be important. So probably the best data for that is from the so-called ABC trial, which looked at anthracycline versus non-anthracycline based chemotherapy regimens. And overall, on the left side, there was only a small benefit for anthracyclines. But if you look, you'll see that that benefit was largely in hormone receptor negative, which meant triple negative cancers. And that was true regardless of nodal status. There's about a 30 to 40% improvement in outcome with the use of anthracycline-based chemotherapy. So anthracyclines are still actually really important in triple negative regimens. And the debate persists on whether or not carboplatin is an important part of neoadjuvant regimens. These are data from CLGB 40603, which looked at adding carboplatin to the AC taxane chemotherapy backbone. And what you can see is that overall in panel B, there was very little benefit in terms of preventing recurrence with the addition of carboplatin in this trial. However, in the so-called, in a different study that was built around including a PARP inhibitor or carboplatin or both, there was an interesting finding from the GBG study here that showed that actually adding carboplatin to paclitaxel by itself or with the combination of veliparib, the PARP inhibitor, actually did help prevent recurrence of breast cancer. And perhaps there was even a suggestion, though it's a little soft, that there might be a survival advantage. So the first thing to say is that before we speak about neoadjuvant immunotherapy, it's important to remember that this is still a subgroup where the optimal chemotherapy program still matters. It absolutely should include an anthracycline-based chemotherapy regimen. And for many people, it's also a good idea to include a platinating chemotherapy regimen like carboplatin. So those studies have set the stage for the chemotherapy approach in general, but what about neoadjuvant treatment? So neoadjuvant therapy has been widely studied in many kinds of breast cancer, but again, it's worth remembering that it's in triple negative breast cancer that you see both the highest rates of pathologic complete response, and you also see the biggest difference between outcomes for those patients who have residual cancer, shown down here in the yellow line in panel E, versus a complete pathologic response. These are data from the German breast group, but you could pull any number of different studies to make the same overall point. So it really is in this cohort of triple negative breast cancer where thinking about neoadjuvant treatment as a way to optimize long-term outcomes makes the most sense, because you see the greatest stratification between residual disease and non-residual disease patients based on their response. The other reason it's really important is because triple negative breast cancers tend to behave differently when you give them neoadjuvant therapy in the sense of how the tumor itself actually shrinks. This is a cartoon from my pathology colleagues at Brigham and Women's Hospital. And what they did is they analyzed the treatment response in the breast for all sorts of tumor subtypes, comparing how the tumor itself actually shrank. And if you imagine a tumor in the breast sort of shown here in the middle, you could picture sort of different kinds of responses. In panels A and B, there's a very tight response such that the tumor sort of concentrically gets smaller and smaller. Whereas in panels C and D, there's a lot of residual cancer scattered throughout the tumor bed. And triple negative breast cancers are the ones most likely to have this kind of tight clustered response. And so it is in triple negative breast cancer that neoadjuvant therapy is actually most likely to achieve breast conserving surgery or other dramatic changes in surgical outcomes. And if you look at the so-called residual cancer burden scale, again, it makes the point that triple negative tumors are the ones most likely to have dramatic responses to therapy. And it is in that cohort that there is the most dramatic effect based on the extent of response. So I mention all this because I think it sets the stage for the very important clinical trial, the Keynote 522 study, which looks specifically at a very complex chemotherapy regimen, carboplatin plus paclitaxel, followed by an anthracycline and cyclophosphamide-based chemo regimen, given with or without the checkpoint inhibitor pembrolizumab. And as part of that study, patients who received pembrolizumab also received another 6 months of adjuvant type therapy with pembrolizumab. And I'm sure that this study is well known to this audience because of the important results that have emerged from it in recent years. Just a couple of other things to note. First is that most patients in this trial had node positive breast cancer or really large breast cancers, typically T3 or T4, and that PD-L1 testing was done in this study, but was not a requirement for treatment eligibility. So here was the first endpoint that was reported, which was the impact of adding pembrolizumab on pathologic complete response in triple negative breast cancer. And what you can see is that adding pembro did increase the PCR rate from 50% to about 65%. Interestingly, there was effectiveness in either PD-L1 negative or in PD-L1 positive cancers. In PD-L1 positive, the PCR rate went from about 55% to 70%. In PD-L1 negative, it went from 30% to 45%. There was actually a bigger benefit for the PD-L1 negative group in absolute terms than for the PD-L1 positive group. And if you look at the numbers at the bottom here, you'll see that most tumors were actually PD-L1 positive at baseline. So based on this, the interpretation has been that PD-L1 is a prognostic marker. That is to say, if your tumor is PD-L1 positive, or if more accurately, if the bed of the tumor is PD-L1 positive, there's a greater likelihood of PCR, but it does not uniquely identify patients who are likely to benefit from pembrolizumab-based therapy or not based on PCR. These then are the more mature event-free and overall survival data that were recently presented at the ESMO conference last year and just published in the New England Journal of Medicine. And what you can see is that adding pembrolizumab had a substantial impact on risk of recurrence, improving 4-year risk of recurrence by about 10%, and a hazard ratio of 0.63, suggesting a 1/3 or greater risk reduction. And intriguingly, that is also translating into an improvement in overall survival with about a 5% difference in 3 to 4 years and a 30% reduction in the risk of death from breast cancer. So it looks like adding pembrolizumab to this chemotherapy backbone is going to be a very important part of management for higher risk triple negative breast cancer. Now, it's also important to look at the kinds of events that were controlled by the addition of pembrolizumab. What you'll notice is that there was an impact on both local recurrence. There were fewer local recurrence events in the breast or regional lymph nodes, but more importantly, about a 50% reduction in the incidence of distant metastatic recurrence with the use of pembrolizumab-based therapy. And that presumably is in part how this drug is showing a survival benefit in early 3 to 4 year follow-up. Now, the investigators have looked really carefully here at outcome by nodal status. And what you can see is that for both node negative and for node positive breast cancers, node negative are the top 2 lines, node positive the lower, there's about a similar hazard ratio. For node negative, the absolute benefit is about 6%. For node positive, it's about 8 or 9%. But again, seemingly a substantial benefit for both cohorts. Interestingly, if you look by whether or not the patient achieved a pathological complete response, you'll note that the addition of pembrolizumab was particularly important in patients that had not achieved a pathologic complete response. Whereas in the patients who did achieve a PCR, there was a non-significant, though numerical, advantage for the use of the pembrolizumab. So that sort of makes sense in the idea that if the patient's tumor is going to respond fully to chemotherapy alone, it becomes a little more unclear how much they would have needed pembro. And based on these kinds of data, there are trials that are emerging for women who've achieved a pathologic complete response with pembrolizumab to ask the question as to whether ongoing pembrolizumab therapy would be helpful. I think I omitted this slide, but the other important slide that I wanted to show was that the event-free survival benefit was seen in both PD-L1 positive and in PD-L1 negative breast cancers. And so the proportional risk reduction is actually greater in PD-L1 negative than it is in PD-L1 positive, all of which begs the question as to how important using PD-L1 as a marker for early stage breast cancer will prove to be. Now, the final thing to say is that as we have begun to use this more and more, we have learned that this regimen is not without its toxicities. Many of these toxicities are very familiar immune-mediated side effects. So if you've begun to have experience treating melanoma or lung cancer or other tumor types with checkpoint inhibitors, you've seen this. But there's a reasonably high rate of hypothyroidism, of cutaneous or skin toxicities, of adrenal insufficiency, about 2 to 3% of patients, of pneumonitis, about 2 to 3% of patients, and even of hypophysitis. So these endocrinopathies and these other inflammatory conditions, including pneumonitis and colitis, we're seeing them now that we're using pembrolizumab more and more. And that's something that you have to be very aware of. There's probably about a 5 to 10% chance of a permanent endocrinopathy as a result of pembrolizumab when treating early stage breast cancer. The other thing that I will just anecdotally say is that while the taxane, carboplatin, doxorubicin, cyclophosphamide cocktail of chemotherapy is what we are using as the backbone for this treatment program, that is a tough regimen. It's a lot more side effects than dose-dense AC Taxol, for instance. And so we're seeing patients getting sicker with more fatigue, more delays because of treatment-related neutropenia or treatment-related thrombocytopenia, more hospitalizations for general fatigue and exhaustion. So this is not a trivial regimen when you're giving it to patients. So I wanted to make sure to leave time for questions, but let me just say a few words in summary, and then we can go to an open discussion. The first is that for triple-negative breast cancer, chemotherapy still matters and probably should include an anthracycline, and in a select group of patients also include carboplatin. For women who have stage 2 or 3 triple-negative breast cancer, our strong preference is to offer neoadjuvant treatment instead of surgery as the first therapy. And nowadays, we are typically using a regimen that includes pembrolizumab based on the data from the Keynote 522 study showing that it has a substantial impact on recurrence. In terms of a little more granular discussion, for node-positive cancers, I think it's very clear that you should be using the pembrolizumab-based therapy. For T2N0 cancers, our group still struggles in the sense that the marginal benefits of adding pembrolizumab-based treatment in this group are not well characterized. Many of these patients will have a favorable overall prognosis, and we usually restrict it to T3 or greater tumor size in the absence of nodal involvement or node-positive breast cancers. The other drugs that are being developed in the immunotherapy space so far have not materialized in mature phase 3 studies as being of clinical benefit. So at the moment, we're mostly just talking about pembrolizumab. And finally, to speak to the issue of biomarkers, it seems clear that if you have a PD-L1 positive tumor, then there's a greater likelihood of complete pathologic response, and that probably is a favorable prognostic marker. But the benefits of pembrolizumab seem to be independent of PD-L1 testing. So in routine clinical practice for early stage breast cancer, we are actually not doing PD-L1 testing, partly because most of the tumors are PD-L1 positive, and partly because it doesn't seem to predict who benefits from pembrolizumab-based therapy. Said another way, the story in early breast cancer is very different from the story in lung cancer, for instance, where the benefit of checkpoint inhibitors really seems to be most dramatic in tumors that are strongly PD-L1 or PD-1 positive. But in breast cancer, the marker is not nearly so robust in early stage. And there also is a strong correlation between PD-L1 testing and the presence of lymphocytes or other immune reactive cells in the tumor bed. And many investigators around the world, like Karsten Denkert in Germany and others like Shreen Loy in Australia, who have studied triple-negative breast cancer intensively, believe that the tumor infiltrating lymphocytes serve as a very good surrogate for PD-L1 expression in triple-negative breast cancers, in part because most of the PD-L1 expression is actually not on the tumor cells, but is actually on these immune cells, and in part because those are the tumors that seem to have a more sort of immunologically charged milieu, if you will, and are more likely to respond to chemotherapy, probably including pembrolizumab-based chemotherapy. So with that, I will pause and take any comments. Thank you very much for the opportunity to speak with you, and I'm happy to be able to join you remotely today.
Thank you, Dr. Harrod. And now we'll move to questions. So you
We have
start.
a question, Dr. Aisha, if you allow me.
Yeah, go ahead, Dr. Mar.
Yeah. Thank you, Prof. Harold, for this excellent presentation. I have a question regarding the adjuvant part in the Keynote 522 with the toxicity and in the we know that in the triple negative, metastatic triple negative, we have justification for that to use the immune checkpoint inhibitor based on the survival benefit. But here, using pembrolizumab in the adjuvant setting is justified with the toxicity or with the immune-related side effect?
So the question is, do we give the adjuvant portion of the pembrolizumab?
Yes.
And usually the answer is yes, but I think you make a really good point, which is that we don't know that that's a necessary part of the treatment program. When the company developed this study, they sort of took all the chemotherapy they could, carboplatin, taxane, anthracycline, cyclophosphamide, and gave it with or without the pembro. So no one could say they didn't give maximal chemo. And then they also gave this adjuvant phase of the pembrolizumab. And so we typically do that, but we do see inflammation situations, skin rash situations, thyroid disease situations. And my threshold for stopping the adjuvant part of the pembrolizumab is pretty low because there are those side effects that we do occasionally encounter, and we don't know that it's essential, especially in a patient who has had a complete pathologic response to the core regimen. The other question that arises is, what if you have a patient who had surgery first, who is no longer has residual disease, but has several positive lymph nodes? would you give pembrolizumab to that patient? And the answer there is we do sometimes think about it, even though those patients are obviously very different from the ones who were treated on the Keynote 522 trial. And there are some scientists who believe that it's actually really important for the tumor to be physically present to help generate these immune responses against the tumor. But if you do see a woman who had surgery first and who had multiple positive triple negative lymph nodes, we often do give the same regimen.
Hi, Dr. Howard. I have a question. What is your criteria to choose a patient for immunotherapy as a neoadjuvant versus only chemotherapy?
That's a good question as well. So typically for stage 1 triple negative breast cancers, we just give adjuvant chemotherapy. For clinical stage 2, but with negative lymph nodes, we often give neoadjuvant treatment, but I typically omit the pembrolizumab-based regimen at that point because we don't know that they are likely to benefit. So for patients who present with clinically involved lymph nodes or patients who present with T3 or larger tumors that are triple negative, for sure, I am giving them the pembrolizumab-based regimen, assuming they are healthy. This is not a trivial regimen to give, and so it's important that people be fairly functional and healthy before embarking on the treatment. And in those women who have larger tumors, like a 3 to 4 centimeter cancer, whether the nodes seem to be negative, that's our gray zone. And we spend a lot of time talking to the patients about whether they're willing to accept the risk of the endocrine side effects and other toxicities of the regimen.
Thank you, Dr. Howard.
Yeah, I have a question, Dr. Howard. Regarding before, we are using for non-BCR or patient with residual disease, Zeloda. Nowadays, with the presence of pembrolizumab as adjuvant setting, a little bit complicated. What's your approach in such a setting? Do you use Zeloda with Pembo or just go ahead with Pembo and then BCR?
For the patient who has residual disease?
Yeah.
Yes. So that's a great question. We have had several meetings just of our own group to try and answer that question. There's a little bit of safety data for the combination of the pembrolizumab and the capecitabine regimen. What we learned in the Keynote 522 study is those patients with residual disease still have a much greater chance of recurrence. And so we do typically give the capecitabine, but I have found that there's a lot of GI side effects because of the pembrolizumab and the capecitabine at the same time, so it is a little harder. The other thing that we do give, if the patient has a BRCA1 or 2 mutation, we also give the olaparib at the same time as the pembrolizumab in the adjuvant space there to help improve their chances as well. But we don't really have any data on whether capecitabine is important in patients who've had those 4 drugs plus the pembrolizumab.
Question, Dr. Howard. For BDL scoring, is it to play a role in the choosing immunotherapy as adjuvant or neoadjuvant setting in the triple negative breast cancer?
The which scoring?
BDL1 score.
Yeah. So by my read of the paper and the literature, PD-L1 is not informative for early stage triple negative breast cancer. Obviously, in metastatic triple negative breast cancer, the data from 355, the Merck study in the metastatic setting, suggests that you only see the benefit in those patients whose tumors were PD-L1 positive. But in the early stage setting with Keynote 522, there is clearly benefit in both the PD-L1 positive and in the PD-L1 negative subset. The other thing that's really important to remember is that in early stage primary tumors, the chance of PD-L1 positivity is very high. It's something about 70–75% compared to sites of metastatic disease, particularly the liver, where the likelihood of PD-L1 positive tumor expression is very low. It's only about 25%. So some of that is because we've enriched in the early stage setting and there's more PD-L1 expression. But in the subset analyses, it looks like Pembro improves the outcomes for both PD-L1 negative and PD-L1 positive tumors.
Last question from my side, if you don't mind, Dr. Aisha. If we use the immunotherapy in neoadjuvant or adjuvant setting in early stage triple negative breast cancer, but if later on, if patient develop metastasis and still it is a triple negative, do you re-challenge the patient with immunotherapy, or you go ahead with a chemotherapy or other line of treatment like PARP inhibitor or something else?
That's also an excellent question. There are no data to really help us guide that. One of the things about triple negative breast cancers is that they tend to recur pretty early. So in a woman who has neoadjuvant pembrolizumab-based therapy, she then has 6 months of pembro. If they have residual disease and they're going to recur, that often happens in the first year or two. And so I think it's hard to imagine that more pembrolizumab or other checkpoint inhibitor-based therapy would really be helpful in that setting. In addition, the drugs we use the pembrolizumab with, taxanes and carboplatin, the patient would have already seen those drugs. So typically we move on. Now, as we get further into this world of immunotherapy for triple negative breast cancer, two things are going to happen. One is there certainly will be some patients who had neoadjuvant treatment many years ago and then had a later recurrence. And for those women, it might make more sense to reintroduce the checkpoint inhibitor. And the other is that hopefully, this is just the beginning of the opportunities to use immunotherapy. And that as we begin to get smarter about adding other targeted or immunotherapy drugs, we will be able to do better and better with re-challenging patients who might have initially had pembrolizumab.
Thank you, Dr.
So we'll move, thank you, Dr. Khaled. We'll move to the next.
Thank you.
Now we'll move to Dr. Talib to present the next speaker.
Assalamu alaikum. Okay. Dr. Mutab. It's my pleasure to introduce the next speaker, Dr. Mutab Al-Fuhaidi. He's head of medical oncology at Princess Noura Oncology Center, and he's also associate professor in King Saud Health University. He's a president of Saudi Oncology Society. He's well known in the field of breast cancer, and he had multiple and many participation in the trial. Dr. Mutab, he will give us a talk about IO versus capecitabine versus PARP inhibitor as adjuvant therapy. Dr. Mutab, mic is yours. Dr. Mutab, can you hear me?
Thank you so much. Thank you so much, Dr. Talib, for your kind introduction. So just give me 1 second, please.
Take care.
Can you see my slide?
Nope.
So just I will share it, share screen, and here, I think. Okay, so I have been tasked over the next 20 minutes to discuss with you the immunotherapy versus capecitabine versus PARP inhibitor as adjuvant therapy. So can you see the slide, Dr. Talib? Dr. Talib?
Yes, I see your slide. Go ahead, Dr. Mutab.
Okay, so when we talk about the triple negative breast cancer, there are a number of historical studies. We don't like really the term of triple negative breast cancer, but we are a bit stuck with it right now. As you know, the triple negative breast cancer has a higher risk and earlier timing of relapse, and the sites of involvement differ from luminal, as shown in this slide here, where there is a more visceral disease than estrogen receptor positive disease. And also there are bone and soft tissue. It is less in terms of the bone disease. And as you know also that the CNS is involved in approximately 25 to 50% of advanced triple negative breast cancer. So what are the expectation with the triple negative breast cancer? So first, we know that there are there is often a very good relapse to the initial chemotherapy, but with an increased risk of disease relapse. And once patient relapse, they have a much shorter survival, and there is increased, as I mentioned, CNS disease, which is often associated with increased anxiety from both patient and healthcare provider in regard to the prognosis. And even with our best treatment, we still see a too high rate of relapse. So the breast cancer classification has evolved, and there are a number of different classifications that have been used in triple negative breast cancer. And this is shown here, pathway analysis overlap. You can see a number of different things that have been shown, which include androgen receptors, include DNA repair deficiency, as well as immunomodulatory group. So this is an algorithm that was actually published by Dinkert in the Lancet in 2016. And really, it is very interesting. It shows a high proliferative triple negative breast cancer with those with increased tumor infiltrating lymphocyte, those with androgen receptor expression, as well as a subgroup with low proliferative special type of triple negative. And we know that we see that with classic pathology. And when we look at the gene expression profiling, there is a basal-like 1, basal-like 2, immunomodulatory, mesenchymal stem-like, and there is also luminal or androgen receptor. There are a key molecular feature with clinical relevance, like those with increased immune infiltrate, BRCA1 and 2 mutation, genomic scar, HRD, and the mutational load. And also, this was published in 2016, as I mentioned. I think we are only just starting to scratch at this in regard to the immunotherapy, platinum chemotherapy, and PARP inhibitor, as well as the anti-androgen treatment. So when we talk about the triple negative definition, it is really interesting as we are not even committed to what we define as AR positive and AR negative. So the AR positive was 10%, and then it was 1% historically. Recently, there has been data to suggest that those patients with AR of 1 to 9% behave a lot like triple negative breast cancer. This data from the GBG and Munich Cancer Registry, which looked at how their breast cancer behave. And the green line, as you can see, those patients with hormone receptor positive of greater than 10%, and the blue and the red line are either triple negative at less than 1%, or 1 to 9%. And what is really obvious is that the triple negative and the 1 to 9% behave the same. So in terms of the triple negative definition, I think it's the time that we need really to change our estrogen receptor positive definition to 10% or greater. So we also know from this old data from 2008 that the triple negative breast cancer outcome is strongly correlated to complete pathological response after a neoadjuvant chemotherapy. So what about the post-neoadjuvant setting? So we know that the PCR is validated endpoint, particularly for patients with triple negative breast cancer. And residual disease suggests resistant disease, and therefore we have to question whether a new agent should be used for adjuvant therapy. Our goal is to improve the overall survival and event-free survival with post-neoadjuvant treatment. And we can use the residual disease as a marker of resistance. So we can question whether we should target our adjuvant therapy specifically to those resistant cells. We can also question whether these resistant cells are a good target for branding new therapy and developing new treatment. And certainly there are a lot of clinical trials which are going on and doing the same principle. So there are major studies in the post-neoadjuvant therapy, the Catherine and the HER2-positive patient population that showed TDM1 over trastuzumab. There are new studies that are adding now trastuzumab deruxtecan and tucatinib. Penelope was really disappointing, and palbociclib for the high-risk hormone receptor-positive patient showed no improvement. And there is the CREATE-X trial where the addition of capecitabine as adjuvant therapy was associated with benefit for all breast cancer subtypes. So the CREATE-X was done in Japan, and it included the HER2-negative patient with residual disease after neoadjuvant treatment that contained anthracycline and taxane chemotherapy, and the disease-free survival were positive for the entire population, as well as the overall survival as shown with the first presentation in 2015 at the San Antonio Breast Cancer Symposium. These are the patient characteristics. Approximately 1/3 of the patient were AR negative and BR negative, and 40% of the patient were a node negative disease. And this is the data that was subsequently published in the New England Journal of Medicine in 2017, when the overall survival for the full data set was looked at. There was really not as much for a difference, although that the hazard ratio was 0.59. But in panel D, one can see that the overall survival among patients with triple negative disease, the triple negative disease, the hazard ratio was 0.52, and the disease-free survival in the panel C was statistically significant with the hazard ratio of 0.58. And this actually led to widespread adoption of capecitabine as adjuvant treatment in the post-neoadjuvant setting for patients with triple negative breast cancer. The GCAM Cyboma study looked at adding capecitabine as well, but they looked at it for patients whether or not they had PCR. And in this publication from 2020, they did not show a statistically significant benefit, although there were slightly better outcome for those patients who either had PCR or did receive capecitabine. The SYS UCC 001 trial, this is from the ASCO 2020, looked at the metronomic capecitabine for 1 year. And as you can see, by giving capecitabine for a year, there was actually an improvement in the disease-free survival as well as the overall survival, a trend. Also, the OS in this clinical trial was not statistically significant. Many of these patients had adjuvant treatment and not just a new adjuvant treatment. So there have been also meta-analysis, and this meta-analysis that was presented at the San Antonio 2020, which looked over 15,000 patients and the 12 randomized clinical trial, showed that there was an overall survival benefit for triple negative breast cancer with the addition of capecitabine. So I think from that, we can see that the meta-analysis showed that although the capecitabine did not alter the disease-free survival, it did improve the overall survival in the cohort with triple negative, and the overall cohort as well as in patient with triple negative breast cancer. So this is another more recent meta-analysis, which actually was performed. And however, it did not look at the individual patient data. It looked only at the study. And it was published at the PMC 2021. And it showed a positive effect on higher risk patients with lymph node positive, as well as those patients who received capecitabine as adjuvant, but not as new adjuvant. So adding capecitabine to the new adjuvant did not make a difference, but adding it as adjuvant after a new adjuvant treatment actually did. So what about the IO? We know that targeting the PD-L1 pathway is important in triple negative breast cancer. And so the question why we combine it with the chemotherapy, and as you saw previously, it induced multiple immunomodulatory changes in the tumor microenvironment that might improve the effectiveness of immunotherapy. So that's why we are combining it in the neoadjuvant setting. So the question, what about the IO in the post-neoadjuvant setting? So we know that there are a couple of studies, the Keynote 522 and the Ambition 031, that both showed an improvement in the PCR. And the Keynote 522 had a statistically significant and the clinically meaningful AFS at their last analysis. What is really interesting here is looking at the event-free survival by PCR. For those patients who had PCR, it doesn't appear that there was an improvement in the event-free survival. But for those patients who did not have a PCR, there was an improvement with 67.4 event-free survival with the Pembro at the time of this analysis, in compared to 56.8 with the placebo. So it actually does suggest that post-neoadjuvant treatment with Pembro might be important for those patients with residual disease. And what is interesting here, that giving the same agent afterward that was given before is really important, because we thought that immunotherapy worked better in combination with chemotherapy than as monotherapy. The SWAG 1418 is a randomized phase 3 trial that is looking at giving Pembro as adjuvant therapy to patients with triple negative breast cancer who have more than 1 centimeter of residual invasive cancer or positive lymph node after a neoadjuvant chemotherapy. This study, I think, will clearly answer the question of whether or not Pembro as monotherapy is helpful after a neoadjuvant chemotherapy for those patients with residual disease. And just to note that the majority of these patients who have been enrolled in this clinical trial have not had Pembro in the neoadjuvant setting. The Olympia study, as you know, it is a study of olaparib in the post-neoadjuvant or adjuvant setting, and approximately 50% of the patients received the neoadjuvant treatment. And for those patients who received the neoadjuvant treatment who were triple negative, they had to have a non-PCR, so any residual disease was okay. So for those patients who were hormone receptor positive, they had to have a CPS score of 3 or greater. So it is a quite bit of disease. Those patients were randomized in 1-to-1 to receive either olaparib versus a placebo for 1 year. So the study showed that there was an improvement in the invasive disease-free survival, and that improvement was seen with both those patients who got neoadjuvant treatment and those patients who got adjuvant treatment, suggesting that the olaparib was effective for those patients with residual disease and for post neoadjuvant treatment. So when we look at early stage germline BRCA mutated triple negative breast cancer, we know that for those patients with neoadjuvant treatment, olaparib might be effective. The big question right now is what about capecitabine, which has been standard for non-PCR? What about the IO? And actually, we don't have data combining those in the Olympia study, and it's going to be a question to either do study or to start getting some real world experience and evidence of combining these agents. Capecitabine was combined with the olaparib. I think it might be difficult. Also, it has been tried to be combined in a patient with pancreatic cancer, but I think it might be associated with more toxicity. Capecitabine is often started, as we know, right away, and it is given through the radiation treatment in patients with triple negative, whereas in the Olympia study, it was given after. So it might one start capecitabine and continue with olaparib. And I think because those patients, we saw that they have early risk of relapse, and the improvement in the Olympia study was seen early. I'm not sure that myself, I would be doing that, and we will see the discussion. What about this clinical trial? This is just to remind you that the adjuvant use of platinum agent post-neoadjuvant chemotherapy are also unlikely to be non-inferior or superior to capecitabine in improving the invasive disease-free survival. And briefly, I will finish up with the emerging therapy. We have talked about PD-L1. We have talked about the PARP inhibitor, the AKT inhibitor. At this point, I don't think that they are a good one. At least in the triple negative. The third are questioning up, and there are ADCs, and there are to ADC. So combining PARP inhibitor with immune checkpoint inhibitor is very interesting in terms of activation of STING pathway. And I think we are going to see more about this. And I think might be really important for those patients who do not achieve PCR. What about new antibody drug conjugate? So TDXD is being blocked in HER2-low advanced breast cancer and might be of importance. And we are going to see in 2 weeks the presentation of Destiny-04. And the same is true for Day2 DXD. So what about the SG or Sacituzumab govitecan? We know the Ascent trial, which showed OS benefit and progression-free survival benefit in triple negative breast cancer for this drug. The SASIA trial is a phase 3 prospective international multi-center randomized open label, which is going to look at patients with HER2-negative breast cancer with residual disease after neoadjuvant chemotherapy. The investigator will look at the triple-negative subtype. So the SG may actually represent a new treatment option against resistant residual disease after standard neoadjuvant chemotherapy. Finally, what about the role of the circulating tumor DNA? And it can be used, as you know, to quantify the residual disease. It is less relevant if we have a surgical specimen showing no PCR, but it might be able to identify some patient with PCR who still have circulating tumor cells, and the circulating tumor DNA might be used to guide our treatment. This is some data suggesting that the circulating tumor DNA might be able to predict those patients who are going to relapse despite having complete pathological response after a new adjuvant treatment. So in conclusion, a patient with triple negative breast cancer who do not achieve a PCR have multiple treatment options. Standard therapy has been with capecitabine. New data now from the keynote suggests that the IO might be helpful. The Olympia trial suggests that the PARP inhibitor may be active in the BRCA mutation, and data for combining this agent is pending. And we have a new agent that are being tested and may provide other treatment option for those patients. And with that, I would like to thank you for your kind attention.
Thanks, Dr. Metab. We'll keep the question and answer at the end. Dr. Majid? So, Mia will present the next speaker, Dr. Rashid Sammani, is a consultant. Huh? I will go ahead. At King Abdullah Medical City in Mecca, he will in 20 minutes he present.
Yeah. Okay. For the.
I present Dr. Majid. A barrier of immunotherapy in breast cancer, why and how to improve. So welcome, Dr. Sharif.
Thank you very much, Dr. Aisha. And first, I would like to thank the organizers of this excellent meeting, Dr. Assam Morshed, Dr. Mirvat Mahrous, and all the organizers for the appreciated invitation, and congratulations for the success of conducting such meeting for several years in a row. So they give me a very hard talk about barriers of immune therapy in breast cancer, why and how to improve. In the coming few minutes, I will try to have some speculation about these points. Anyway, some introductory slides about what we know about immunotherapy in breast cancer. We know that breast cancer is not that greatly immunogenic disease. Several other cancer types are more immunogenic than breast cancer, as we can see in this diagram, that the level of mutations are much more in other tumor types compared to breast cancer. However, among breast cancer subtypes, triple negative breast cancer is the most immunogenic compared to other types of breast cancer. And this is reflected on the data of immunotherapy, of single agent immunotherapy in triple negative breast cancer. We have seen previously the data coming from the Keynote 119 presented by Dr. Lisa Carey, that in this second line study, patients who received the monotherapy with pembrolizumab, the trial was negative compared to a standard of care or chemotherapy, despite some trend of some benefit in patients with a PD-L1 more than 20%. However, this is an exploratory endpoint, and this is not the primary endpoint of the study, so the trial is negative. So the bottom line here is monotherapy with immune therapy in the triple negative breast cancer is not the standard of care. And again and again, we know that the level of tumor mutation burden is much lower in triple negative breast cancer compared to other subtypes. And based on this data, we have several studies that address the concept of combining immune therapy with other agents, typically here chemotherapy, in order to improve the outcome in triple negative breast cancer. And we have seen before the data of first-line studies of immune therapy plus chemotherapy from the Impassion 130 and Keynote 355. And we know that for the primary endpoint of PFS, we have some improvement, clinically and statistically significant improvement in terms of PFS in favor of combining immune therapy, either pembro or atezo with chemotherapy, hazard ratio 0.62 and 0.65. And in addition, the overall survival, especially in the trial of Keynote 355, was improved in favor of chemotherapy. But I need to draw your attention to the median overall survival here. It is about 2 years. If we compare the median overall survival, this is the best median overall survival that we can achieve in triple negative breast cancer. If we compare with HER2 positive, about 5 years, and hormonal positive, 5 years and even more. So still, I think we need a lot of improvement in triple negative breast cancer to enhance the survival outcome to be more or less similar to other breast cancer subtypes. So the question is, how to move forward and how to improve. Different strategies we can try. The first is to look for better biomarkers for selection of immune therapy. The next strategy is to look for other combinations. And the third and last strategy, in my opinion, is to look for other targets of for immune therapy in triple negative breast cancer. We'll go one by one. Regarding the biomarkers, looking for biomarkers other than PD-L1. So we know that triple negative breast cancer is not one disease. And we learned about 10 years ago that we have different molecular subtypes among triple negative breast cancer. And this started with the pioneer work from Lehmann et al. From Vanderbilt classification, who classified triple negative breast cancer into 6 subtypes. These are like 1, 2, mesenchymal stem-like, luminal androgen receptor, and immune modulatory subtype. So we learned that there is a category within breast cancer, within triple negative breast cancer, that is immunogenic, the immune modulatory subtypes. And we have later on different classification, different molecular classifications addressing the same points. In 2015, we have another classification which classified triple negative breast cancer into luminal androgen receptor, mesenchymal, and basal-like immune activated and basal-like immune suppressed. So again, we have a category which is immunogenic. So the bottom line from all these molecular classification that we have certain fraction or certain proportion among triple negative breast cancer which is immunogenic. So can we use this immunogenic category based on this molecular classification or molecular tools as a biomarker for immune therapy instead of PD-L1? Let's look for this retrospective analysis coming from our translational research of patients enrolled in the IMPassion130 trial. They looked for the outcome of patients treated with Atezo plus nab-paclitaxel compared to compared to chemotherapy alone in patients treated with in the IMPassion130 trial. And they looked for the molecular classification of those patients, and they found something which is important. In the category of patients that have been classified according to this Bernstein classification, the basal-like immunoactivated subtype, which is 27% of patients, Atezo added great benefit to those patients. And please look to the hazard ratio. It is 0.54. It is much better or relatively better compared to the 0.65 in the IMPassion130 by the PD-L1 selection. So it seems that maybe what we can say at this current time that maybe selection of patient based on some molecular tools here, basal-like immune activated subtype by the Bernstein molecular classification, may be a better biomarker compared to the classic PD-L1. However, I need to emphasize again and again that this is coming from retrospective analysis. It needs prospective validation. This is number one. Number two, it is not easy to conduct in the routine practice. PD-L1 is much easier. So we have a lot of logistic barriers for applying that in the routine practice. Still, it needs verification in further trials. The next attempts to look for a better biomarker for immunotherapy in triple negative breast cancer, they looked for the outcome based on selection of patients with CD8 immunohistochemistry assessment. And we have a classification of triple negative breast cancer based on the level of infiltration of the tumor cells and tumor stroma by CD8. You know, CD8 is a cytotoxic T cells, okay? So those patients are classified into a category called inflamed. This is the more immunogenic category where we have CD8 more than 500 within the tumor microenvironment, and excluded 40. And the third category is immune desert, which have no or very little immune cell infiltration. And they found that, as expected, the inflamed category had benefit from the addition of Atezo to nab-paclitaxel. But again, look to the hazard ratio. The hazard ratio of 0.63, more or less the same like the 0.62 and 0.65 in the first line trials by selection by PD-L1. So selecting patient based on this biomarker CD8 will add no benefit compared to selection based on PD-L1. So this is not a good strategy. So just to summarize the trials to have biomarkers for selection of immunotherapy in triple negative breast cancer, we have, of course, the PD-L1, we know that, and the hazard ratio 0.6 something. We have a selection based on tumor infiltrating lymphocytes, but again, the hazard ratio is the same like PD-L1, so this is not a step forward. CD8 by the inflamed, excluded, and immune desert. Again, the hazard ratio is the same, so this is not a step forward. However, the only step forward for a better biomarker up till now is selection based on molecular tool, as in the basal-like immune-activated subtype, which is 27% of patients with a hazard ratio 0.54, and again, this needs further validation. So what we can say up till now that other biomarkers other than PD-L1 are not ready to be implemented in clinical practice. However, we have some promising data with molecular tools that we need to be verified in further studies. The second strategy is to look for new combinations with immunotherapy other than chemotherapy. Okay, let's look for the what we have up till now. So we learned it from translational research from the Impassion 130 that patients who have angiogenic tumors are less likely to have a good outcome with the combination of Atezo plus nab-paclitaxel. So it seems that having angiogenic tumor may confer some resistance to immunotherapy. And based on that, it may be a good strategy to combine immune therapy plus chemotherapy plus anti-angiogenic agent to optimize the outcome. And this is a concept behind this single-arm phase 2 studies that have been presented in the ASC last year, the Future C study. The Future C, they used triplets of agents. They used immune therapy. Here it is Pembrolizumab. This is one of the Chinese immune therapies, not available in the West. Okay. In addition to chemotherapy, which is nab-paclitaxel, in addition to anti-angiogenic agent, which is Famitinib. And here they selected patients not based on PD-L1, but based on CD8 level more than by immunohistochemistry, more than 10%. And this is based on the Foden classification coming from China, that patients with CD8 more than 10% are the immunogenic category within triple-negative breast cancer. Anyway, whatever the way they used to select patients, in this study, the triplet combination of agents, including anti-angiogenic agents, leads to an overall response which is 81%. Okay, if that's a great achievement, let's compare with what we have in the Keynote 355. Here, the best response that we achieved with Pembro plus chemotherapy is 52%. So we have extra 30% response rate with the addition of anti-angiogenic agent in addition to chemotherapy and the immunotherapy in the Future C study. However, again and again, this is single-arm study, 46 patients only. I think this is a promising approach, but it needs to be investigated in a randomized clinical trial to address the benefit, the actual benefit of adding anti-angiogenic agent to immunotherapy and chemotherapy in triple-negative breast cancer. And again, what is confirming the potential benefit of this triplet combination is the survival outcome, not only the response rate. If you look to the median PFS here with a Future C study, it is 13 months. The best PFS that have been achieved in first-line studies is 9 months. So at least numerically, you have better outcome. And the overall survival in the Future C was not reached. So it seems to be better. But again, this is coming from very small study, single-arm study, and we need a randomized one to confirm the benefit of this combination. The other potential combination of the immune therapy in metastatic triple-negative breast cancer is PARP inhibitor. Okay. So we have, as we listened from Dr. Metrab just a few minutes ago, that we have potential synergism between immune therapy and PARP inhibitor, and treatment with PARP inhibitor leads to stimulation of the STING pathway, which leads to increased infiltration of the tumor with T cells. Okay, but does that theoretical advantage translated into the clinical practice in clinical trial? Yes or no? Let's look to what we have. So this is the Mediola study, which looked for the outcome of patient treated with the PARP inhibitor olaparib in addition to the immune checkpoint inhibitor durvalumab. The primary endpoint of this study is disease control rate at 12 weeks. Okay, let's look to what we have in terms of the primary endpoint of the study. That's fine, 80% disease control rate at 12 weeks, that's fine. However, if we look to other endpoints, which is the response rate, BFS, and so, the response rate is 63%. Just I need to remind you that the response rate with the PARP inhibitor monotherapy in the Olympiad and in the Embarca study, about 60%. Okay, the median BFS 8 months, quite similar to what have been achieved with monotherapy with PARP inhibitor. So at the current moment of time, we cannot say that adding immunotherapy to a PARP inhibitor is a good strategy. We need more data to clarify the benefit of such combination. And even in another study, which is the Tobacco trial, investigating the combination of naraparib plus pembrolizumab in patients with BRCA, germline BRCA mutation and wild, and including as well some wild patients, the overall response rate in general 21%, and in the germline BRCA mutant patient 47%, and again we don't have clear benefit of the combination in the metastatic setting up till now, and it needs further investigation. The last combination that I need to just to have a quick few slides about it, which is combining immunotherapy with histone deacetylase inhibitor. We have some preclinical data that histone deacetylase inhibitor have some synergism with immunotherapy, and they increase the ratio of CD8 compared to FOXP3, which is a suppressor for immune response. So the ratio will be higher. That's to say the tumor will be more immunogenic. This is the theoretical advantage of the combination. But again, does that or was that translated into some benefit in clinical practice? We have a very small study, a very small series of patients, 20 patients treated with a combination of entinostat, histone deacetylase inhibitor plus immune therapy. They included some triple-negative breast cancer and some hormonal receptor positive breast cancer. It seems that the response rate was better in triple negative as expected, but please look to the survival outcome of BFS, very modest. Overall survival, better to some extent in triple negative breast cancer. If you look to the median survival in triple negative breast cancer, 24 months, not far away, or almost the same as have been achieved in first line immunotherapy trial that we have up till now. So up till now, despite having very small number of patients, this is not a promising strategy up till now. So for the summary of this part, we can say that for combining immunotherapy with other agents, the most promising approach up till now that needs to be validated in a randomized trial is combining with anti-angiogenic agent. However, the combination with PARP inhibitor or histone deacetylase inhibitor is not that promising up till now. The last approach is to look for another or other targets for immunotherapy other than PD-L1. Okay. So we know that PD-L1 is not the only immune checkpoint. We have other immune checkpoints as well, like LAG3, TIM3, and others. And we have some data about the anti-LAG3 inhibitors, and those agents enhance the infiltration of tumor cells with cytotoxic T cells. And we have some data in triple negative breast cancer that patients with LAG3 high tumors have worse outcome compared to patients have LAG3 low tumors, which gives some rationale of adding anti-LAG3 in triple negative breast cancer. And they found as well that there is a co-expression of PD-L1 and LAG3 in the same tumors as well. So this gives the rationale of combining both agents in the treatment of breast cancer. And we have some data from preclinical data and some small series of patients, of melanoma patients treated with the combination of Nivolumab plus anti-LAG3, and we have some promising results. And we have some preclinical data in triple negative breast cancer, but it needs further investigation to confirm the validity of this potential combination. Just I need to finish with some few slides about early breast cancer. We have seen this data before in the last two presentations about the potential of immunotherapy plus chemotherapy in the neoadjuvant setting. We know that. But the issue is, we noticed that in patients for the Keynote 522 who received neoadjuvant chemo plus immunotherapy and achieved PCR, the benefit of the adjuvant part may be more limited compared to the benefit in patients who did not achieve PCR, as you can see in this diagram. However, if we look to another study, which is Nivo study, using another agent, which is durvalumab in combination with chemotherapy, we have some contradictory results. Despite that, This study is much smaller compared to the Keynote 522. This is number one. Number two, there is no adjuvant immunotherapy in the Nivo study. Okay, and modest improvement in BCR. However, we have great improvement in terms of survival outcome. Okay. But what I need to draw your attention is, if you look to the outcome based on the BCR survival outcome, invasive disease-free survival, based on the BCR status, here in contradiction to the Pembro study, here we have better or much better invasive disease-free survival benefit in patients who achieved the BCR compared to patients who did not achieve BCR. So this adds to the confusion of do we need to give immunotherapy in patients to achieve the BCR or to save it to patients who did not achieve BCR? And to have better answer for this question, we need to have such a design of a study. We need to have a study that addresses neoadjuvant chemotherapy plus immunotherapy, and then compared to chemotherapy alone. And then after surgery, we need to have a second randomization of immunotherapy versus placebo in both arms to check, do we need actually the adjuvant part of immunotherapy, or where the benefit is limited by the carryover effect of the neoadjuvant immunotherapy plus chemotherapy? So this is my last slide. This is a summary of what we said before. For the strategy of looking for better biomarkers, up till now, we don't have ready biomarker to be implemented. However, molecular tool may provide the potential biomarker that need to be further investigated. The only potential promising combination is combining immunotherapy with anti-angiogenic agents, and LAG-3 may be a promising candidate to be combined with other anti-PD-L1 checkpoint inhibitor, but needs to be investigated more in triple-negative breast cancer. And in early breast cancer, I think it is critical to know how to select the patients who need the adjuvant part of immune therapy. And thank you very much for your kind attention.
Thank you, Dr. Semani. And now we'll take just a few questions on the floor here. Are there any questions? Okay, so let's see the online. Okay, just one thing. I wonder sometimes, the biomarker is the never-ending story, isn't it? So whenever we discover something, and then it's a marker, after that we want something better. So when we are going to stop and to find the marker?
Very hard question. Science will not stop. When you have a new achievement, you need to have more and more. And you will have new challenges and new questions as well. So I think all of us agree that adding immune therapy to chemotherapy in triple-negative breast cancer is a step forward. Yeah. However, is it the optimal step? Up till now, I think we agree, Dr. Assam, it is not the optimal step. If you look to the overall survival, which is the end point of that the patient or any physician should look to, still we are talking about 2 months median survival. However, the beauty is, if you have, we know that certain tumors will respond to immune therapy, but how to pick them, this is a question. It seems that if you apply more perfect biomarker, it will pick the immune category in a perfect way. However, you will decrease the pool of patients who will be candidate for the immune therapy. For example, the PD-L1 positive patients in the two first-line trials, we are talking about 36 to 41% between the two trials. However, the immunogenic category, basal-like immune-activated subtype, it is 27%. So you will decrease the pool of patients who are candidates for immunotherapy. However, the benefit will be much greater. This is what we can do.
Dr. Assam, can I comment, please?
Yes, Dr. Fahidi, go ahead.
Yeah, so just I would like to comment on the potential barriers for the immunotherapy use. So I think, I don't know if Dr. Sharif would agree with me, but two important points, which I think one is the financial toxicity, and the second is the financial and the toxicity itself. So this medication, the pembrolizumab, is really associated with significant toxicity, hepatitis, colitis, pneumonitis, and you just call it thyroid problems. So I think we need really to learn how to use this medication and how to do a follow-up on those patients and to deal with them. Because really, I heard that we lost some patient in different institutions. Some patients, they were lost because they developed hepatitis, fulminant hepatitis, and they died, despite that they were treated in the neoadjuvant setting for potential of cure. And one patient, another, I heard from a colleague that this patient developed pneumonitis. Myself, I have a patient who had developed vitiligo. So now this patient is having severe skin reaction. So I think the barriers for the use of the immunotherapy, we have always, beside what Dr. Sharif mentioned, is just to remember those two important points, in my view.
Thank you very much, Miteb. Yeah, this is very important, which sometimes we tend to not or we don't pay much attention to. And managing side effects and line of communication between the physician and the patient is very important to pick up these things early, so we will not proceed into the irreversible toxicity that we may lead to patient death or mortality and morbidity. I do believe that this is very important, and this raises the importance of having such coordinators helping the physician in reaching out to the patient, and the patient can reach out to them with the results of investigation, any complaint, so to catch up things early. It's I would call it early detection of side effects and screening for side effects, if we may say so. Thank you, Miteb. Majid, guys, do you have any other comment or question?
No, thank you.
I do have a question, please.
Okay. Miteb, sorry, Majid, you were cut off. We can't hear you. Let's take Dr. Mahrous.
Thank you very much, Dr. Miteb and Dr. Sharif, for excellent presentation. My question regarding the 522 study, as you can see that in the metastatic setting, the Pembro study, it was based on the CPS more than 10%, and we had a significant benefits. However, in the neoadjuvant setting, we are putting in consideration just on a PCR and RD, which is not biomarker-based therapy. And in the meantime, we will give the patient all the treatment at the start, and then we'll give them adjuvant. And it was, I think the benefit, it was more for residual. So do you think this is a treatment changing policy or what? Because it's truly very confusing data. Thank you.
Thank you very much, Dr. Mirvat. This is an excellent question. And actually, when you have, with all the respect of all the physicians who designed the study, I think when you have a confusing design, you will have confusion. Even if you have code data, you will still be confused. So we don't know exactly is the benefit. Traditionally, patients who did not respond to treatment in the neoadjuvant setting should not respond in the adjuvant setting. And even we are saying post-neoadjuvant. Post-neoadjuvant is something that was not given in the neoadjuvant setting. So why do we have more benefit in patients who did not achieve PCR? Is it the carryover effect of the previous immune therapy that have been given in the neoadjuvant setting, or it is the benefit of the additional cycles that have been given in the adjuvant setting? We don't know. So we don't know if it is critical to give the adjuvant part or not. We don't know. And I totally agree with the comment of Dr. Miteb that this treatment is not without price. It's not only the financial price, it is toxicity as well. So I think here the regulators or regulating authorities should have some important design of the study. I think critically we need to have a randomization in the adjuvant setting to know whether the benefit in the non-BCR is related to the adjuvant part or it is only simply the benefit coming from the new adjuvant setting.
So my response to the same question, thank you, Dr. Mahrouz. So as mentioned by Dr. Sharif in the keynote 522, those patients who has no PCR, they actually benefited. And again, this is really raising a question. So we just know that the combination of immunotherapy and the chemotherapy is providing benefit when to use the immunotherapy. So how this single agent immunotherapy in patient who has residual disease led to an absolute improvement of approximately 10% in the invasive disease-free survival. In patient who had complete pathological response, really I will think 100 of times to continue the pembrolizumab in the adjuvant setting. I mentioned in my presentation this WAG 1418, which clearly will answer the question. So again, those patients, whether we are going to give them pembro as immunotherapy or not to give them. So it is a placebo in patients who received the new adjuvant chemotherapy and they have residual disease. And they define the residual disease. They said it's more than 1 centimeter and they have to have positive lymph nodes. And just as I mentioned, that the majority of those patients who participated in this clinical trial, they did not have a new adjuvant pembrolizumab. So this is a question of adjuvant pembrolizumab versus not.
There is a question online from Dr. Radwi, Amir Radwi. We say hi to Amir Radwi. He's one of our senior colleagues at the National Guard Hospital. His comment is that triple negative is a very heterogeneous disease with the present population are not pathways or gene addicted to the use of favor one way over the other. What is the best worked up till I can't see with my glasses, I can't see without my glasses. I don't know what happened now. In terms of negative plan, destructive chemotherapies, immune therapies, I think we need more. It's rather a comment than a question. Yes. Okay, thank you, Dr. Amir. Very well noted, and we hope next time we'll have you among us here.
I have a question for Dr. Metab.
The last question, please. Yes, Dr. Talib, go ahead.
For the residual disease, for the primary index tumor, if it is already achieved pathological complete response, but the lymph node is positive, do you think this is a residual disease and you will give whatever, according to the CREATE-X trial, the capecitabine or adjuvant sitting in immunotherapy? So what is the definition of residual disease exactly? Do you consider node as a residual disease?
So residual disease is residual disease, regardless of the tumor size.
Even if you achieve complete response in the breast itself, but not in the lymph node.
So now we are back to the definition of what is the definition of complete pathological response. So the well-known definition that we have in both breast and the lymph nodes, and we can skip the DCIS. So we are talking about the invasive breast and invasive lymph node.
Thank you, Dr. Matar.
All right. Thank you very much, guys. Interesting session. Thank you, Metab. Thank you, Majid. Thank you, Aisha. Thank you, Dr. Sharif. I'd like also to thank Dr. Harold as well as Dr. Cassidy. And now I will just deliver the floor to Dr. Mahrouz to go ahead with the first satellite symposium. Dr. Mirfat, please go ahead.
Thank you very much, Dr. Morshid, for excellent session. And it was very interesting discussion as well. It's my pleasure to start the Satellite Symposium, and we'll start first, excuse me, with Gilead Company Satellite Symposium. It's my pleasure to introduce our honorable speaker, Dr. Catherine Harper. Dr. Catherine Harper, she is a well-known name in the breast cancer field. She is a medical oncology consultant in Kent Oncology Center, and she has many publications in triple negative and in the breast field, and she is principal investigator and co-investigators in many publications. She will give us a talk about current and future treatment options in metastatic triple negative, see beyond the negatives. Professor Catherine, the floor is yours. Thank you.
Thank you very much for your kind introduction. And I'm afraid I'm going to have to advance the slides using my colleagues, so forgive me. First slide, please. So these are the disclaimers of the talk and just my conflicts of interest. Next slide, please. And as we know, we're talking about a very aggressive clinical form of breast cancer in the form of triple negative. And we're going to be concentrating the talk on targeted treatment in the main. And we know that the distant recurrence is mostly cited in visceral sites in this disease and resulting in a mean to distant recurrence of time of 2.6 years from diagnosis. So a truly difficult problem for many women. Next slide. And this is manifest in its very poor prognosis, and the 5-year survival rates dismal compared to the other tumor types. And this is seen in the SEER data here. Next slide, please. So what is the standard therapy for triple negative breast cancer? Well, we have a problem here. This is a biologically and clinically heterogeneous disease. There's little data in how to order treatments, particularly when we've got new treatments coming into the early setting. And we have to follow these up very closely because of the poor prognosis of the disease with its metastatic treatment. And then clinical trial design is challenging because of the problems with resistant targets. So this is the landscape of triple negative breast cancer. It's complicated, but it does provide us with expanded options and evolving fields in this area. So you've got the intrinsic features, the genetic features, the homologous recombination deficiency aspects, such as the germline BRCA and somatic mutations of BRCA1 and 2, and also PALB2, which is now becoming more important. You've got the PIK3CA pathway, which has been investigated, other genetic mutations, such as the NTRK fusions and MYC-AMP, which is looking more promising. And then you've got the development of subtypes through using the PAM50, such as you've heard before, the basal immune activated and suppressed, the mesenchymal, and the luminal androgen receptor. And then we've also got the proteins that we can target, such as TROP2, HER2 low, which is actually a manifestation of HER2 investigations. And then you've got various others that are coming forward. So it's a mixture of the extrinsic and extrinsic factors, the extrinsic being the immune profile of the tumors. Looking also, the immune spatial distribution within the tumors is looking as though it may be a target in itself. And it's important that we must differentiate from this landscape within the primary tumor versus the secondary. Next slide, please. So let's first look at anti-PD-L1 and PD-1 plus chemotherapy in triple negative breast cancer. And I know you've heard a lot about this, so we'll move quite quickly. Next slide, please. So as we know, this is a tumor with high mutational rate, lending itself to immunofiltration, particularly with T cells. Both T cells are in the immune area, in the tumor area, and then the PD-L1 positivity that can either be measured on immune cells or the tumor cells. And this also lends itself to the difficulty. Next slide, please. So that is the problem. Are you measuring it on the immune cells or on the tumor cells? Are you measuring in both, such as CPS? Are you using enumeration of positive cells, such as CPS? Is it area occupied by the cells? Various different cutoffs. Obviously, the cutoffs used in early disease are different to late disease. And we do believe that there's also a shift in the immunogenicity of early disease into late disease, which is why we are seeing differences in the outcomes of the keynote trials, perhaps. And the platforms we use are obviously different, the Ventana and the DACO. And obviously it's important that the companion diagnostic matches the drug and not to mix up the companion diagnostic with different drugs. They have to be the same ones done in the trials. Next slide, please. But they don't cross over, as we can see from this. And the CPS-10 versus the Ventana, you can see how the differences lie. Next slide, please. So let's look at these first phase 3 studies with PD-L1 inhibitors. You've got the Impassion 130, 131. We won't spend too much time. As you know, that was a negative trial with all the issues related to the paclitaxel, steroids, etc., which have been discussed, and the Keynote 355. Both in metastatic, inoperable, locally advanced triple-negative breast cancer, no prior therapy for triple-negative breast cancer in the advanced setting. The difference between 355 and 130 is 6 months PFI from adjuvant treatment or early treatment, and 130, 12 months, and similar co-primary endpoints. Next slide, please. So you can see from the 130 that you have it was a hierarchical design. In the PFS, you have the ITT with significant, allowing for significance to be attributed in the PD-L1 population with good results here, with the hazard of 0.62 and a significance there, and then carried through into the overall survival. Unfortunately, not allowed to attribute a p-value, but clinically significant overall survival benefits. Next slide, please. And again, with the Keynote 355, you have this with PFS, with the CPS greater than 10, you have a significant PFS and the overall survival benefit carried through as well. Next slide, please. So what about the story of targeting PIK3 and AKT pathway in triple negative? So again, returning to the landscape, this is the area we're trying to target with the AKT inhibition. Next slide, please. And we've got several trials in this area. The Lotus trial and the PAC trial, looking at ipatasertib and then capivasertib versus paclitaxel and placebo, combining paclitaxel, with significant PFSs in the altered PIK3, AKT, PTEN pathways in both trials. But unfortunately, when we looked further, next slide, please. And with the Lotus trial, you see that when we actually looked at the overall survival in the altered state, there appeared to be no difference. So this was disappointing. And in the next slide, please. In the PAC studies, again, the overall no meaningful differences were seen in terms of benefit with the capivasertib between patients with or without alterations. So targeting this did not actually make any difference. It was a universal effect. And this has been carried through into the Opportunity 130 study, using ipatasertib with paclitaxel again, but measurable with the PIK3CA AKT being altered, looking specifically at that group, no prior chemotherapy, greater than 12 months since last neoadjuvant or adjuvant chemotherapy. And again, you can see absolutely no benefit. So really these have not been taken forward into standard of care at this point. Next slide, please. So what about the PARP inhibitor pathway? Next slide, please. And again, we're looking at the homologous recombination deficiency pathway, looking at both dramatic and somatic now mutations in these BRCA particularly, and PALB2 coming forward. Next slide, please. And the two main trials in this were the Olympiad trial with olaparib and the Embraca trial with tildacerib. And the trouble with these is there was significant median PFS improvements, as you can see here, but they have not shown, they have not actually investigated subsequent to platinum therapy. Of course, this makes it quite difficult now because we are following the Brightness study using a lot of platinum in the early setting. And, you know, many of these patients are relapsing just around the 12-month time point. So where does this sit following carboplatin? We don't know. If you, next slide, please. And that's just the response rate. Next slide, please. And in the Brocade study, where they actually combined with carboplatin, olaparib, which is not such a good PARP trapper as olaparib, looking at versus placebo and carboplatin and paclitaxel, they had two or less lines of cytotoxic therapy for metastatic disease, and one prior line of platinum, but no progression for 12 months. So within the 12 months. And you can see that a range of chemotherapy, sorry, next slide, please. You can see that the PFS is improved, but the benefit is actually after the carboplatin has stopped. So perhaps there's actually only benefit in using this after the carboplatin, so following a sequential schedule rather than the combined. The PALB2 does seem from this waterfall plot show to have benefit in both these agents, and this is now being investigated. Next slide, please. So we've got this study that was presented at ASCO last year, this phase 2 multi-center study of talazoparib for somatic BRCA1 and 2 mutations. And this is a single arm versus, and it's recruiting now, and hopefully we'll have an answer as to how this actually works out in the somatic. Obviously, if you have a somatic mutation, if you reflex test for a germline, you're likely to find it, but not always. So this is an important point we need to investigate. Next slide, please. So what about the role of ADCs in metastatic triple negative? Next slide. So these are the new kids on the block, very exciting drugs that have the following characteristics. Obviously, we have a tumor antigen, which can be present in many tissues. We have an antibody which has high affinity for that antigen. And then we have a linker, which is stable in plasma, but efficiently releases the payload of a potent cytotoxic, in many cases, into the cell. Next slide, please. And so this is how it works. You get binding of the ADC to the antigen, internalization with the early endosome, and then degradation of the ADC in the lysosome, and then release of the payload inducing apoptosis. Next slide. But this toxic payload is giving a bystander effect, and this may be the clue as to why these agents are so useful, is this bystander effect. Next slide, please. So as you may be aware, there are drugs in this area that have been approved in both Europe and US. So there's trastuzumab mantasine in HER2 disease in early and late setting, and there's trastuzumab deruxtecan, which is also approved in this setting, in the secondary setting. But saxatuzumab govitecan, which we'll call SG from now on, is being approved in the US and Europe only at present in second line. So, sorry, if you could go back, please. So this whole issue of HER2 status, this is a diagnosis really, or is an entity of exclusion, of excluding positivity. And you can see that it's quite prevalent in triple negative, as you would expect. So mostly dominated by the HER2 0, but there is a reasonable number of IHC 2+ and 1+ in this triple negative group. Next slide, please. And this indicates that from the using trastuzumab deruxtecan and phase 1b study in HER2 low, that there is activity, mostly in the HER2+, but also in the HER2 1+. Next slide, please. So if we look at trastuzumab deruxtecan as one of the first of these novel drugs, this has got all the components that you would expect. It's got a humanized anti-HER2 IgG antibody with an amino acid sequence similar to trastuzumab, carrying a very toxic payload, the exatecan derivative, topo1 inhibitor, and the tetrapeptide cleavable linker. So importantly, this high drug to antibody ratio of greater than 8, and this stable linker, which are the two important key factors I feel in these drugs. So we're going to see released at ASCO the very positive data for the Destiny-04 study, looking at trastuzumab deruxtecan versus chemotherapy in previously treated HER2 low breast cancer. And these are women and men with unresectable and metastatic HER2 low cancer progressing on endocrine therapy, 1 to 2 lines of prior chemotherapy, and of note, particularly nobody obviously allowed HER2 positivity, so making sure we rule out those genuine HER2 positive cases. And this is met its primary endpoint, and we'll be hearing about this at ASCO. Next slide, please. So where do we go with this whole HER2 story? Is it that we've got basically an entity that is really just being targeted by ADCs that have got an incredibly high high toxic payload and therefore are really performing by bystander effect. And are these novel ADCs with higher DAR, drug to antibody ratio, and cleavable linkers, are they going to be better with greater activity and greater toxicity? Look, we do need to actually be clear about what we're actually measuring. So we do need to define the cutoffs for HER2 low. There is incredible disparity between and within laboratories on defining HER2 1+ and 2+ as an IHC, because it's IHC. So this needs to be really worked on. But it is there in triple negative breast cancer, so we do need to pay attention to it. And it's a high prevalence in the metastatic compared to the primary setting. And we're seeing in the Begonia trial, for example, that there's robust activity of TXD plus Nivolumab, and that's irrespective of PD-L1 status. So there is indeed great promise. But then the DAISY trial, which has also shown that HER2 0 gain benefit. So it's an interesting field. Next slide, please. So let's look at SG, Sacituzumab govitecan, first-in-class TROP2 directed ADC, and the only one that's been approved for triple negative breast cancer. As I say, has all the important features, a very toxic payload, the SN38, the stable linker, and the TROP2 directed antigen effect. Next slide, please. So this is the seminal trial, the registration study, ASCENT, a phase 3 confirmatory study of Sacituzumab in refractory relapsed triple negative breast cancer, metastatic breast cancer, greater than 2 chemotherapies for advanced disease. 1 required prior regimen could be from progression that occurred within 12-month period after completion of neoadjuvant treatment. So picking up these very difficult patients with stable brain metastases, as is normal in these type of trials, they were allowed, but they weren't included in the primary endpoint analysis. Randomized to 10 milligrams per kilogram IV of SG, days 1 and 8, every 21 days, and then TPC, treatment of physician's choice, eribulin, vinoralbin, capecitabine, gemcitabine. So a fair representation of what we would use as perhaps second line. And treatment was allowed till progression or unacceptable toxicity, and the endpoints is here. Next slide, please. So this, just to show you that the characteristics were well balanced, and just to point out that a good range of ages here, up to 82, so median of 54, but a range of ages included. Also BRCA positivity, and interestingly, people who had been diagnosed TNBC in the metastatic setting, indicating a metastatic biopsy was utilized to actually define them as triple negative. So not just using the primary diagnosis. And again, PARP inhibitors represented well, previous PARP inhibitors and previous use of checkpoint inhibitors. And again, a reasonable number of visceral load patients in this study. Next slide, please. So truly impressive results for this heavily pretreated group. So from this analysis, the BICR analysis, we see a significant PFS, median PFS 5.6 versus 1.7 months, and then overall survival with a significant difference, and hazard ratios, again, very good hazard ratios. Next slide, please. And again, in the if you look at the intention to treat population, this is still carried forward, and again, significance in both PFS and overall survival. Again, it's truly impressive for a difficult population. Next slide, please. So trying to pick out subsets that may or may not benefit, nothing, absolutely clear. Obviously, the no effect boundary crossed there by the Asian population, very small numbers, so not confidence intervals, not surprisingly crossing there. Next slide, please. So what about the TROP2 expression? Does that have any leverage on the benefit? Well, essentially, as your TROP2 expression increases from low to high, your PFS does improve, but basically there's benefit across the board. It's not felt that it's appropriate, therefore, to use this as a biomarker to select patients. And so the drug has been approved without TROP2 being utilized as a biomarker, which is appropriate, bearing in mind this graph. Next study, please. Next slide, please. So what about the safety? So you have to get something for a very effective drug. This drug isn't without its side effects, but essentially it is manageable. There is an increase in neutropenia such that there is an increase in the febrile neutropenia there, and therefore the GCSF usage was higher compared to TPC. There were dose reductions, but they were similar across both arms. And there's importantly no severe cardiovascular toxicity and no greater than grade 2 neuropathy. And importantly, as an ADC, there was no grade 3 interstitial lung disease. It is not a significant problem with this drug. No treatment-related deaths with SG, and AEs leading to discontinuation were low and similar between both arms. Next slide, please. So this drug has now been approved for patients with greater than 2 lines of systemic therapy, at least 1 in the metastatic setting. Next slide, please. So what about the story with HER2 low? Well, as you can see here, from progression-free survival and overall survival in both HER2 low and HER2 zero, this is still beneficial in both of these groups. So this is of clinical benefit in both these groups in metastatic triple-negative breast cancer, regardless of HER2 status. Next slide, please. So what about some newer agents? Well, we've got a TROP2 ADC in development. So this is a humanized anti-TROP2 IgG antibody, which is combined with deruxtecan. And this is a humanized anti-TROP2 IgG with a topoisomerase payload with DXd, which we all know, with the linker again. And this is being run now and hopefully will show activity. Next slide, please. And this is in the tropion pan tumor 1 and has already started to show some activity. And we've got low numbers at the moment, but there's 24 patients treated at 6 milligrams per kilogram dose and a couple at 8 milligrams per kilogram dose. And the treatment is ongoing in 18 patients and 6 patients have discontinued, and all due to disease progression. So that's being assessed for the standard effects of safety, etc. Next slide. So we have 3 drugs currently, ADC drugs that have been approved in the US and Europe and the UK. But there are many questions that remain. Are they going to become standard for HER2 low in breast cancer? Will TROP2 ADCs work in hormone receptor positive breast cancer? And if one ADC works, can you follow it with another one? Are you going to target non-resistant pathways? And will you be able to pick up new payloads, tap them onto the antibody, and create a second effect? And again, are there optimal combinations with other medications? Next slide. So let's look at the guidelines we currently have. And if you add the next slide, please. So we've obviously, in the NCCN guidelines, we've got the use of pembrolizumab. Atezulusumab has now been dropped in the US due to the Passion 131. And you have got for sacituzumab approved for triple-negative breast cancer, received 2 lines, as we said, for metastatic disease, and 1 in the metastatic. 2 lines with 1 in the metastatic. Next slide. And then obviously for germline BRCA1 and 2 mutations, they should be tested for all patients who could possibly receive olaparib or talazoparib. The ESMO guidelines, I really like these because they really direct therapy according to the biomarker, and these essentially are saying is your first line therapy, even if you are a BRCA patient, is to receive PD-L1. If you're PD-L1 positive and BRCA positive, is to receive immunotherapy first, and that is atezolizumab or pembrolizumab in Europe. If you are BRCA mutated, then they would prefer they advise that you use PARP inhibitor-based therapy over chemotherapy, and that the chemotherapy, if these patients are, although and these are very well tolerated drugs, from the triple negative trial, it would be carboplatin if you haven't used it, and if you're PD-L1 wild type and BRCA wild type, then combination chemotherapy or sequential chemotherapy, depending on your visceral load, stroke crisis. And then second line is obviously SG, and third line further chemotherapy. So what is standard for triple negative breast cancer? Well, yes, it's not one disease entity, but we've got several actionable targets that perhaps can be combined and with trials that are looking at that. What about the order? Well, we're stratifying in clinical trials now for previous exposure, and we'll be able to draw out as a result of that how treatment should be designed. And the clinical trials are able through the ADC to look at non-resistant targets and try to further improve outcome. So I'd like to thank you for allowing me to present this data, and I'm happy to take any questions.
Thank you very much, Catherine, for excellent presentation and overview. And we are very sorry for the delay. My question first regarding that, you presented that in ESMO guidelines, the Atezo is still there, and we know that the Atezo plus it was withdrawn with FDA, and because non-confirmatory data. Is still that Atezo have a rule in triple negative patient, specifically that we do have the IM patient 131, it was positive, however 130 it was negative based on the just only paclitaxel. So what do you think that we do have Atezo, we have Pembro as a proven, and also I will go for the point that as a subsequent therapy as well. Go ahead. Thank you.
Yeah, I mean, I think, you know, obviously our problem is that we're going to probably get 522 approved, and we're going to have pembrolizumab in the early setting. So that makes the whole metastatic setting difficult. We don't know the answer. It's probably going to be the same rules, i.e. greater than 12 months exposure from your last dose of immunotherapy before you could consider immunotherapy again, but we just don't know. I mean, this is, you know, if you've suffered any toxicity, you're unlikely to be able to, but equally, if you've gone 15 months in the early setting having immunotherapy, you are unlikely to have the immunotherapy toxicity. We know that 15 months seems to be a cutoff when you don't develop the itises. So maybe those are the candidates that can have subsequent immunotherapy in the advanced setting, to be decided. In the first part of your question, we still have Atezo on there with nab-paclitaxel. Many of our patients have been exposed to paclitaxel in the early setting. And so we feel that it's a different drug, as it were. So we feel a little bit more confident with it. And but as you say, you know, the data from 355 is very promising. And also for the patients that relapse earlier, then that is a better drug. You know, you've got better data there. Also, I quite like the combination of chemo they had allowed there. You know, that is a realistic combination with carboplatin in there. So but again, we have carboplatin now. We follow brightness very closely in Europe. We're giving all our patients carboplatin in the neoadjuvant setting. Very few patients don't get neoadjuvant chemotherapy with platinum now. So, you know, they've all been exposed. So that if they relapse within 12 months, you know, it's difficult.
You presented very nicely the SG data, and I agree with you totally in heavily pretreated population, refractory patient, and we do have this response rate and PFS. My question that if the SG data, they included patient was, because we have a stratification regarding the triple negative purely, or patient was low expression ER. So they were included in the study because in the subgroup, we don't know exactly this part. And the other part of the question regarding the brain metastasis was allowed in the study, and we didn't see any in the subgroup analysis. Thank you.
No, I mean, they weren't allowed in the primary analysis, and that's you know, may come out later. With regard to ER, I understand there's no particular difference. So you know, they're a triple negative. So are you talking about ER or HER2? Because the HER2 data is there. Obviously, as an ER patient, then they weren't included in the study. So they had to have a minimum of, you know, 3 and under by Aldred score.
We do have a question from the floor that for a patient with BRCA positive patient to go for IO therapy as an upfront, or olaparib or PARP inhibitor, followed by the SASI of the patient as they are progressing. So the point that in the SG data, IO is what not included in the study. It was only PARP inhibitor, and in the guidelines as well, it was putting, but we don't have data that this patient, they are responding to SG.
I think in the study there was PARP inhibitors and IO so that has been there were small numbers, but they were there. With regard to what you should use first for patients in the first line setting, metastatic setting, triple negative, if they are PD-L1 positive and BRCA positive, the ESMO guidelines I think are fair because of the overall survival benefit data. They are suggesting that you utilize your IO first. Followed if you have availability of drug to use PARP inhibitors. That's the difficulty, is having access. I mean, obviously in the UK, we don't have access like that. We don't know we don't know whether you should follow PARP inhibition following from IO. But obviously in the Olympia study, we are allowing that, and in the Olympia trial data, they're suggesting they're coming up with a plan for you to use it in the early setting, that PARP should follow IO. So, is built in as recommendations. And in the ZEST study that some of you may be taking part in, the IO has been built into that. So indicating that sequential use of these drugs is probably okay.
Perfect. I would like to thank you so much for your presence and contribution. And it's my pleasure to close the Satellite Symposium for Gilead Company. And we'll start in the next symposium, which is for Amgen Company. I would like to introduce our meeting chair, Dr. Essam Morshid. Dr. Essam, please, the floor is yours. Thank you.
Hi, good evening, everybody. I hope we are still awake after a long day. It gives me a great pleasure to introduce the second satellite symposium for the breast session, which is sponsored by Amgen, and it goes around the biosimilar. Our speaker is distinguished associate professor and senior consultant medical oncologist at the Department of Medical Oncology at Salamanca University. He is the head of the breast cancer unit as well within the same institute. Dr. Cesar Rodriguez is also, Sanchez is also the vice president of the Spanish Society of Medical Oncology. Maybe I'll call it SIOM, if I may say so. And also he is the chairman of the biosimilar working group within the society. He is a co-author and author of many books, chapters, and peer-reviewed articles. And he's an invited speaker in many prestigious international and national conferences, and he's going to talk to us about biosimilar. Dr. Sanchez, please, the floor is yours for 30 minutes, sir.
Thank you. Thank you very much for the kind introduction. Thank you very much to the organizing committee for this kind invitation to take part in your prestigious meeting. I'm going to share my presentation. So let me, 1 second, please. Okay, it's okay?
Yes, okay.
Okay, thank you very much. Well, I'm going to show you in the next 20 minutes, 25 minutes, the role of trastuzumab and in general, the role of biosimilars in the management of breast cancer, and specifically in HER2-positive breast cancer. These are my disclosures. Well, why it's important to consider the use in the clinical practice of biosimilars in oncology. Probably in most cases, we are always thinking in a problem of saving costs, but at the present, we think that this is a problem that is not the only one. We should consider that the saving cost in oncology can be reimbursed, can be used again in projects for better care of our patients and also a better care in the global health system. I will take some seconds at the end of presentation for this question, because we're always thinking that using biosimilar we can save cost, but we can use them also for a better health care for our breast cancer patients. Well, in a brief consideration about biosimilar, you should remember that the biosimilar is a drug that is not the same that the original drug, because although the proteic structure of the drug should be identical to the original one, we have some differences regarding glycosylation, fucosylation, and other characteristics of the drug. But we should consider that these differences should not affect to the efficacy or safety profile of the drugs. And very important consideration is also this. The variability that exists between a biosimilar and the reference drug is not different from that we have between the different batches of the reference product. This is a very simple example. If you see at the left of the slide, you can see 3 different drugs. One is the biosimilar in green of Trastuzumab, and the other 2 are original drugs, Herceptin from the US, original Herceptin from the European Union. You see that there are differences in the characteristics of the drug regarding glycan profile, but there are also differences between batches from the European Union and US drug. So we should consider that a biosimilar is different of the original drug, but one batch of the original drug is also different to the other batch of the original drug. And this is for the molecular profile, but also for the efficacy profile, as you can see in the right part of my slide, when I show you the antibody activity of different batches of original Trastuzumab and the biosimilar. And also here you can see that the number of changes that European Union has approved during the last year for Trastuzumab, 26 changes in the structure of Trastuzumab until 2016. So you can see that we are not talking about anything new. We are always using a biosimilar of the original drug when we use a different batch of the original drug. But what are the key points in the development of biosimilar, and what's the relative importance? This is important because we should consider that the most important part in the development of biosimilar is the low one, this one, is the molecular analysis and the biological quality assessment. If we can show that the biosimilar is similar, have an identical activity in the molecular analysis and the biological quality assessment, we can consider that this there is a very few probability of have differences in the activity in clinical practice. One example, again, considering a biosimilar of Trastuzumab and 2 original drugs from Europe and US, in a chromatography analysis on the left of the slide, you can see that there is no difference. You can say to me, if I don't say you who is the original or who is the biosimilar, which are one of the drugs. At the right part of the slide, you can see again fucosylation, glycosylation, and you see that when we consider this analysis of the molecular profile, the properties, analytical properties of the drug, very similar. And this should be done also in activity. This is an article comparing biosimilar to original drug, and this is evaluation of analytical similarity when we consider activity in antibody activity mediated by lymphocytes and the anti-proliferation activity. They are very similar. So then, after this molecular analysis, we should consider pharmacokinetics and pharmacodynamics comparison and pharmacology in terms of safety also. And look here, probably you are, if you see the slide, you can see only one line, but I can tell you that there are 3 lines. And these 3 lines are biosimilar and 2 original drugs from Europe and from US, and pharmacokinetic properties. In this case, this is a biosimilar of Trastuzumab of Amgen, is not able, looking at the lines and the graphs, to find any differences in terms of pharmacokinetic profile and also in development of antibodies neutralizing to the drug. Well, and then, and only at the end of the development of these drugs, we should perform a clinical comparison. And it's only needed one phase 3 trial, because if we consider the same activity in one phase 3 trial, after all the previous development that I show you, we can consider that it's not probably any differences in any scenario of the treatment in different indications. It is very important to consider what is the best scenario to perform the phase 3 trial, the pivotal trial, to get the indication. In the case of breast cancer, I think that neoadjuvant setting is the best scenario to test the activity of the biosimilar, because the tumors are very, very, very homogeneous, the biopsies are recent, and a surrogate point for efficacy is a pathologic complete response that probably is the best surrogate endpoint compared with clinical response or radiological response when we consider metastatic setting. So I think that the trials evaluating the efficacy of a biosimilar of trastuzumab in breast cancer that used the neoadjuvant model are probably better evidence that those who perform the trials in the metastatic setting. Well, this is an example. This is the study design of the development of the biosimilar of Amgen or trastuzumab comparing with original Herceptin. And this trial has a very nice design, because after surgery, they tested what was the impact of switching from one biosimilar to other, not only compare the activity, but only the switching in terms of efficacy, into event-free survival and overall survival, and in terms also of safety profile. Well, you can see here there are no differences between the pathological complete response between the original drug, trastuzumab, Herceptin, and biosimilar from Amgen, and this can be said not only for the Amgen biosimilar of trastuzumab, but also to other tested in clinical practice and authorized by European Union. Well, these are secondary endpoints for another biosimilar. We should test the pathological complete response, but we can see in a long-term follow-up also the survival effect and the disease-free survival, same data. Well, and finally, we should consider a safety profile. And you see here, there are no differences in terms of any toxicity, and also in cardiac toxicity when we compare the biosimilar and the original drug. In this case, this is another biosimilar of trastuzumab from Samsung. Well, then what we can consider after this data. I like this position paper from the European Society for Medical Oncology, because there are two points that are key points for the clinical practice. First one is extrapolation to all indications. We only need, as I said before, one clinical trial, one phase 3 trial to can extrapolate to all the clinical indications a biosimilar. If we have positive data from one clinical scenario, we can go again to other scenarios. If we have positive trials in neoadjuvant setting, we can use with no doubts in this moment biosimilar in metastatic setting, in the adjuvant setting, and in all of the stages of the disease. And there is another situation, is interchangeability from and switching from the original drug to biosimilar, or the biosimilar to original drug. And this is very important. We have data that we can consider in terms of safety, in terms of efficacy, but the physician should be well informed about the products. All the parts of the clinical practice should know at every moment that they are performing a switching. Also the patients, also the institution, also the pharmaceutical department. So it's important because we should monitoring closely the possible changes in activity and also in safety of the drugs. So extrapolation can be considered safely, and of course switching can be considered also in the clinical practice, but all parts of the institution should be informed. I would like to show you this paper for review, in which we can see that we can make correctly comparability studies enough to consider switching from the reference product to a biosimilar, from a biosimilar to other biosimilar. But remember, the multi-switching has not been tested in clinical practice, so it's not recommended. One switching can be done from the product of reference to biosimilar or in the inverse direction, but multi-switching should not be considered at the present. Finally, I think this is the most important way. When we start to use a biosimilar in clinical practice, the post-approval trials, the post-approval data are very important. We have to take all the information for real-world data setting to know the efficacy pattern and the safety and the patterns of use of the drug, and phase 4 trials, and also data coming from real world use should be done. I'm going to show you 3 experiences in this sense. First one is the German experience with the trastuzumab biosimilar in the university, from the Bavarian University Breast Cancer Centers. And you can see here the patterns of use of trastuzumab before 2018, and most of patients were treated with Herceptin, of course, and the venous presentation, but also subcutaneous. And you can see on the right part of the slide the change from 2018, and vast majority of the patients were switched to the use of biosimilar. And it was done in all of the scenarios of the disease, in the neoadjuvant setting, in the metastatic setting, in the adjuvant setting, and also in a single therapy, but also in combination with pertuzumab. Pertuzumab plus trastuzumab has not been tested in the phase 3 trials of biosimilars, but if we consider the properties of the drug and the results of the phase trials in the neoadjuvant, is not probably we will see any differences in terms of efficacy when we combine the biosimilar of trastuzumab plus pertuzumab compared with Herceptin plus pertuzumab. And see here that this is very clear in this evaluation of the efficacy in the neoadjuvant setting. We can see that the pathologic complete response obtained until 2018 with Herceptin original is not different to those obtained with the combination of pertuzumab plus trastuzumab biosimilar. Indeed, we have better results because probably we have better population, but there is no evidence, there is any evidence of a worse result with the biosimilar. And this is a second example. This is a study performed in Europe, in some countries of the European Union, about 500 patients across 8 countries in Europe. And especially we can test here the patterns of use, the safety profile, the scenarios in which we are using the combination of trastuzumab biosimilar. Well, this is a retrospective and prospective trial. It has been closed for recruitment. 500 patients has been included in this study, and we have data coming from San Antonio 2020 of a preliminary analysis, and the final analysis of the trial is going to be presented at ESMO in Paris this year. The primary purpose, the primary endpoints of the trial was demographic and patterns of use, concomitant treatments, exposure to prior trastuzumab, switching, this is very important, and places where we are using the biosimilar, but also safety profile as exploratory endpoint, and of course, efficacy analysis. We don't have data from the last endpoints. We only have data, preliminary data from the primary objectives. This is the poster presented in San Antonio. And there is one problem regarding this trial and 3 questions that we should consider about the use of trastuzumab in Europe. And these are the 3 questions. First one, in many centers, there is not a real policy and well-documented policy for the use of biosimilar. We have to use protocols. We have to document that we are using a biosimilar, and you see that only was documented correctly in less than 1/3 of sites that recruited patients for this trial. So First question is this: we are not doing it correctly. We should consider a better documentation to show what patients are using a biosimilar, what patients are using an original drug. Second question, and this is very important, not all patients are well informed about the drug they are using, and we should consider that they should do. And finally, in the documentation, not always is mentioned what kind of drug is being used by the patient, if the biosimilar or the original drug. This is the positive part of the trial. The biosimilar is now being used in Europe in all the scenarios of the disease: adjuvant, neoadjuvant, metastatic, and in metastatic disease in all lines of the disease. So it's very important. The biosimilar has come to Europe, and they are to stay here and look independently of the estrogen receptors or the stage of the disease. And look here, and more than 1/3 of the patients included in the study, in the preliminary analysis, we have performed switching. So the switching has been adopted by the clinicians in Europe as a very, very conventional procedure. 44% of patients were switched from intravenous trastuzumab, but also look here from subcutaneous trastuzumab. Sometimes, and it can be done from another biosimilar, but in most of cases from the original drug. In conclusion, from the Gardenia trial in Europe, we see that we consider that the biosimilar of trastuzumab has been now using in all of the stages of the disease, in all of the scenarios. The switching is very, very common in Europe, but the problem is we have to document better the way we are using the drugs. This is the enrollment by country, with Spain in the first place and France in second. And finally, I will show you a very, very brief experience in Spain, in our region. In Spain, we are using trastuzumab from 2018. And I'm coming from this region, Castilla y León, with 2.5 million people. And look here, in 2018, we were using trastuzumab only in 23% of patients with breast cancer. Next year, 66%, and in 2020, in almost patient. In our institution, 72 patients received trastuzumab until February 2021. This is a very brief experience. And look here in the neoadjuvant setting, 23 patients, and what's more important, all of them combined with pertuzumab in the neoadjuvant setting. And this is very interesting because the efficacy endpoint, the pathological complete response, is very robust endpoint, and we should analyze correctly this data. Well, most of them were treated with anthracyclines. These are the stages. We have 1.5 patients with estrogen receptor positive and the other half negative. And look here, when we combine the biosimilar of trastuzumab with pertuzumab in the neoadjuvant setting, we have a 74% of pathological complete response. These data are very impressive, and we can consider the efficacy of biosimilar in this very pure scenario can give us a very, very interesting information about the efficacy and also the safety, because we didn't have any cardiotoxicity in all the patients treated, and the efficacy is very comparable considering hormonal receptors positive or negative. So our preliminary data confirm a high efficacy in terms of pathological complete response when we use trastuzumab biosimilar with pertuzumab. The results are comparable considering the expression of hormonal receptor, and there have not been reported unexpected adverse events in the first analysis. We are ongoing in the recruitment. We have more than 50 patients now in the neoadjuvant setting and more than 100 patients in all of the scenarios of the disease. So now we are working in this interesting program. We are reducing the cost of the care in our breast cancer patients. So we are now reimbursing this saving cost in new projects for our patients. So we are not only saving costs, we are doing a better outcomes for our patients with higher patient satisfaction, and of course, in how enhances the healthcare system. Well, this is all from my presentation. This is my city, Salamanca in Spain. It's a very beautiful place, and I hope to see you here sometimes. Thank you very much for your kind attention.
Thank you very much, Professor Sanchez. Now, because we are very behind in time, just one comment, maybe you have heard this before. The use of biosimilar, which precisely I'm talking about, trastuzumab, the combination of trastuzumab plus pertuzumab, this is one thing. The other thing is that all the available biosimilars now are IV, and we have subcutaneous trastuzumab, as you know, and this represents a major challenge in adapting the biosimilar, especially if we are talking about the cost effectiveness, decreasing the incidence of patients coming to the clinic or the clinic visit, the day unit administration, the pharmacy, etc. So what's your comment about these two things, please?
Well, this is very, very important question. Now, we have the presentation of subcutaneous trastuzumab, but now we are going to have also combination of pertuzumab and trastuzumab. In Europe, it has going to be an imminent indication. Well, we have to take in consideration all the data together, and it depends probably on the healthcare system we are considering. Probably in a system, in a private system, in which the cost of the nursing, the cost of the day hospital time you need to give the drug, and if you take in consideration of this, all of these questions, probably you should consider that the combination of a subcutaneous way of pertuzumab plus trastuzumab can be cost effective. But for example, in public systems or systems in which you have to administer the drugs, all of them in the hospital, probably saving costs from biosimilar of trastuzumab can be cost effective compared with a combination of pertuzumab plus trastuzumab subcutaneous, because the cost of this drug is very high. So it depends what do you want to do with your money. You can save money using a biosimilar and can use this money to other programs or to save costs from your system, because you have the same efficacy, you have the same safety profile. Or maybe you can save time from the administration or save time for the patients not going to the hospitals so many times. It depends on. For example, I'm going to show you one question. If you use combination of pertuzumab plus trastuzumab in the neoadjuvant setting and you are giving an intravenous drug like taxane, probably there's no problem to use all the drugs in the intravenous way, because the patient is going to receive chemotherapy and need to use an endovenous treatment. If you are using it in the adjuvant setting without chemotherapy, probably you should consider in some moments the use of subcutaneous way, because the patient doesn't need any endovenous drug. So it depends on the moment of the treatment, of the time you have in the hospital for administering drugs, and probably also the time for patients. It's not easy to answer this question.
Thank you very much. It was a pleasure having you among us here. And inshallah, we hope to see you, a lot of you, in the future. Thank you very much, Professor Sanchez. Thank you very much, guys. And now I think without any further ado, we'll move to the third satellite symposium, which is sponsored by Lilly. And it will be about hormone-positive breast cancer, toward the future. Our presenter and speaker will be Dr. Aisha Al-Harbi. Dr. Aisha Al-Harbi, as have been introduced before, is a consultant medical oncologist at the King Fahd Armed Forces Hospital and in Jeddah. And she's well known in the field of breast cancer, with special interest of breast cancer and GI cancers. Dr. Aisha, you have 30 minutes minus some minutes. It's up to you. Okay, so we can go to dinner. Thank you very much. Aisha, please, the floor is yours.
Thank you, Dr. Assam, for your nice introduction. So as mentioned by Dr. Assam, this is my topic that will I just highlight important present target agent in the hormonal positive and the future and upcoming data for that. So this is a disclosure. As we know, luminal breast cancer is heterogeneous disease, and this heterogeneity shift the tumor from early stage. My voice is clear or no? Yeah. And this heterogeneity shift the tumor from early stage to metastatic stage, as we see here in the MATCH trial that published in 2015. We see less luminal A shifted to the metastatic stage and more luminal B, and also HER2 enrich. With that, there is no difference in treatment recommendation based on luminance subtype. This is the big shift treatment, or the biggest change in the hormone positive metastatic breast cancer. As we know, we have three CDK4/6 inhibitor that evaluated in 3 phase 3 trial, which is PALOMA-2, MONALEESA-2, and MONARCH-3. Actually, these 3 trials that evaluated the CDK4/6 inhibitor with letrozole in any treated patient, post-menopausal. And also we have one trial, which is MONALEESA-7, that evaluated ribociclib with aromatase inhibitor with ovarian suppression agent or tamoxifen. That was the trial in pre or perimenopausal. If we see the BFS, it has a similar hazard ratio across the 3 trials, and also showed improvement in BFS and BFS2. That mean a prolonged progression to the second line. If we move to the overall survival data, we see that ribociclib trial that reported overall survival in MONALEESA-2 and also in MONALEESA-7 with hazard ratio 0.76 and almost similar hazard ratio. We are waiting to see the data for overall survival for PALOMA-2 and MONARCH-3 in upcoming ASCO. This is the updated overall survival from MONALEESA-7 with median follow-up 53.5 months and improvement in overall survival by 10 months and with hazard ratio 0.76. Also delayed time to chemotherapy and prolonged chemotherapy-free survival. Also, if we move to the MONALEESA-2, as we mentioned, that showed overall survival benefits. Ribociclib achieved significant overall survival benefits in MONALEESA-2. It has improvement in overall survival by 12.5 months with hazard ratio 0.76. And as we see here, that overall survival was beyond 5 years with overall survival rate 52 at 5 years. And overall survival was independent of metastatic site, number of site, and prior therapy. Also, the overall survival benefit with ribociclib increased over time, as we see here in the 72 month or 6 year, there is improvement by 12.2% in overall survival compared to the 4 years with 5.7%. Also, there is a rule for CDK4/6 inhibitor as second line, but to progress on aromatase inhibitor. As we see here, we have 3 phase 3 trial that approved in second line, which is that evaluate the CDK4/6 inhibitor with fulvestrant. There is some variation in the study design and population. If we move to the MONALEESA-3, that including patient on first and second line. And for MONARCH-2, didn't allow prior chemotherapy for metastatic disease, and only prior endocrine therapy, only one endocrine therapy were allowed prior to abemaciclib. If we move to the PALOMA-3, we see more resistant population, as third of patients that receive prior chemotherapy, and any number of lines of endocrine therapy were allowed. For overall survival, we see that in MONARCH-2 has a ratio 0.75, similar to that in MONALEESA-3, which was 7.2, but in PALOMA-3, 0.7 now, which is not much significant. This is the overall survival data for MONARCH-2, showed 9.4 month overall survival benefits with median follow-up 47.7 months, and also delayed time to chemotherapy. MONALEESA 3, as I mentioned, that include patient in first line and second line. If we see that patient in first line, actually, if overall survival net rich, if we see the combined population, we see almost overall survival with ribo and fulvestrant 53.7 months compared to 41 with placebo and fulvestrant. It's really important that I would like to mention it. For Paloma 3, updated overall survival, we see that patient didn't have or no prior chemotherapy. The median overall survival was 39 versus 29 for placebo group with hazard ratio 0.72. In contrast to patients that receive prior chemotherapy, there is hazard ratio 0.97. So that means that patient didn't get a benefit. The group that received prior chemotherapy didn't give a benefit from adding palbociclib. So sequencing of endocrine therapy sometimes or more benefit instead of moving to chemotherapy without indication. The common questions: what the good partner with CDK4/6 inhibitor? Is it aromatase inhibitor or SERD? Actually, in this data that study the efficacy and safety of palbociclib with letrozole versus palbociclib with fulvestrant. If we said the BFS, we see similar BFS. So there is no difference, but usually prefer oral instead of injection. If we move to the toxicity of 3 CDK4/6 inhibitor, all the 3 treatments are well tolerated. And usually the physician prescribe this CDK4/6 inhibitor based on his experience, based on toxicity profile, and patient characteristic. As we know, the dosing schedule for palbo and ribociclib are similar, 3 weeks on and 1 week off. With amibaciclib, it was continuous dosing. Neutropenia, it's more with ribo and palbociclib, less with amibaciclib, and GI toxicity with amibaciclib more than the ribo and CDK4 and palbociclib. And QTC in prolongation, it was more with ribociclib, as we know, and will be more with combination with tamoxifen. Alopecia, usually it's not more than a grade 1 in the 3 CDK4/6 inhibitor. And the unique side effect is increased creatinine in the amibaciclib, which is usually with normal renal function. So we have a still ongoing study that will be presented in this ASCO, which is a maintained trial. That study the use of ribociclib in patients that progressed in a prior CDK4/6 inhibitor. And also Paloma trial, that use of that study, still these 2 are ongoing trial. So it's use or re-challenge of palbociclib in patients that progress in palbociclib with hormone treatment, with change the endocrine therapy with palbociclib. We know ASR mutation has, patient with ASR mutation has relative resistance to aromatase inhibitor. And this combined analysis of SOPHIA and EFFECT trial that we see that compared ASR with mutation in fulvestrant versus exemestane in hormonal positive metastatic breast cancer. If we see here that patient with wild type patients with wild type have similar benefit from fulvestrant and exemestane, as they have similar BFS and overall survival. In contrast to the patient with ASR1 mutation, patient with fulvestrant, they did more well or more benefit than the exemestane. For that reason, we have more than one targeted agent or more than one ongoing trial that study the efficacy of different targeted agent in patients with ESR1 mutation. One of these, this Emerald trial that presented the first oral SERD. Actually, this is trial in hormonal positive HER2 negative. Patient progressed on 1 or more line of endocrine therapy for advanced disease, or that patient or has received prior endocrine therapy, were randomized to just I will go highlight the result of this trial. I will not go through in detail. So patient randomized to elacestrant, which is the first oral SERD, versus endocrine aromatase inhibitor or fulvestrant, which is injection SERD. 17% of patients had no prior fulvestrant. This is the BFS at 12 months. As we see, BFS at 6 months, it was 34 in all patients versus 20 in the other groups. And also BFS rate at 12 months at 22 in illustrant versus 9.4. If we move to the patient that harboring ESR1 mutation, that we see BFS at 12 months at 29 and versus 8.2. With that also, so it showed higher BFS rate at 6 and 12 months. If we compare that with fulvestrant, we see also superiority of oral steroid over fulvestrant. So that means we need to know more about ESR1 mutation. As we know that patients with fulvestrant, with ESR mutation, they did well. But in this trial that showed patients on illustrant, they did well with more than the fulvestrant. So we need to understand more the ESR1 mutation. Also, this is a new CDK7 inhibitor, which is samuraciclib, first in class oral selective inhibitor in combination with fulvestrant in patients with hormonal positive HER2 negative breast cancer. It was single arm study. And I want to go in detail of this trial till we find the final result of the trial. Actually, it showed overall clinical benefits at 24 weeks by 36%. We know patients with PIK3CA mutation has faced poor prognosis, as we know that patients with PIK3CA mutation has a role in endocrine resistant, and usually patients with that mutation has lower overall survival compared to patients with wild type. And we have two trials that study that mutation or PIK3 inhibitor, which is SOLAR and BILEAF trial. BILEAF trial specifically studied the patient that received a prior CDK4/6 inhibitor and showed improvement in BFS and also overall survival improvement in patients with lung and liver disease. And still we have more and more targeted agent in hormonal positive breast cancer, which is like a selective androgen receptor modulator that is studied in the phase 3 ARTIST trial as third-line metastatic setting, which showed BFS 5.5 months. Also, there is a role of target agent in patients with high tumor mutation burden and HER2 somatic mutation. In patient high tumor mutation burden, that study Nivo plus Nivolumab or pembrolizumab. For patients with HER2 mutation, we have triplet agent, neratinib, fulvestrant, and trastuzumab. And it also the data showed some efficacy of this agent in that group of patients. We know that patient with FGFR amplification has a patient with FGFR1 amplification has resistant or endocrine resistant. And we have several agents in early phase trial that study a FGFR inhibitor in combination with palbociclib and fulvestrant. So selection and sequencing of therapy for hormonal positive HER2 advanced breast cancer. We CDK4/6 and PIK3 inhibitor are effective in patients with visceral and bone dominant disease. Chemotherapy should be sequenced after all available endocrine therapy option, of course, except in patients with life-threatening disease. Sequencing depends on prior endocrine therapy in early stage setting and disease-free survival, and also the presence of biological biomarkers such as PIK3CA. Just I would like to highlight, we know there is no head-to-head comparison between the three CDK4/6 inhibitor. Just I would like to highlight some of the difference between the three CDK4/6 inhibitor. We know that abemaciclib, it's giving us continuous dosing, in contrast to palbo and ribociclib that giving 3 weeks off and 1 week off. And also monitoring of patients will be lab testing in amoeba and palbociclib, but in ribociclib we need to add ECG monitoring in the first 3 cycles. Also that abemaciclib is highly selective for CDK4 more than CDK6, and approximately about 14 times more selective for CDK4 than CDK6. CDK4 is implicated in breast cancer tumorigenesis, but CDK7 is male in stem cell that the neutropenia is lower or lower in such a group with abemaciclib. Also in terms of potency, amoebocycline potent inhibitor for CDK 4 and 6. We see IC50, which represent maximum inhibitory concentration, as we see here in this schedule, comparing CDK4 IC50 and CDK6 IC50, and we can see it compared with other CDK4/6 inhibitor. Also, continuous dosing of amoebocycline that helps in decrease tumor growth and also increase apoptosis and decrease proliferation. Here there is 4 prognostic factor, which is liver mets, patient with progesterone negative, and patient with also primary endocrine resistant and tumor grade. Usually, patient with these 4 factors has lower overall survival and lower PFS. But based on Monarch 2 and Monarch 3 subgroup, we found some activity of amoebocycline or highly active of amoebocycline in such a group of patients. If we see here in the dark blue, that patient with the liver mets has a ratio 0.45. In contrast, the patient with no liver mets has a ratio 0.55. It seems that amoebocycline has really good activity in such a group of patients. This is one of the unique segregation of amoebocycline from other CDK4/6 inhibitor, Monarch 1, that studied amoebocycline as single agent in patients with heavily pretreated with endocrine therapy in later line. Actually showed BFS benefit with 5.9 and overall survival with 22. Based on that, approved amoebocycline approved as single agent in hormonal positive breast cancer. Regarding penetration of amoebocycline in CNS, we know that amoebocycline is highly expressed in CNS, and based on we can see in this trial that include 10 patients that measure concentration of amoebocycline in plasma and CSF. And so based on this data, we can use amoebocycline patient with CNS involvement. Regarding the diarrhea, one of the major side effects of amoebocycline, we know most of patients may lead to discontinuation of treatment because of this side effect. If we see that diarrhea in the first cycle represent by 20% and decrease to about 4% with in the sixth cycle. So monitoring patient or educate the patient in the first 6 cycles is really important to avoid discontinuation of treatment or even reduce the dose of treatment. All we agree that first-line treatment in metastatic breast cancer, hormonal positive, CDK4/6 inhibitor plus aromatase inhibitor or fulvestrant, but there is no current guideline to guide you what's the second line beyond the progression of CDK4/6 inhibitor, and this is what unmet need in advanced metastatic hormonal positive HER2 negative. So with that, I conclude my talk. Thank you.
Thank you very much, Dr. Aisha. Very interesting presentation. Maybe we don't have my questions. So let me ask you, and I do believe some of the people of Lilly like this question, some of them they don't. If you have the 3 options, the 3 drugs available to you, okay, at your disposal, so which patient you think that will be comfortably choosing amoebocycline for, if you want to justify it?
You know, from all the trials, we have that similar hazard ratio for the 3 CDK4/6 inhibitor, and so we can say it's has similar efficacy. But I'm sure that there is some difference in molecular characteristic of the 3 CDK4/6 inhibitor. Usually, I tend to use amoebocycline in patients with visceral mets, just at liver or impending crisis, instead of jumping to chemotherapy. But for regarding palbociclib, I used to palbociclib to patients with bony mets and ribociclib in between, and mainly for pre or perimenopausal patient.
Right. I used to say and to tell the guys when they come and visit me that if I'm going to choose one over the other, especially when it comes to abemaciclib, I would be delighted to use it for patients who were heavily pretreated or who had bone marrow suppression at the neoadjuvant and adjuvant setting, who couldn't tolerate the chemotherapy. I will not actually subject them to a bone marrow suppressive agent. This is one. Two, patient preference is important, and especially with the continuous doses. You know what is the advantage of continuous doses rather than when you talk about biostatistic, yes, compliance. The patient will be used to take the drug daily. So certain patients who are elderly, where they face some problems to reinitiate the cycle of medications, continuous medication will represent a nice option for them, believe it or not. The third one, which you don't like to talk about it, it's not an indication yet. Maybe I'll prefer it for patient with CNS metastasis, especially isolated CNS metastasis or isolated CNS recurrence when the systemic disease is well controlled. Thank you very much, Dr. Aisha. Very nice presentation. Thank you all for attending and for staying so late. Just let me tell you some housekeeping tips. Tomorrow, inshallah, we'll start at 10 a.m. and we hope to find you here. And it will be the final day. And enjoy, I think it's Jeddah season. Yes. Gala dinner, second floor. There is no pool in the second floor. You sit by the pool. Thank you very much. Have a nice day.